Welcome back everyone after the inspiring awards session, and I'm happy and congratulations to all of those who won the awards as well. And we're back to Retina, and I know that everybody has been pretty excited about Retina. The next session is the Retina second session, which is to be chaired by Dr. Ajit Babu Maji sir and Dr. Manoj Khatri sir. Dr. Ajit Babu sir is the consultant Retina services at CFS Hyderabad, and his keen interest in management of retinal disorders has changed a lot of things over time. Thank you, sir. You're known for your meticulous surgeries. Thanks a lot for taking care of our patients, sir. And also, Dr. Manoj Khatri, sir, the founder and managing director at iDocs Hospital, Chennai. So, over to you. I would like to introduce our first speaker for the day, Dr. Mangal Dogra, sir. He'll be talking on pediatric retinal disorders. He is a world-renowned ophthalmologist and currently serving as director of Grewal Eye Institute, Chandigarh, and he's a former professor and chairman of Advanced Eye Care Center at PGI, Chandigarh. Over to you, sir.
Okay, now it's on. I think thank you, Rolika, for nice introduction. At the outset, I would like to thank entire CFS team, especially Dr. Santosh Onawar, Dr. Rashmin here, as well as Dr. Mahipal, and Rolika, of course, she made so much of effort. I think it's a great effort. I have, right from beginning, if Santosh would remember, I would say, hardly anything is done for education when it was small, and how big it has grown. It's a great, absolutely, because some of us, those who taught lifelong, that's what we feel, that this is the greatest service one could do. I've been told to talk on pediatric retinal diseases. It's a huge subject. I'm just going to give you a little overview. I do have some financial disclosure because I do serve as a speaker or as an advisor for them. As far as the pediatric retinal diseases are concerned, it is the major cause of childhood blindness. You would realize that it is totally reverse than what happens in the adults. And here, the major contributors still are retinal dystrophies, a lot of degenerative disorders where a lot of therapies are being tried. Also, there are diseases like congenital retinoschisis, retinopathy of prematurity, Coats disease, retinal detachment, and familial exudative vitreoretinopathy. I just want you to see this slide. This is a long time back. This slide was by Claire Gilbert. In fact, I had borrowed from her. And if you look at it, the retina contributes maximum to the childhood blindness. So that is where the importance lies. As I said, these are the retinal dystrophies which have major contribution as far as this part is concerned. And you know, these are the disorders which all of you know. These are sort of heterogeneous kind of disorders, mostly bilateral symmetrical. And there is usually a progressive photoreceptor atrophy like this 15 years old male child, night blindness, nystagmus, visual acuity only 660. There's a family history, and ERG, there's no wave formation. I'm not going into too much of, there'll be disorders, so many disorders. I'm not going, so treatment for previously incurable such diseases as what I have shown you, the gene therapy. These days, gene banks are being created. Genetic testing is being done because these are specific for the genes. The therapies are being tried and already promising in Leber's congenital amaurosis. So we are looking forward when you are going to be perhaps growing, you'll have a lot of therapies for some of these disorders. So congenital retinoschisis is something which is not seen uncommonly. It is the X-linked, so affects only males. Female carriers, you can't even identify. That's where the problem is. And affected males usually have a poor central vision, and they may, during early stage, sometimes they have good vision also. It's not that, but once they go for first screening, their vision may not be normal. And there is usually splitting of the retina, and the visual acuity somewhere vary between 618 to 660, and the typical is a spoke wheel pattern, and OCT is diagnostic. Something like this. If you see something like this is diagnostic, this spoke wheel pattern. If you see, this is pathognomic. And on OCT, which has come, we used to always diagnose this on spoke wheel pattern earlier before OCT came in. Now you see nice schisis in the retina, and you may have splitting of, as I said, of these layers, and mostly it is the neurosensory retina which is split. So you may have many things that you have inner layers which consist of internal limiting membrane, retinal nerve fiber layers, and may have these kind of oval large defects. And mostly the peripheral schisis most of the time is intratemporal, and most would require observation. You see, they remain mostly they remain stable and may not progress, but even if they progress subsequently, they'll do good for fifth to sixth decade. And but some indications for surgery are there. They may develop rhabdogenous retinal detachment, sometimes vitreous hemorrhage, or a tractional retinal detachment over the macula, or which is encroaching it. Usually it doesn't progress. It may be there. Observe it. Don't go, because surgery could be a problem, or macular pucker, or other things there. And the pre-op retinoschisis with RD is here. I'm going to just show you one case. I remember this child came to me from Delhi. Other eye was count finger close to face. He used to go to school, but with buckle, you see, we could get good results. So that is what is very important to see. And fever, again, another disease which we thought we are not seeing this in this country, is very, very common. You will have this disease so common that you will see even more cases than you see of congenital retinoschisis. This is characterized by the temporal retina, which does not vascularize. It just mimics, it comes in the differential diagnosis of ROP. And you will have new vascularization, retinal exudation. I'll just show you some of those things. Usually bilateral involvement here may not be symmetrical. It is mostly asymmetry is common, not like ROP, which is mostly symmetrical. And most would progress during adolescence. I have had so many of them. They too used to do well, but once they are around puberty, they suddenly worsen. But once they have gone beyond 20 years, they may not progress. That is something you'll find many of them, they'll do fine. So all family members here require screening, and 58% may be asymptomatic. And clinical examination, especially these days, ultra-field fluorescein angiography, which is done with so many cameras which we have, including Optos, that it is very important. So all these diseases, you see, these are peripheral diseases where you have a peripheral avascular retina. ROP, Coates, persistent fetal vasculature, earlier called PHPV, Nuries, incontinentia pigmenti, and toxocara canis. All of them, they would come in the differential diagnosis. You may have some presentation like this. You may have nerving of arcade, peripheral retina is avascular, and you can see there is a leak from the new vessels. And also you may see dragging, nerving of these vessels. So that is what you are seeing. The whole retina gets pulled, and the posterior pole becomes dragged, and macular heterotopia is there, which gets shifted away. So these kind of cases, you need laser treatment to the periphery, and may need some of them anti-VEGF injections or a pars plana vitrectomy at times. And you can see like this, laser has been done, and peripheral retina, so this would stabilize, it won't progress. And this is another side, you can see the other eye. And this kind, you may see sometimes vision suddenly dropping down to count finger from, and here you can see it has started bleeding, and this case definitely requires surgery. And once the surgery is done, you can see you can do very well with pars plana vitrectomy, gas tamponade, and doing laser in the periphery. I'm just going to talk a little more about ROP. This is the subject which has been very passionate to me. I've done a lot of work on that right for the last, it has been 32 years journey for me as far as this disease is concerned. This is a vasoproliferative disorder of premature retina. Why it develops, you know, since it is a premature child, the peripheral retina is not vascularized, you have avascular retina, huge. So that is what happens. And once you have that, this retina is going to develop into either a normal vascularization or ROP. That depends on various things. But in our country, you see, when I was a resident like you, this was seen as retrolental hypoplasia, differential diagnosis of retinoblastoma. Only one page used to be there. These days we have a society for this. There are books for this. So much has happened, and it's so important that this is becoming a leading cause of blindness for our country. And in India, heavier and older infants are developing ROP. This, I'll be just showing you, these figures are mind-boggling. You can go through these publications here, including the editorial written by Dr. Santosh Sonawar here, that India accounts for the most preterm birth in the world, 3.5 million, and 6 lakhs born less than 32 weeks of gestation, and 2 lakhs are at risk of developing ROP, and 20,000 develop sight-threatening. That means they need laser or treatment or injections. And in addition, what we have observed, higher birth weight babies develop ROP. And the most important factors, I think you can read through that and look at it. Low gestation, low birth weight, oxygen, they are always consistent. There are numerous other factors which I'll not even go. What is very important here is, if you can diagnose that treatable stage, 90%, more than 90% will have a favorable outcome. Otherwise, these children are irreversibly blind. Nothing can be done later on. It has a very short window for treatment. I think I'm just going to share this publication. You must have heard about Anand. He is big way into ROP. He was a resident with me. He did this as his thesis long time back. Why it is important? This is what we observed. That those days, 16% of the babies were more than 1750. Everybody said, don't examine anybody because Western guidelines said 1500 grams. So many would have been missed. And look at, they were even bigger than 2 kgs. And 23% of babies were more than 32 weeks of period of gestation. So mostly in Western guidelines, it was 30 weeks or 32 weeks. So how many would have been missed? So with these kind of studies, we changed the guidelines. This is from Government of India, Ministry of Health. These guidelines have come. We changed it to 2 kgs and 30. Remember that everybody below 2 kgs and 34 weeks of period of gestation, they need screening. And when they need 30 days, remember, sacrosanct. Before that must be, wherever it is. If you do this, even if you don't know, please tell that somebody has to screen. It will be the greatest job because you're going to save somebody's eyesight. And who should do? Ophthalmologist who knows about ROP, who knows indirect ophthalmoscopy. All of you, I hope you do know indirect ophthalmoscopy. How many of you have indirect ophthalmoscope? Raise the hands. Oh God, I'm so happy. Nobody during our time had indirect ophthalmoscope. Even the institutions were not having that. So that is what was so that's a great thing. So all of you can do, and of course we are having these now wide field screening cameras, smartphones. All these are coming in. I think documentation, it will take a whole lot of time for me if I delve into all these things. We have to know about pre-plus, plus, zone, stage and clock hours of disease. And this is the way the pre-plus looks like and the plus looks like. These are the standard photographs. And you may even sometime, even when you are just looking at it, you see vessels like that. That means very, very serious diseases behind. And of course, you classify according to, this was the first disease, internationally classified in 1984. And we have a recent revision for this in 2021. And of course, this is, the location is according to zone. Anything which will be posteriorly is going to be more serious. And if it is in the periphery, it's not going to be that serious. They have added recently in 21, this posterior zone 2. That means something happening here is also very serious because so that is what it is. So stage 1 is a demarcation line between vascular and avascular retina. Stage 2 is just a ridge. This line forms a ridge. And stage 3, there is an extraretinal fibrovascular proliferation. You can see these vessels growing up perpendicularly. Then the retina start detaching. You have a localized detachment sparing the fovea 4A. If it involves fovea, then becomes 4B, or total detachment stage 5, where you don't want to see them because that's where the problem is. We have aggressive ROP. In fact, our group has done maximum work on excessive posterior ROP. And I'm not showing you on all my publications here, but what is important is because of our publication only, and especially they never wanted to name this as hybrid. So perhaps this was the name given by me, published way back in. But on these two publications, they had to change, and they had to include all these, and all these pictures, they were contributed by Anand Venekar. He was part of the group, those who did this classification this time. So you can imagine where we have gone from here. And current treatment, of course, is close monitoring of oxygen levels and the neonatal care. If you have a good neonatal care, you are in a good center, you will not even see babies with ROP. If you are in even a peripheral place where they give 100% oxygen, there's a lot of infection, you'll see a lot of them. So peripheral retinal ablation with laser is still a gold standard. Anti-VEGFs, they are coming in a big way, and they are being given, and you require surgery for stage 4 and 5. And these are the indication. Perhaps I'll not go into details of them. You can go through, and they are available everywhere. And the laser has to be delivered properly, confluent manner. If you delivered like that, confluent, more than 90% attain success. You can see the first thing is plus disease disappear. These vessels straighten up. This is taken just after 2 weeks. That is what happens. So that is what is important. And anti-VEGFs, I would say, they are coming in a big way, and they are more acceptable. They are being used as a primary therapy these days for anything in zone 1 or aggressive ROP. And you may need still laser, but there are still a lot of things to be learned about that. Late recurrences, systemic adverse events, we have to remember that. So that's very important. And lens sparing vitrectomy for stage 4 is very, very great procedure. At least I was very fond of it, did a lot of them. And so this is something, one of my cases where it came very late. You can see fold form. You just do a lens sparing vitrectomy, everything goes back. And you can save such a child from going blind. And management of stage 5, you don't want to see them there. I really appreciate everybody. I started doing some stage 5, but ultimately felt that this is something where you have a very poor outcome, you need more time. But I appreciate people, 1/3 reattachment and scene. Some of them may have a functional results, but don't let them go there. That is what I would. So in conclusion for ROP, I would say ROP blindness is preventable in majority of babies. Higher birth weight babies develop severe ROP in India. And screening is most important to identify. So that, remember that, 2 kgs, 34 weeks, and also before 30 days. And it has to be properly screened. Either you do indirect ophthalmoscopy, or you have some kind of a image-based screening. And manage all treatable ROP promptly with laser or anti-VEGF. And that is what is a critical, small window. If you can do that, I think you do 100, 200 phacos. It's okay, that old man lived 5, 10. Here, one child you prevent living 70, 80 years. It will be the greatest satisfaction you get in life. Lens sparing vitrectomy for stage 4 is promising. As I said, this is a great procedure. Vitreous surgery for stage 5 is required, but usually lead to poor outcome. Don't let them go there. So the major problem at this time is our suboptimal neonatal care and delayed screening, which has to be. So I'm just going to briefly talk about the Coase disease, non-familial. In first decade, almost always unilateral, I would say. Very rarely we have seen. And these are mostly the male children which are involved. You have sometime female. Characteristic retinal telangiectasia, subretinal, intraretinal, and cholesterol crystals are very characteristic. You'll see something like this. This was the 6-year-old male child, came to me in 2009. One eye was 6'6", other eye count finger 2 meters. You can see these typical telangiectatic vessels in the periphery and exudation, and also in the posterior pole. That's how the vision is so. So what happened? We did tell that we are going to do for you sort of a laser treatment. Parents were not convinced. They wanted good vision. How to give good vision? There was a scar here. So they waited. So what happened? Look at it, at this, what was happening here. It has come ultimately to this place, and not only this place, it ultimately came all the way. So if you treat, it would have been much better outcome. But still, I think this child was lucky. We gave that time anti-VEGF Avastin, followed by laser to the periphery. Somehow, the whole exudation disappeared. So I think you have to definitely offer treatment to such babies. I'm just going to talk about pediatric retinal detachment. This is another area which is so different from the adult detachment, because here the anatomic and the functional outcome could be quite different. Because the reason is, most of the time, you see, we find that they don't even know that detachment has happened. If one eye is detached, he may not know, because it's his child. And so we have to explain, parents' expectation is so high these days. They have one child or two children. So they want perfect results. No, you have to make them understand. And that is where what was talked in the morning, that communication and consent is very important. And you will, if you are doing in infants, especially ROP, you need really experienced anesthesiologist. And UA, sometimes you can't bring for UA, don't take any decision, look at everything and bring back again after counseling and amblyopia as it is a concern. So scleral buckling, very commonly performed. At least I performed maximum number of scleral buckle for most of the detachments wherever possible. And lens sparing vitrectomy, I have already shown you the results, and lensectomy vitrectomy for complicated cases. So most recommended in retinal detachment in children, the problem is vitreous is so adherent, you can't remove it. So if you can buckle it, this is the best thing. Like this, trauma in a child here, you can see 11-year-old, fairly large, giant ear, you can buckle it, it will do well. And that is what happened here. I'm just going to show you one extreme case. This case, I still remember, he was a hostler coming somewhere from a fancy school in Dehradun, didn't notice anything, and RD with PVR. So everybody is telling me, my whole team, it is vitrectomy, sir, nothing. So I was seeing the break. So I said, I'm going to buckle. I did buckle. Can you see? Even that subretinal band has gone to the periphery. So that is what buckle is so important. Even if you have membranes, you have contracted retina, if you are seeing break toward the periphery, buckle it. You will get excellent results. That is very important. And lens sparing vitrectomy, I have already said, I have shown you that example of a 4B ROP in vitreous hemorrhage, endophthalmitis, posterior retinal breaks, even some cases of fever. I have shown you this already. But lensectomy, vitrectomy, you see a lot of complex retinal detachment in children. And we see ROP stage 5, which is again required lensectomy, vitrectomy. Many of the cases of fever, which I have shown you, RD with coloboma, which is very common, and persistent fetal vasculature, PHVV, which I have said, and RD with Irwan. I think I'm just going to show you probably two examples. This child, I can't forget, this was brought to me quite a few years back, 9 years old, brought by some people. Other eye was thicical, one eye was just PL. PR was inaccurate. And it was like, since the child was totally blind from a very poor family, it was like this. Closed funnel, it was like fibrotic, totally. We didn't know that. But anyway, I took this challenge of doing the surgery. And ultimately, can you see here how it was attached? Also, the whole macula is dragged down. And once the oil is removed, still we could get vision, which was good for the child as far as his rehabilitation was concerned. So that is what. This is another girl I wanted to share with you, which is a 14-year-old girl. Again, 2 years, no system, hand movements. And you can see here what has happened. You have this kind of a tractional retinal detachment with a proliferation behind and vitreous hemorrhage. And other eye, look how angry looking it is. It is a tractional retinal detachment again, and the whole retina is up. These vessels are occluded. And how did we reach the diagnosis? I think this was sent to me from Lucknow, and there was an angiogram done by Lucknow earlier. This is where it clinches the diagnosis. You have to look at it very carefully. You see these arterial beautiful knots. Are you seeing them all over? And peripheral avascular retina. And these nice arterial knots are seen in Irwan. So what is Irwan? I think you're going to, some of you must not have sort of heard about it, but you're going to see many cases there. It's not uncommon in our country. And this is the idiopathic retinal vasculitis, aneurysm, and neuroretinitis. So this girl received intravitreal injection in both eyes, pars plana vitrectomy with endolaser was done. And this is what was happening to the right and left eye. That is the way we got the results. But what I want to tell you is, look at how lucky she was. She regained almost like 6/9 vision in one of the eye. Other eye was something like 660. And this is what I want to show you many years later. Subsequently, she goes to the college, she's grown up, and she's done very well, and because one eye is doing very well for us. But I don't know how she's seeing 6/9. This is avascular here, and this is not uncommon in these Irwan cases. We see some kind of macula getting remodeled there or something, but she's 6/9 in this eye. The other eye, she sees 660, and this also somewhat looks similar, but maybe it is more involved here. So, well, I can go on and on, friends, but I would like to just conclude my talk here that pediatric retinal diseases are a major cause of childhood blindness, the number one cause. And you will have to learn more and more about these cases, and especially don't forget about the emerging problem of ROP. ROP, during your time, only in few years' time, it will be number one cause of childhood blindness. It is a number one cause of in many South American countries. So it will become so here. These diseases may pose major diagnostic and management challenges, as you have seen some examples, and half of the cases may have preventable or treatable cause. So I think that is what is important. If you can prevent them and if you can treat them timely, so that is where your role is going to be. And thank you very much for your attention.
Thank you, Dogra sir, for an inspiring talk as always. Before he leaves us, any questions from the audience? He's teacher of teachers for all of us here, including me.
Thank you.
Any questions for Dogra sir? Okay, sir, just to simplify, all these are budding ophthalmologists here, and we are majorly concerned about a disease called ROP because screening is the one which all of us should be doing it. Whether you treat or don't treat doesn't matter much. Any tips you will like to give these residents on how to start screening and the way, and also which classification to follow for the exams as well as for the practical purposes?
I think, thank you, Manoj. I already asked this question that how many of you do indirect ophthalmoscopy or carry.
Yes.
So I think they are already on the line.
Yes.
So that is why I especially asked for raise of hands, and perhaps almost 80 to 90% raised their hands, which is amazing to me. It was not happening even earlier. Probably Santosh would remember in earlier days when I would tell that very few had. So if more and more people, if they learn indirect ophthalmoscopy and you know about ROP, I think don't hesitate, go in your area, and you will not escape. If you are going towards retina, there is no way that you can escape from ROP screening now. Because SNCUs in the district hospitals, there are already 700 something all over India. They want to decrease the infant mortality down. So what to talk of NICUs and others? And for any pediatrician, what is the biggest prestige? For us, big prestige is to have phaco, LASIK or something that. For them is to have a NICU. That is the biggest prestige, that they open the NICU, if they have opened the NICU. So you can imagine how many, and that's how the numbers are going up. So you must learn, and it's not difficult. I can tell you, you may not need much for learning. Now there are at various places people, those who are doing screening, and we are very happy. You know, when we started in this country, we were two people in the country. One in north, that was me, and one in south, that was Lingam Gopal. This is 91. So can you imagine that was the situation? But very few were surviving those days. We started seeing ROP, and now it is an epidemic. So what classification? It is standard classification. You follow this international classification, which is, I said, the stages. And treatable stage, I have not gone into that detail. You have to look at all those treatment guidelines. They are very clearly given. And if you have a confusion, send it beforehand. Send it to another person who knows about it. So that is the way. But don't forget, less than 2 kgs, 34 weeks before gestation, must be screened. If you are not doing, send to somebody. Or emphasize upon neonatologists. And also improve their neonatal care. Tell them they should not be giving this 100% oxygen business. That is what is creating that aggressive ROP, or what we said, change the classification also. And also, remember, it has to be before 30 days, 3 to 4 weeks after birth. Must. Later on, it might already go into stage 4, 5, and you can't do much there. Otherwise, if you detect early, more than 90% will have favorable outcome. So that is what again. Yes, No, no. You have to be very gentle. You see, those who are trained with me, they realize it that you don't need two things all the time: speculum and depressor. No, you only need in very rare situation where you are not able to examine. That is the way the people were trained for entire country with me. Most of the time, they are not. These include people like big ones, like Dr. Subhadra. You will not see her putting that speculum Anand for every case. No. So they, all these people, and you can do the same because child is there. You can just maneuver the head and see easily till that zone 3. And in anything in zone 3 will not be serious anyway. And even plus disease is most important. If you have diagnosed that, cake is taken. That is what it is. Thank you.
Thank you so very much, sir. Any other doubts for Dogra, sir? We want it to be a two-way communication. You can be open and upfront in asking any doubt, however simple it is. So the classification to be followed is ICROP, International Classification of ROP, and zone-wise and staging-wise you need to be very sure, and then you screen as sir said. Thank you, sir, once again for your wonderful talk. We move on to the next talk. This will be by Dr. Nikhil Paul, sorry. He is principal consultant at Max Healthcare Saket and also Panchshil Park, New Delhi. Has an experience of over more than 20 years. Is a graduate from RP Center and also a Retina Fellowship from Wisconsin Madison, USA. Has more than 50 index publications to his credit and has been invited speaker at various scientific forums. Over to Dr. Nikhil for his talk on diabetic macular edema.
Thank you, Dr. Manoj. That was a very kind introduction. And first of all, it's a privilege for me to present at this iFocus program of Center for Sight. And I would like to thank Dr. Hanover, Dr. Mahipal, and the whole CFS team for giving me this opportunity. And since it's supposed to be a postgraduate education program, and I've been asked to speak on a very highly specialized topic, I'll try to keep it as simple as possible. I'll be speaking on brolucizumab, the real-world evidence in Indian diabetic macular edema patients. So as we all are aware that diabetes is increasing day by day, and India is becoming the diabetes capital of the world. And there are almost 463 million people living with diabetes, and out of that, 27% have some or the other diabetic retinopathy. And the most common causes for blindness in these patients are either diabetic macular edema, which may be either center involving or non-center involving, or proliferative diabetic retinopathy. My talk will be pertaining to diabetic macular edema, center involving. And there's been a 51% global increase in the diabetic, and especially by 2045, it's going to become a pandemic. So the treatment burden in diabetic macular edema is that there are various injections which are right now available, maybe aflibercept, bevacizumab, or ranibizumab. So aflibercept is Eylea, bevacizumab is Avastin, ranibizumab is Eccentrix in India, or biosimilars. The problem with them is that almost more than 50% of them require monthly injections till 2 years. And if you can see this table, in aflibercept, bevacizumab, ranibizumab group, the first year they required 9 injections, and the second year the total number of injections required was 14. So there's almost a 67% dropout of the patients. And because of this dropout, the vast majority of the patients receive a suboptimal treatment and don't respond as well as they should. So Indian retinologist perspective has been on diabetic macular edema that 90% of them consider fluid as an important disease activity parameter. 41% of the patients have inadequate fluid resolution despite optimal usage of these anti-VEGFs. And because of that, 92% of the retinologists consider that injection frequency has been the key factor for the non-compliance. And if we are able to reduce the treatment burden, and in this, we'll be able to somehow meet the unmet need in diabetic macular edema. So the various studies performed from brolucizumab, it was initially launched in 2019, and in India it was launched in October 2020. First, the approval was received for neovascular AMD, and with the Hawke-Harrier studies showing good evidence, and in Indian studies also initially showing good evidence, gradually it started to be adapting even for diabetic macular edema. And there, Dr. Vasumati will be presenting on the Kite and Kestrel study pertaining to diabetic macular edema. So I'll be just focusing on the real-world evidence in Indian experience. And this study has been done by Dr. Devulal Chakravarti at Dishai Hospital in Calcutta. It was a retrospective, consecutive, interventional, single-center study. All patients were treated with intravitreal brodusumab 6 milligrams between November 2020 and May 2021. There were 13 eyes of 13 patients of recalcitrant diabetic macular edema who had been previously treated with either anti-VEGFs or steroids, and they didn't respond as well. So the demographic details were non-specific, and one can see that previously they had been received either anti-VEGF injections or steroids. And the mean number of previous injections which had been given were 15. So the study design was that it was a retrospective study of 13 patients with a monthly follow-up. And the first brodusumab injection was given in 13 patients, and the second injection was given at least at 16 weeks. Only one patient received injection at the 12-week interval, and they were followed up monthly. 9 eyes completed 12-week follow-up after the second injection, and 2 eyes received repeat injection at week 12. So the mean number of injections given in this study were 2.07, and during the mean follow-up of 24.6. The studies showed that there was a significant visual acuity improvement. All 13 eyes completed the monthly follow-up till 12 weeks, and all of them showed significant visual improvement at week 12. There was a significant reduction in the central subfield thickness on the OCT, and the higher proportion of patients on 16 weeks regimen with brodusumab, 91.6% could achieve a treatment-free interval. None of the eyes reported any signs of inflammation, vasculitis, or any other ocular systemic adverse events. I'd like to just point out here that this brodusumab injection initially in the Hawk and Harrier study showed almost 4% incidence of intraocular inflammation, including severe occlusive vasculitis in few patients. But few studies subsequently, like the IRIS study, showed a frequency around 2.4%. And in India, almost more than 20,000 injections have been given for neovascular AMD and lately diabetic macular edema. And the incidence of these intraocular inflammation reported has been less than 1%. So the confidence of all our ophthalmologists has been growing. So to summarize, the real-world outcomes of brodusumab in recalcitrant diabetic macular edema patients has shown significant visual improvement compared to baseline, significant reduction in central subfield thickness, 91.6% patients could achieve 16 weeks treatment-free interval, and none of the patients in this study reported any ocular systemic adverse events. There was another case series published by the same group, Dishai group, in which the case one, he was a 37-year-old male diabetic for 12 years with both eyes moderate NPDR with left eye diabetic macular edema. He had previously received 11 ranibizumab injections over 6 years, last being given in August 2020. Post the 11th dose of ranibizumab, there was minimal response noted, probably tolerance to the injection. So the patient was switched over to brodusumab in October 2020. And as you can see on the serial OCTs, his OCT picture started improving, the cystoid pockets started responding, and there was complete resolution of the subretinal fluid, serous retinal fluid, and significant intraretinal fluid reduction at week 12, including a notable central macular thickness reduction at week 12. And this was corroborated by improvement in the BCVA at 16 weeks. Case 2 was a 49-year-old male, again a diabetic for 15 years, with both eyes severe NPDR, with right eye recalcitrant DME. He had received 13 ranibizumab and 2 dexamethasone implants during the 7 years of follow-up. And there was unresolved retinal fluid with the previous injections, as can be seen in the OCT. And he was switched to brodusumab. And as you can see in these pictures, beautifully depicted, there is a complete fluid resolution with significant visual acuity gain. The third case, again, was an NPDR patient with recalcitrant diabetic macular edema in the right eye. And he has received 20 ranibizumab, 3 bevacizumab, and 2 aflibercept injections before switching over to brodusumab. And as you can see here, there was almost complete resolution of the SRF and the IRF. So to summarize, the early real-world case series of brodusumab has demonstrated significant fluid reduction, both intraretinal and serous retinal, and there was notable visual acuity improvement. And the injection interval which has been kept in these studies was 12 to 16 weeks. I also started using brodusumab in late 2020. This was my first case in which I used it. He was a moderate NPDR patient, and there were cystoid pockets on the OCT. And as you can see in the picture that he responded with 1 injection. And I've again repeated the injection at 16 weeks. I'm not following a classical loading dose pattern and more of a PRN pattern. The case 2, as you can see in the date, he come to me in September 2022 with a bad OCT picture, and I gave him 1 injection, and all his fluid has gone, and especially the hyperreflective dots have also disappeared. This is case 3. This was during COVID times in 2020, where he came to me as a treatment-naive patient, and he couldn't come for follow-up, didn't want to. I explained him all the risks and benefits of the injection, and he agreed for brolucizumab because he didn't want to come for follow-up. And in spite of dissuading him, he agreed for it, and he came to me almost after a year of the first injection with no fluid recurrence. In the case 4, this patient was a recalcitrant diabetic macular edema patient. I had already given him 5 ranibizumab injections and 2 aflibercept injections, but he had shown no response. Ozurdex was not an option because he was a glaucoma patient. So I agreed for brolucizumab. I've injected him 2 injections at a gap of 12 weeks, but there's been no change in morphology in him. And this patient, just a month back, he came with an intraretinal cyst, and I injected, as a treatment-naive patient, I injected brolucizumab, and he came to me a few days before with a smile on his face, and the OCT picture showed almost complete resolution in the cyst. So the take-home message which I want to give here is that diabetic macular edema is a difficult disease to treat. There are many treatment options available, but there's no consensus on what treatment is the best, what protocol is the best, and we are still learning with each other. Thank you.
Thank you, Dr. Nikhil, for a wonderful talk. Any questions to Dr. Nikhil? I think there are no many questions. Thank you so very much.
Thanks.
But the important take-home message is at this stage, we should be aware what are the newer molecules, especially in the anti-VEGF side, because there is lot much of research and lot much of molecules are coming into clinical usage. You should also be well versed with the pharmacokinetics, both for the theory and as well as for the practical question. And also what are the recent trials which are happening, especially on the diabetic macular edema front, which is very, very important to know. At least the gist of it, what is the aim of the trial and what is the end point, and so on. So with this, we move on to another prolific speaker amongst with us, Dr. Vasumati Vedantam. She will be again talking to us on a topic related to diabetic macular edema. But before she starts, let me give her a brief introduction to you. She is a consultant vitreoretinal surgeon and medical director of Radhatri Netralaya, Chennai. She has a fellowship from L.V. Prasad Eye Institute, Hyderabad, in vitreoretina, and also fellowship in pediatric retina, ROP and electrophysiology from Moorfields Eye Hospital, London. Has been published very widely in all the major peer-reviewed journals, and she has many achievements of awards for her to her credit. To name a few, she was named as Women Entrepreneur Welfare Association Best Social Service Award, Ophthalmology Oration and Gold Medal by IMA, Deccan Dhanavantri Award by Sukar Medical Research Foundation, and recently Sherpa Awards, which has been also conferred from Nepal to her. We welcome Dr. Vasumati here for a talk.
Thank you, Dr. Manoj, for the kind introduction. And thank you, CFC, Dr. Honavar, Dr. Mahipal Sachdev, for the kind invitation. And it's my first time in iFocus, and it's a great feeling. And thank you, Novartis, for facilitating this talk. So I would be talking on the new era in the management of diabetic macular edema, and I would be talking about a drug called brolucizumab, or Peginax as the trade name is known. And we have a whole lot of anti-VEGF agents, but brolucizumab is a power-packed small one. Like it has the lowest molecular weight, as you can see, when compared to the other anti-VEGF agents, but it delivers the highest equivalent active units. You know, the concentrated molar dose is the highest amongst all the anti-VEGF agents, which probably accounts for its superior efficacy, if I may say. So I would just briefly touch upon Kestrel and Kite, which are pivotal 52-week randomized controlled trials, and the phase 3 results are out. It is a non-inferiority trial of brolucizumab and comparing it with aflibercept, 2 doses of brolucizumab compared with aflibercept for the treatment of patients with visual impairment due to diabetic macular edema. And the overview, Kestrel and Kite were more or less similar, but only thing is Kite had a slighter advantage. It was in 23 countries when compared to Kestrel, 13 countries. And the study design is all patients received 5 loading doses, be it brolucizumab or aflibercept. Only thing is in brolucizumab, the loading doses were 6 weeks apart, whereas in aflibercept, it was 1 month apart. And after the 5 loading doses, all the brolucizumab patients received injections every 12 weeks, that is every 3 months. And if there was disease activity, as mentioned by DA, the interval was shortened to 8 weeks, that is 2 months. Whereas all aflibercept patients, after the 5 loading doses, monthly loading doses, had an injection every 2 months. So in the primary endpoint, we can see that brolucizumab 6 milligrams was non-inferior to aflibercept. This is the brolucizumab 6 milligram. You can see that both in Kestrel and Kite, the visual acuity results were absolutely non-inferior to aflibercept, and also a robust improvement in the central subfield foveal thickness from the baseline in both Kestrel and Kite with brolucizumab 6 milligram, and a slightly greater reduction, superior reduction of the central subfield thickness with brolucizumab 6 milligram when compared to aflibercept in Kite. And when we remember that Kite was in 23 countries, probably these results can be extrapolated across all races. And fewer patients on brolucizumab, this blue is a brolucizumab, had intraretinal or subretinal fluid at week 32, as you can see. And also the comparable improvement in the diabetic retinopathy severity scores from the baseline with between both brolucizumab 6 milligram and aflibercept in both Kestrel and Kite. So quickly, I will talk about my experience with brolucizumab in diabetic macular edema. I'll be talking about 8 patients. 1 is unilateral and all 7 are bilateral. And number of eyes 15. And the visual acuity at the baseline was 624, and at 1 month it was 612. So these are the graphs. And this is my first case, right eye diabetic macular edema, proliferative diabetic retinopathy in a 40-year-old type 1 diabetic patient. Left eye, he had PDR, vitreous hemorrhage, and TRD, and underwent vitrectomy. And so I'm going to talk only about the right eye. Right eye, best corrected visual acuity at presentation was 618 in 18. And he received brolucizumab injection on 18th of March 2022. And at 2 months, visual acuity was 618 n 12, slight improvement in the near visual acuity. And underwent a second injection. And after that, with an injection interval of 5 months and at 11 months follow-up, his visual acuity was 612 n 8. I'll be showing you his pictures. This is a right eye pre-injection fundus photograph. You can see the neovascularization on the disc and the disc edema and the clinically significant macular edema. And this is a 2 months follow-up. You can see that the disc hyperemia and the NVDs and the edema has sort of come down. And this is the fundus photograph at the second injection visit. And this is at 11 months follow-up. We have seen him even recently, and he is doing extremely well with just 2 injections. To quickly run you through the structural B scans of the OCT of this patient. This is a pre-injection best corrected visual acuity 618 in 18 with some parafoveal cystoid macular edema. And at 2 months follow-up, he did quite well with 618 n 12 vision. But he didn't come for follow-up and came back 5 months later. And you can see that the edema has come back. And then we gave him another injection. And this is a 2 months follow-up, 612 n 8, a very beautiful looking retina there. And this is the change analysis of the central subfield thickness. As postgraduates, I encourage all of you to use a lot of OCT. In fact, OCT has become an integral part of all of our armamentarium, even of a general ophthalmologist. Even if you don't do retina, you cannot afford not to have an OCT machine. And it's important that there are several biomarkers in diabetic macular edema which have come out recently, but still the most important biomarker from time immemorial has been the central subfoveal thickness change analysis. So if you see that, you can beautifully understand, and you can even tell the patient, it increases the compliance of the patient. You can see that all these figures are in minus, which means that the edema is continuously reducing. It's on the wane. And when we last saw him this month, his right eye OCT, the vision was 612 n 12. He had developed a cataract, but 11 months down the lane, still there is no fluid, as you can see. So we have advised cataract surgery following a dexamethasone implant. This is my second case. From now on, all the cases are going to be bilateral. 55-year-old female patient, type 2 diabetic. Right eye and the left eye, right eye visual acuity, pre-injection visual acuity was 6 parts and N6, left eye 636, N36. She received the first brolucizumab injection on 12th August 2021, and at 2 months follow-up, her visual acuity was 6.6 N6 in the right eye, and left eye it had improved to 6.18 and N18. And then the second injection of brolucizumab after 4 months, and at 2 months follow-up, the visual acuity in the right eye was 6.6 N6 and left eye 6.18 N18. So these are the pictures. Right eye, this is a pre-injection picture and 2 months follow-up, and this is a second injection visit, and then the 2 months follow-up after the second injection. We haven't seen her after that, but apparently she's quite comfortable. That's what she told us on a telephonic call. So this is a pre-injection picture, structural B scan of the OCT, and you can see that this is 6 parts and N6 with some sort of an cystoid spaces in the outer retina, and this is 2 months follow-up. It had nicely flattened out, no fluid now, 6 N6, and came back 4 months later with edema both in the inner and outer retinal areas, and again after the second injection doing very well with 6 N6. And left eye, these are her pre-injection, 2 months follow-up, the second injection visit, and the 2 months follow-up fundus photograph. And this is the pre-injection picture of the left eye. You can see there's a huge foveal cyst here, and at 2 months follow-up, visual acuity improved to 6.18 and 18, and you can see the dramatic resolution of the foveal cyst here. And this is the second injection. She again came back with a foveal cyst 4 months later, and nicely flattened out again 2 months later. So this is a 2 months follow-up, and you can see the right eye is 6.6 N6 and the left eye is 6.18 N18, and she was seen 8 months later. Both eyes were stable, and this actually I have found time and again. I'm not showing the other cases, but 2 injections within 6 months stabilizes the scenario in most of the diabetic macular edema, especially if they are treatment naive. And case 3, it's a case of bilateral DME, 66-year-old female patient, type 2 diabetic. Pre-injection visit, right eye 624 N36, 2 months follow-up improved to 624 N24, marginal improvement. And after 2 months, she had a combination treatment of brolucizumab and dexamethasone implant, and best corrected visual acuity was 6.18 N18 at last follow-up. And right eye 6.6 N8 to 6.6 N6 after 2 months follow-up. And these are her left eye pictures. You can see the exudates here, the pre-injection. And after 2 months follow-up, you can see that the exudates have started crumbling now. So this is the 2 months follow-up picture. And these are OCTs done from another center. She was referred from another center. You can see that this is the pre-injection B scan, structural B scan of the OCT, and this is a cyst 6.6 N8. And this is a 2 months follow-up. She's doing extremely well with 6.6 N6 vision. And the right eye, this is the pre-injection visit. Again, she had subretinal fluid as well as foveal cyst. Again, these are scans from another center. And you can see the whole lot of exudates. And this is at 1 month. Her vision had improved. So out of interest, I repeated the B scan of the OCT picture. And you can see that the cyst and has dramatically reduced, and so has the subretinal fluid. And this is the 2 months picture. The edema has come back, and the outer retinal cystoid spaces are also back. In fact, in my limited experience of brolucizumab and DME, the outer retinal cystoid spaces are a little more resistant to treatment when compared to the inner retinal cystoid spaces. The inner retinal cystoid spaces go off very well, and she was advised a combination treatment of brolucizumab and dexamethasone implant with a 3-week interval between the 2 injections. At follow-up visits, she was 6.18 and 18, and she refused further interventions. And these are her pictures. You can see that there's so much of minus here. As postgraduates, please understand that the change analysis, if it's minus, that means the edema is reducing, and if it is plus, that means the edema is on the rise. This case 4 is a case of bilateral diabetic macular edema, a 60-year-old female patient, type 2 diabetic. Right eye 612 N12, and after brolucizumab, it was 636 N36. She developed a cataract, and she was advised cataract surgery. Left eye, pre-injection visit, it was 624 N24, and at 2 months follow-up, 618 N18. So this is a pre-injection picture of the left eye, and this is at 2 months follow-up. The OCT will tell you a very good picture of what's happening. And you can see that she has inner and outer retinal cystoid spaces, a hell lot of subretinal fluid. And you can see that this is at 2 months. You can see that this proteinaceous fluid, there's some moderate reflective material here that has disappeared, but the foveal cyst is still intact. But the subretinal fluid is gone, and the inner and outer retinal cystoid spaces have also very much reduced, which accounts which probably accounts for the improvement in the best corrected visual acuity. This is the right eye, the pre-injection visit 612 and 12, and you can see the subretinal fluid and the cystoid macular edema. And these are her FFAs. She has severe NPDR. And after 2 months, the cataract increased in the right eye, but the subretinal fluid had reduced well, so had the cystoid spaces, but they are still persistent. So I've advised her cataract surgery after dexamethasone implant. And this is the fifth case, a case of bilateral diabetic macular edema in a 70-year-old female patient, type 2 diabetic, hypertensive, borderline nephropathy. These are a veritable cocktail of systemic disorders, and usually they go hand in hand in accelerating the malignant nature of the diabetic retinopathy in a patient. And if you see the right eye, left eye, the visual acuity was 660 N36, and 2 months the visual acuity had improved to 618 N18, which is a big thing for such patients. And you see the right eye, this is the picture, it's so much of hard exudates, and this is the 2 months follow-up. And the OCT shows you that the cystoid spaces have definitely started reducing at 2 months. And this is a left eye picture, 636 N36, lot of exudates even at the foveola. And this is a 2 months follow-up. And you can see that these are the OCT pictures which show so much of hard exudates quite close to the fovea. And with a single injection, you can see that they have sort of crumbling down, and there's a very good reduction in the hard exudates with a single injection. And case number 6, 55-year-old male patient, type 2 diabetic, hypertensive, cardiac patient, hyperlipidemia, everything. Right eye, he was post 1 injection of aflibercept. Left eye, he had undergone macular hole surgery with me, and then he had developed diabetic macular edema. So he has already undergone 4 aflibercept, 2 ozurdex, and 1 ranibizumab innovator. So but he was a voracious reader, and he could detect a recent onset of metamorphopsia. So he came to me, and after careful consideration and explanation of the risks and benefits, we gave brolucizumab injection. And because he wanted things to become all right with the limited number of injections and limited interventions. And at 2 months follow-up, it's 66 N6. These are the pre-injection pictures of the right eye. You can make out the cystoid space here, and this is a 2 months follow-up, an absolutely dry retina. And left eye, this is a pre-injection picture and a 2 months follow-up. And this is the whole eye which had undergone the macular hole surgery. So this one, he had this recent onset of the cystoid spaces and metamorphopsia. So, and a 2 months follow-up, he had sort of beautifully recovered. And this is a picture 1 year later. After that single injection of brolucizumab, he's still stable, 66 N6, and very happy. So one of my last cases now. Last case, bilateral diabetic macular edema and PDR, 45-year-old female patient, type 2 diabetic. Right eye and left eye, 6/9 N8 vision. 2 months follow-up, 6/6 N6, it had improved. And left eye alone, she underwent the second injection and a third injection. I'll quickly run you through both eyes PDR on FFA, proliferative diabetic retinopathy. And these are the pre-injection pictures of the right eye, and this is at 2 months follow-up. And the OCT also shows the disappearance and reduction in the cystoid spaces at 2 months. And this is a left eye, was slightly resistant to treatment, pre-injection, and this is at 2 months follow-up, and you can see the PRP marks also here. And left eye, inner retinal cystoid spaces had sort of nicely come down. As you can see here, the inner retinal cystoid spaces are coming down. The outer retinal cystoid spaces are still stubborn and persisting, but her visual acuity continued to improve, and so did her central subfield thickness. My last case, a case of bilateral diabetic macular edema, severe NPDR. In fact, I was the one who detected that he was a diabetic because he came to me with defective vision, undetected diabetic. And this was his clinical picture, sent him back to the diabetologist, and we detected the diabetes. And pre-injection right eye visual acuity, 6/12 N12. And you can see the CME here. And 1 day post-injection, he came back very happy. So out of interest, I repeated the OCT. This is just 1 day post-injection, 6/9 parts and N8. And you can see the dramatic reduction in the edema in the OCT. This was the pre-injection pictures, and these are the post-injection pictures, 1 day post-injection. And this is a retinal map also, almost 101 micron reduction in the central subfield thickness in just 1 day. And this is pre-injection picture with subretinal fluid and CME. And this is 1 day picture. Again, his vision had improved, and you can see the subretinal fluid has dried up in a day. and CME has also come down pretty well. And again, a comparative pre and the 1 day post-injection pictures. So this is a retinal map also, which shows a similar story. And recently, he came back and we've started doing PRP also, and he's still maintaining well. So quickly, my learnings, I have a small number of cases, I agree, but brolucizumab definitely lasts longer when compared to other anti-VEGFs. No need of monthly loading doses. I never use monthly loading doses with brolucizumab. I use monthly loading doses with other anti-VEGF agents. 2 injections within 6 months maintains stability in a large proportion of cases, especially if systemic parameters are also well controlled. Brilliant subretinal fluid drying effect, a good reduction in hard exudates. And regarding the intraretinal fluid, the parafoveal inner retinal cystoid edema shows a very good response, whereas the foveal cyst and the outer retinal cystoid edema show a moderate response. And a very good wow effect, immediate improvement in brightness and vision even within a week of injection. So thank you very much for your patient hearing.
Thank you so very much, Vasumati ma'am, for a wonderful talk. Any questions for Dr. Vasumati, please?
Yeah.
So I think there are, yes, please.
Yes. That's what I. In fact, all the I understood your doubt. All the major randomized control trials, not just protocol, every trial talks about loading doses of anti-VEGF agents, not only for DME but also for AMD. Yeah. So, but in clinical practice, it's just not practical for us to suggest monthly loading doses for. We do suggest, but it's very impractical for us to follow that because our patients don't want us to give them so many injections. We all of us want to do loading doses and treat and extend regimen, which is the scientific way of treating such patients. But patients want only PRN most of the time, so we end up doing PRN most of the time. But with all other anti-VEGF agents, I have found very good results with monthly loading doses because if you treat aggressively, they do very well. But with brolucizumab, probably because of its longer duration of action as well as its superior fluid drying effect, I have not found the need for even advising loading doses. Okay, thanks.
I think there are no more questions. So we move on to the next talk will be by Dr. Ajit Babu Majji. He's again, he doesn't need any introduction to all of us here. He is teacher of teachers, fortunate to be one of his resident in his earlier days. He was former head of department of Retina at LV Prasad Eye Institute, Hyderabad, and now heading the department of Center for Sight at Hyderabad. He will be talking to us on a very relevant topic, diabetic retinopathy, basics of diabetic retinopathy, right at the undergraduate level and at postgraduate level and beyond, how to manage diabetic retinopathy on an overall scenario. Over to you, sir.
Thank you, Manoj, and good afternoon to everyone. And I thank Santosh and Rolik. Mahipal, he's not here, though I thank Mahipal and whole CFS team for giving this opportunity. And you have listened to 2 talks on diabetes, so it's an epidemic. See, there are so many diabetic patients, there are so many diabetic presenters are there. So they primarily concentrate on the injection. Don't think that management of diabetic retinopathy is only injections, okay? So if you see, the epidemic is very much on, and we are in India having a lot of diabetic patients, and it is not the retina specialists that need to manage the diabetic retinopathy. Rather, every ophthalmologist shall be able to manage diabetic retinopathy. In India, the prevalence is very much high. And if you take the diabetics, at least 1/3 of them will be having diabetic retinopathy some stage. So it is very, very essential for all the patients of diabetes to go to the ophthalmologist and have a screening. This is very, very primary importance. So prevalence is 35%, one third, let us say. Then if you see the vision threatening diabetic retinopathy, that is either proliferative diabetic retinopathy or diabetic macular edema, is almost up to the tune of 11%, which is very, very significant number. So you should not neglect any diabetic you know or any of your relatives who are having diabetes, get them screened. Why it is important to India? Because in developing country, if you see the age of onset, it is almost 65 plus age, the diabetic retinopathy's more severe forms happen. However, in India, it is what age group? It is almost 42. That slide is not coming. Slide is going out of this.
Slide is getting cut. Audio visual. Can you just correct, please?
Actually, it is 45 to 60 years. Yes, now it is all right. Okay. So the working group is getting affected. So one diabetic, if he has some blindness because of diabetes, the family earning mainly goes down. So it's very, very important for us to screen the diabetic retinopathy. And various studies have shown the prevalence of diabetes mellitus in the population. It's almost, if you take urban population, it is about 10%. In rural population, it's almost 7 to 8%. So different studies, everyone proved that diabetes is very common. And the prevalence of diabetic retinopathy among diabetics, I already given you the percentage. This is very, very old studies which shown lower percentage. And what are the risk factors? You should always understand that certain factors need to be controlled. Out of that, the DCCT trial has clearly shown that HbA1c percent, that need to be controlled. And if it is controlled, almost like 45% of reduction of diabetic macular edema happens, which is very essential. There is another modifiable risk factor is hypertension. Hypertension again, 35% risk reduction. Someone may ask you how much risk reduction that can happen with control of diabetes, good control, and hypertension. Other risk factor that is very, very important is the hyperlipidemia, which again contribute for reduction of 30% if good control of lipid profile is maintained. Obesity, though not given a specific percentage, it increases the risk of onset of diabetes and the complications as well. So this is cardiac. What is the most common cardiac lesion that happens with diabetics? Can anyone answer? You say diabetes, retinopathy is I, and we will read. Diabetes we will not read. This is what, no? Answer? Atherosclerosis. Yes, there can be a premature atherosclerosis that can happen, but I asked the cardiac lesion. Dilated cardiomyopathy. Okay? Remember this. Because the pump function gets less and there will be increased ischemia in diabetic patients, and these are more prone for dilated cardiomyopathy. Then comes the side effects in the diabetic feet. This is mainly because of diabetic neuropathy. The nerves get affected. Okay? So out of that, if you have almost 60% of the diabetics have some form of neuropathy. So here it is foot neuropathies, out of which only 25% can have ulcers. What kind of ulcers that can happen in diabetics? Foot ulcers? Can anyone answer? You are fresh from MBBS, not me. Neurotropic, very good. The other one? Okay, we will cover. Again, if you see, 25% of the patients will have foot ulcers who are having, almost 25% go for amputation. This is very, very essential because good control of diabetes requires a good exercise quotient. If that is not done, the drugs do not affect well on the body, so the effects of diabetes can happen to all the organs, including the eyes. We always say that no one talks about diabetic retinopathy in the general physician level, but we also do the same mistake of not talking all other organ involvement. And if foot ulcer is there, then almost 85% of the amputations are mainly because of the foot ulcers. So these are the two types of foot ulcers. One is trophic ulcer, someone told very nicely. The other is gangrene or ischemic type, which again bypass can help them in avoiding gangrene. The other effects are diabetic nephropathy. Anemia again can aggravate the severity of diabetic retinopathy, lipid derangement and neuropathy. Definitely these need to be controlled. Now let us restrict ourselves to the ophthalmic involvement. Again, duration of diabetes, you cannot change this. This is not modifiable risk factor. So with the duration, there can be increased percentage of diabetic retinopathy, which you should know, which is IDDM or NIDDM. The duration is a little bit higher in NIDDM to have some form of diabetic retinopathy. So again, now the classification, every one of you may be knowing, and it should be knowing actually. So in mild, moderate, non-proliferative diabetic retinopathy, the main characteristic lesions are microaneurysms, number one. The number two is intraretinal hemorrhages. Hard exudates can happen, but they are not so classic. Cotton wool spots, initially we have given so much of importance or less important compared to microaneurysms and intraretinal hemorrhages. So when it comes to the classification of diabetic retinopathy, this is very, very simplified classification where the mild and moderate lesions may be there, but they are less severe. However, intraretinal hemorrhages, if they are severe in nature in all four quadrants, or venous bleeding in two quadrants, or moderate to severe irma in at least one quadrant also, these are three characteristics which you need to remember. If they are not there, then it is mild to moderate. If two of them are there, then it is very severe. If one is there, it is severe non-proliferative diabetic retinopathy, which is very simplified classification of non-proliferative diabetic retinopathy. So this certain times in the ETDRS, they have not highlighted the capillary non-perfusion areas, but fluorescein angiography can help you in identifying that. Why it is important? If you see the percentages here, the very severe non-proliferative diabetic retinopathy patients, within 1 year, half of them will progress into proliferative diabetic retinopathy. That is where the imminent treatments are very much needed. So how to manage non-proliferative diabetic retinopathy? No diabetic retinopathy. Here it is very, very essential stage where you need to educate the patient and have a good counseling so that it will help the patients in a very long run. That is very important. Otherwise, no documentations are required. Whereas mild to moderate, probably you need to reduce the follow-up for 6 to 12 months. If it is no diabetic retinopathy, it is annual follow-up. And the mild to moderate non-proliferative diabetic retinopathy, probably documentation is needed. Okay. Then if there is a diabetic macular edema and which is not clinically significant, non-center involving, probably you may have to observe, or you go for a specific treatment like laser photocoagulation, not injections. Because injections, both the talks are sponsored talks, you don't get carried away by that. Okay. Then clinically significant macular edema, everyone knows the definition of that. What is important? One clinical finding in clinically significant macular edema, diabetic macular edema. All three parameters I have written, but one single finding, which if it is not there, then it is not CSMA. thickening. Retinal thickening is the answer. Okay, hard exudates is not the answer. Someone was telling. Okay. Then this is not so much required. Then different types of diabetic macular edema. It can be focal, it can be diffuse, or it can be cystoid type, or ischemic maculopathy, or a traction maculopathy. These are the types you need to identify in diabetic macular edema. Then this was ischemic type. And here again angiography is important to identify the peripheral ischemic areas if there are persistent neovascularization that need to be treated with laser, not by injections. And the DME OCT classification, one should well aware of that because a lot of treatments can be titrated according to the type of OCT findings. And OCT angiography is also important in diabetic macular edema. And ultra-wide field imaging is required only in cases where there is a persistent diabetic macular edema or recurrent vitreous hemorrhages. Those cases only you need to rule out the peripheral ischemia and tailor your treatment towards those areas. Then ultrasonography B scan is mainly for media haziness, and if there is a vitreous hemorrhage, then you can see whether any traction, type of traction which is there or not, retinal detachment there or not, or choroidal detachment is there or not on B scan. And this is a traction maculopathy, which is classically, what is the treatment for traction maculopathy? PPV, straight. There is no other injections or lasers, okay, straight surgical intervention. And this is the algorithm which we have given involving center involving macular edema, non-center involving macular edema. Non-centering involving macular edema, probably you consider laser. Even this era, it is the treatment and it is very effective as well. However, you should stress about the good control of the systems, which is very, very essential. No one teaches this. This is very essential to stabilize the systems of diabetic patients. And laser photocoagulation, already we have given the indications there, and these are the parameters. If you want to note down, you can note down. Mainly it is ETDRS study which has given the modified grid now. The classic grid is no more useful and it is not effective, or rather it compromises the field, so you don't apply that. Modified grid is the treatment, and focal can be tried in cases where it is not center involving and away from the center. Probably focal laser is need to be done. And anti-VEGF agents, I need to skip this. Though the agents here, we have 3 agents we have given, but brolucizumab and faricimab, or faricimab is also very soon coming. It's already been applied in the clinic in USA, and in no time it will be available in India also. And among these 3 agents, the aflibercept was proven effective. So the comparison, the KITE study and CRYSTAL study, it's compared aflibercept with brolucizumab. In KITE study, Indian patients are more involved, where the effectiveness is almost equal. No one has asked that question to Vasumati when she showed that. You should have asked that. Then the treatment regimes, either it is a fixed dose regime, monthly regime all through, or treat and extend, or PRN. These are the 3 doses which we are, you have asked that question, very nice for that. But these are the 2 or 3 dosing regimens you can follow. However, when you are in the clinic, you will understand what pressure from the patient for the money that they have to spend with each injection. That's why we have to modify the regimens. And then steroids is another option which previous 2 speakers only concentrated on anti-VEGF. Again, here, when you use the steroids, make sure that he is a pseudophakic rather than a phakic patient. The pseudophakic, the results are very good in MAID study. And then now we will proceed to the proliferative diabetic retinopathy. Again, it is early proliferative, high risk proliferative, then advanced proliferative. Advanced proliferative, again with complications, is the fourth stage you can see. In early proliferative, the neovascular process will start, and here again, the anti-VEGFs can be given, but they given in every month if the patient can afford and can come. The advantage is the field sparing. However, laser photocoagulation is the gold standard for early proliferative diabetic retinopathy, with a PRP regime which was described in both DRS and ETDRS studies. Yeah, you are taking photographs, right? They are anyhow recording, don't worry. And this is the PRP pattern. Means certain times you may have to search for the laser spots, but when you are doing a tight laser, which is very much needed. And it can be Pascal laser, can also be a mode to give in a single sitting, it can be done. And these are the complications. These are important. Like CNVM can also be a complication of laser. Macular burn, especially when the learning stage, this can be a very serious complication because of the laser. So the constriction of the field is another disadvantage in terms of laser compared to anti-VEGF agents. But anti-VEGF agents, the patient should be under regular follow-up. If he loses the follow-up, he may go to the advanced stages of proliferative diabetic retinopathy. So then high-risk proliferative diabetic retinopathy, where the neovascularization of disc and neovascularization of retina or elsewhere, NVE. The size is more important. For NVD, it is either 1/3 or 1/4 of the size of the neovascularization is significant, above which is significant. NVE is more than half disc area. And this associated with pre-retinal or vitreous hemorrhage, you will consider this as a high-risk PDR. Why it is important, high-risk PDR? Why should we classify it or identify it as high-risk PDR? Detachment, no. The complications, yes. The either bleed or traction detachment, let us say, but it is more urgent for you to handle this patient compared to a early PDR. Early PDR, there will be some time a gap you can give, but not high risk. High risk, you should convince the patient, do good laser and send the patient, or if they are a very affluent patient, you give the injection and then call them. And this is a glaring example. If you see, a lot of neovascularization is there. It is not 1/3 or 1/2. It is several disc diameters of neovascularization is there. If you see, the macula is very healthy and this patient will have 6/6 vision. 6/6 vision do not rule out high-risk proliferative diabetic retinopathy. And the urgency, the patient may not pursue, that's where you have to take the patient to the fundus photographs and show him this is the picture you are having in your eye, and if this is left, either it will bleed very soon and lead to blindness, or if it is left and it is not bleeding, there can be a severe traction detachments where advanced stages of diabetic retinopathy can happen. So here again, this thing is very essential is that you do the pan-retinal photocoagulation. Then proliferative diabetic retinopathy with CSME or diabetic macular edema. This is where the injection role will come before the laser. Where there will be, if you do the laser, there will be a worsening of diabetic macular edema. So you need to consider first injections, and if the proliferation and the fibrovascular proliferation is not much, probably you add laser so that you can stabilize the patient clinically. The ultimate, if you cannot save at these stages, then the ultimate is the advanced proliferative diabetic retinopathy, where the surgical intervention is required, and the classic surgical intervention basic is vitrectomy. However, you do handle all the fibrovascular proliferation, everything along with vitrectomy. So what are the indications? We have enumerated here. Mainly the vitreous hemorrhage is the most common indication for vitrectomy in diabetic retinopathy. Next comes is the traction or the rhegmatogenous retinal detachment. Very rarely persistent nevascularization in spite of several sittings of laser. I have done few patients where there is a traction and the nevascular membrane is pulled up. That will not regress. That answer is you should go for vitrectomy. Means 10 sittings of laser they have done, still he is recurrently bleeding. So you should go for a vitrectomy. And a diabetic macular edema, when it is persistent and it is resistant cases where injections are repeatedly given, 10-15 injections, you may have to consider a vitrectomy in these cases. So these are the main targets of vitrectomy in these cases, and these are the few cases. You can see the amount of proliferation, and post-surgery, it's not only stabilizes the diabetic retinopathy status, but it gives a stable long-term result in terms of visual acuity. That is more important. And what is the treatment for this premacular hemorrhage? Vitrectomy? Laser. What is that laser called? Laser hyaloidotomy. That is the good answer, but in diabetics, because the posterior hyaloid is very thickened, it's very, very difficult to attempt egg hyaloidotomy. Youngsters where there is a subhyaloid hemorrhage, the hyaloid is thin and you can create a good egg hyaloidotomy. Okay. However, here the proliferative process also will be there along with it. So mostly you may have to do the resort to a surgical intervention, that is vitrectomy, and this patient done well with vitrectomy with 20/30 vision outcome. Another these days proliferative process, it goes through stages. If you see the fibrovascular proliferation, if the vasculature is predominant, the surgical intervention, especially the intraop, there can be a heavy intraoperative bleeding. These cases you may have to top up with anti-VEGF agents so that there will be a temporary regression of neovascularization, and which will give you a blood-free vitrectomy. What is the duration between injection and the surgery? Excellent. Probably you people are doing more surgeries than me. That's very nice. No, good answer. Within a 1 week time, it is the best time for performing a vitrectomy. So this is the outcome. See, with so much of vascular membranes, there is no bleed. This is the first day photograph. That's why I showed, means it is a little bit effective. Certain times we show you the best photographs so that the impression should be good. Okay, then surgical management of status post VR surgery. Why it is status post VR surgery? All VR surgeries need not go so successful and rosy. Certain times complications do happen, and what has happened here, there is a lot of fibrosis and a traction kind of a detachment involving the macular center. So the vision is only half meter. Unfortunately, both the eyes of the same patient, I show the other eye also, had similar kind of a complication. So don't think that vitrectomy you have done, everything will be over. No, advanced proliferative diabetic retinopathy especially is a very tough condition for a vitrectomy, and there can be a lot of complications. Okay, so this patient, what we have done, we done the revitrectomy and remove the membranes. I put the oil initially, and then 3 minutes are there. So I will stop in 3 minutes. Don't worry. Okay, so that is the outcome. See, vision 20/60 and a stable retinal status, which is very important. This is the fellow eye. You can see what is there. Such a large retinal hole, it's very, very tough to close. So we have intervened that eye first and then this eye, because this got operated somewhere else and landed up with me. So we operated the other eye, that is worsened within that 2 months period to half meter. Again, the outcome is 660. So it's not that all surgeries are successful, and it's not that all resurgeries are also successful. These are one good example to tell you that resurgery can be attempted. So the complications, I enumerated all the complications here. Most importantly, anterior hyaloid proliferation. Certain times when the vitrectomy is not proper or the amount of laser is not proper, there can be a proliferation of neovascularization in the residual vitreous, which can be very, very dangerous, and it can lead to a recurrent vitreous hemorrhages post vitrectomy. This you need to remember. Rest all complications can happen along with the vitrectomy. So this is very, very important 4 slides which are there. So another 2 minutes easily we can cover. First is first dilated examination. This is very essential, that if a person who is detected diabetes before 30 years, he should be examined by 5 years. If it is above 35 years, you should examine there and there, means immediately you should done. And during pregnancy, you should start the examinations from the first trimester onwards. Then follow-ups, anyhow, I covered this in the beginning as well. The no retinopathy annual screening, mild to moderate, 6 to 12 months. If macular edema happens, 4 to 6 months. Severe NPDR, 3 to 4 months is the follow-up schedule. And during pregnancy, every trimester you should do. And very severe non-proliferative or early PDR, you should suggest the treatment. High-risk PDR, actually you should not leave the patient actually from the clinic. Somehow you hold his feet and do the laser so that you will save him. That's what the empathy you need to have towards the patient, right? And this is last but very important slide, where a high-risk PDR or severe visual loss can happen if there is a baseline like very severe retinopathy. If the patient is already presenting, then he is a high risk, and visual acuity is poor, then high risk of visual loss. Glycosylated hemoglobin, I already told it will prevent you almost what percentage? I will not ask, time is up. And diabetic neuropathy, diabetic feet, that's why you should always see the diabetics, their feet, how the fingers are, and whether it's ischemic is. Low hematocrit value, again anemia, very important. And lipid profile, increased triglycerides is again high risk factors for these patients likely to lose the vision in follow-ups, okay? And low serum albumin is indicative of nephropathy. Excellent. Okay. With that, I would say thank you. It is on time. Rolika.
Thank you, sir, for your master class, I will say.
Now, master class is coming in during AOS. That is 1 hour instruction course on diabetic retinopathy.
Okay, before we leave our beloved Ajit Babu sir from the dais, like from the speaker dais, obviously. Any questions for him? I'm sure a lot of questions will be there. Yes, please, go ahead.
Don't ask questions to me, I may not answer.
You have
may
to
not be
answer,
able to answer.
You
may
have
not
to
answer
answer.
is different.
Yes, please, go ahead.
Sir, regarding vitrectomy indications, you told one is persistent macular edema. So, what cases will go? Because generally, if there is persistent macular edema, we'll try to do FF and we'll see any periphery CNP areas. Then we'll try to laser.
Yeah.
Like, in which cases we can go to vitrectomy?
These cases, mainly if you have a peripheral significant ischemic areas, definitely the first go is to target those areas with laser, okay? You have done that, there is no peripheral ischemic areas, you have done almost 10, 14, 15 injections, which already 2 speakers have highlighted how many number of injections happily you can give in the clinic. If that is happening and the patient is bleeding for money, not for the blood inside the eye, money, and there is a taut posterior hyaloid especially, those are the cases for vitrectomy in a persistent diabetic macular edema.
Thank you.
So diabetic macular edema per se, it's a very good question actually. You should rule out whether it is tractional or non-tractional.
Yes.
So the tractional macular edema, you lean more towards vitrectomy. It's not that you are just going to do vitrectomy straight away. In select cases, yes, we do it straight away where there is too much of traction, pull on the retina. But if there is a epiretinal membrane and those kinds of things, so you should be very watchful in injecting this patient and follow these patients very closely. But very valid question.
Yeah, not only that, in the OCT you should see whether there is any hyaloid traction. It need not be a point traction. You may be thinking that this is point traction and it is indication for surgery. So it has a broad-based traction, and this may lead to a early cellular maculopathy
Yes, sir.
or the fibrosis, little bit of fibrosis in the periphery. That can be a good indication for vitrectomy in maculopathy, persistent maculopathy.
But you should always be watchful. Very good question. Any other questions for sir? Okay,
Thank
sir.
you.
Thank you so very much,
You
sir,
are
for
so
the
kind.
enlightening talk. Always pleasure listening to you and learning from you, sir, always. Next, we have another prolific surgeon from Delhi and Faridabad, a very dear friend, Dr. Avaninder Gupta. He doesn't need any introduction. He's a consultant at Center for Sight and also Nayan Jyoti Eye Center. He will be talking to us on two very relevant topics. One is what is the protocol T. drcr.net, as what already we are, all of us are aware that they have devised very protocol, but which one is for what it is of knowing is of prime importance. So he'll be speaking to us on protocol T. Let's hear more from him on that. And also a very relevant topic in medical retina is central serous retinopathy. How are you going to manage it? Over to you, sir.
Thank you, Dr. Manoj. And at the outset, I'd like to thank Dr. Santosh, Dr. Mahipal Sachdev, Ritika, and especially Rolika for arranging this great meeting. I'll be talking about central serous chorioretinopathy. This is the third most important macular disease encountered in day-to-day practice in our retina practice. CR is characterized by serous detachment of the neurosensory retina with or without pigment epithelial detachment. It was first described by Graffe in 1866, and he described this as a recurrent central retinitis. Gass renamed it as an idiopathic central serous retinopathy and also described the etiopathogenesis of central serous retinopathy. If we look into the pathophysiology of CSCR, what happens, there is an hyperpermeable choroidal vessels. Because of that, there is an increased hydrostatic pressure, which overcomes the barrier function of retinal pigment epithelium. There are two barriers, one is inner and one is outer. So the outer retinal barrier is governed by retinal pigment epithelium. This leads to a formation of a pigment epithelial detachment. There is a breach in the RPE, and once this breach occurs, it allows entry of fluid in subretinal space. Recently, aldosterone oblique MR pathway has been postulated in pathogenesis of CSCR. If we come to the cause, it's usually idiopathic. Young males are the epidemiology is young males are affected. Usually it presents between the age of 30 to 50. It's a macular detachment and not macular edema. You have to differentiate between detachment and edema, because in edema you will have intraretinal cyst, in detachment you will have a subretinal fluid. There is an association of stress. Type A personalities will have this disease found more commonly. In hypercortisolemia, hypertension and sleep apnea, the incidence is more. So you should always take a very careful history and also tell your patients suffering with central serous retinopathy to change their attitude, do some meditation to decrease the stress. Patient usually comes with a complaint of blurred vision, relative central scotoma, metamorphopsia, dyschromatopsia, hypermetropization, and micropsia. The diagnosis is usually with plus 90D or indirect ophthalmoscopy. What you see here is a central blister-like appearance in the macular area, and because of this central-like blister-like appearance, you will have a relative scotoma. It's important to see all the margins of this serous detachment, because many a times inferior detachment can also present like serous detachment here, And if you miss an inferior detachment, then line of treatment changes. So all the margins of this blister should be seen. BCVA generally improves with plus 1.5 diopter spherical, and many a times you will see yellowish precipitate in the CSR that are subretinal precipitate, and that is a sign of resolving central serous retinopathy. Investigation, we generally do an OCT followed by a fluorescein angiography or ICG in few cases. This is one of the patient, you can see there is a central serous retinopathy. These are pigment epithelial detachment filling up in early phase, and you can see there is a point leak here which increases with time and becomes an ink blot leak. These are the typical findings on fluorescein angiography. Once you do an ocular coherence tomography, you can see a subretinal fluid, which is an hallmark of central serous retinopathy. Another patient, you can see on fluorescein angiography, there is a juxtafoveal leak with a pigment epithelial detachment and is a serous fluid, which suggests the patient is suffering from central serous chororetinopathy. It is important nowadays to do an OCT EDI. Anybody can tell what is OCT with EDI? So how do you measure EDI in patients of central serous retinopathy? There is all machines will have an marker where you can put an EDI, and then what happens initially on doing OCT, the maximum gain comes from the vitreoretinal interface, which shifts on to the retinal pigment epithelium, so the choroids can be captured. And if you are doing an SS OCT is swept source OCT, which has more penetration, and you can get a better choroidal picture. So what we are doing is a spectral domain OCT, and in that there will be an EDI mode. But if you do an SS OCT, then you can measure the choroid. What is the normal choroidal thickness? Yeah, anybody? It's 287 at the age of 50, and there is a decrease by 10, decrease by 10 microns every 10 years. Okay, so the adult patients will have a thinner choroid, but in patients with central serous retinopathy, you will find an increased thickness of the choroid. This we also call as a group of disease, what we call as a pachychoroid disease. And CSR is one of the, in pachychoroid spectrum, CSR is one of the spectrums in pachychoroid spectrum. So always, if you have a doubt of a CSR or you have a confusion, then you always should go and measure the choroidal thickness. Coming to the variants of central serous retinopathy, it can be typical CSR or it can be an atypical CSR associated with retinal pigment epithelium. There can be leaks which can be single, it can be an ink blot leak, it can be a smokestack appearance or an inverse smokestack appearance. And many cases you can find a multiple leaks. There can be a small blister-like CSR, but many a times you can find a giant central serous retinopathy, which mimics usually like an inferior RD. And you should know this entity, and you should be able to differentiate between a giant CSR and an inferior retinal detachment. Again, according to the chronicity, you can classify it into acute central serous retinopathy and chronic central serous retinopathy. Acute central serous retinopathy usually resolves by 2 months, 2 to 3 months, but in chronic cases, it persists over a period of 3 to 6 months with pigment degeneration. This is one of the patient of multifocal CSR, and this patient had a large inferior detachment, and you can see multiple leaks here in this patient. This is another patient of a chronic central serous retinopathy. You can see this track here. This denotes that this patient is a patient of a recurrent central serous retinopathy. And if you see, there are multiple leaks here. We did focal to these leaks multiple times. You can see this focal marks here. Each time it used to resolve, but after a period of time, the CSR used to reoccur again Finally, with this, we did photodynamic therapy to this patient, and you can see a total resolution of central serous retinopathy in this patient. Coming to the differential diagnosis, pachychoroid spectrum, what we have talked about, many times CNVMs can present as in central serous retinopathy, PCV, optic nerve head pit, inflammatory disease like VKH, AMPP can also present as in serous detachment and choroidal tumors. Here is one of the patients of PCV presenting with subretinal fluid. The important thing here to distinguish from a central serous retinopathy is you should see the pigment epithelial detachment. The pigment epithelial detachment, if the angle is more than 45, then it are on the side of an PCV, and you will see a double layered sign in this. Or if you see this kind of a double hump PED, the diagnosis is spot on of a PCV. This is one of the patient you can see presented with an serous detachment here, and if we do an you can see an OCT topography here, a lot of fluid in the central, and you can if we did an octa, there is an CNVM here on fluorescein angiography. You can also see an choroidal neovascular membrane. This is optic nerve head pit also presenting as a serous detachment, and you can see on OCT pictures, you can see the optic nerve head pit extending into the optic nerve head. Vogt-Yanagi syndrome presents usually as an exudative retinal detachment, but how to distinguish from a central serous retinopathy is you will see yellowish pinpoint lesions at the retinal pigment epithelium. In these cases, OCT is not diagnostic. In these cases, fundus fluorescein angiography is diagnostic. You will see an early hypofluorescence followed by multiple leaks over a period of 3 to 5 minutes. And all the cavities will be full of fluorescein dye, and you can see multiple serous detachment on fundus fluorescein angiography, which is diagnostic of VKH disease. This is one of the very interesting patient. This patient came to me. He said, patient told me the diagnosis, I have a central serous retinopathy, and I have been treated 2 times before. Each time it resolved by itself. But once I did an ultra wide field imaging here, you can see there is a mass lesion here, and you can see there is a serous detachment. So if you see only the posterior pole, then you will make a diagnosis of central serous retinopathy. But the moment you do an indirect ophthalmoscopy, you will diagnose it as an choroidal hemangioma. And we did in fluorescein angiography, and you can see there is a filling, early filling of the dye in this lesion, and late leakage suggestive this is an choroidal hemangioma. So you need to distinguish and know these diseases which can be confused with the central serous retinopathy, because central serous retinopathy is one of the most common encountered disease in our daily practice. If we look at the management, there is currently no standard of treatment of central serous retinopathy. Various modalities has been tried: focal laser, TTT, PDT, ICG-mediated focal laser, intravitreal bevacizumab, and drugs like rifampicin, ketoconazole, propranolol, epinolone with limited success. And each of this we'll discuss in detail. So if the patient comes within first episode of acute central serous retinopathy, you have to counsel the patient. There should be a masterly inactivity. Do baseline imaging. Rule out patients whether they are taking any skin creams or patient is on steroid, because we know steroids can worsen the disease. This is one of the patient. You can see ink blot leak here, and we watched this patient for 6 to 8 weeks. There is a spontaneous resolution of central serous retinopathy over a period of time. How much to observe? 8 to 10 weeks is an ideal time. You can see the signs of subretinal precipitate. It shows that the CSR is resolving. If the job demands are high, like drivers, bilateral involvement, steroid for systemic cause, recurrent central serous retinopathy, then early treatment in terms of focal laser can be taken up. If it's a recurrent or a chronic CSR, repeat fundus fluorescein angiography. Generally, what I do now is I do an OCT at the first visit, confirm the diagnosis, FFA is only done once I plan a treatment for the patient. So localize the leak in AV phase or mid phase. If it is in safe area, that is 750 microns away from the central of the fovea, then you can give a gentle focal laser burn. It's very important that your burn should be only grayish white, not whitish color burns. A few spots of 200 microns in the area of leak is given. The results are generally good. It's important that you have to tell the patient that improvement will not occur immediately. It will take somewhere between 2 to 4 weeks for the improvement to occur. This is one of the patient. You can see multiple leaks here. And we did a focal laser for this patient. And after a period of time, you can see the CSR has resolved. These are the OCT pictures, serial OCT pictures, showing the resolution of central serous retinopathy. Coming to recurrent or chronic central CSR with subfoveal leaks, options are various drugs, but all the drugs, there is a big question mark whether these drugs works or not. The treatment of choice, if PDT is available, then yes, a low fluence PDT is the treatment of choice. Apleneron is one of the drug which is talked about. It's aldosterone antagonist. It's given in a dose of 50 milligram OD for 4 weeks, used in treatment of high BP and congestive heart failure. Blocks aldosterone pathway. This blocks amount of sodium and water the body retains. Has been used anecdotally. There are multiple, there is one trial which has come from American Academy, which what we call as an Vichy trial, which showed apleneron has no role in central serous retinopathy. But many patients, we are giving apleneron where you have a subfoveal leak. And this is one of the patient, you can see there is a subfoveal leak, and we cannot do a focal laser, and the chronicity was somewhere around 2 to 3 months. And over a period of 4 to 6 weeks, you can see a total resolution of the central serous retinopathy with a subretinal exudate, and vision improved to 6.9 from 6.60. Rifampicin, again, it's given in the dose of 300 milligram, increases the metabolism of endogenous steroids. This is one patient of central serous retinopathy with a lot of subretinal exudation, and we gave rifampicin, and you can see the resolution. But these are not the drug of choice. These are therapeutic trials what we have done because we couldn't do a focal laser in these patients. Mifestrone then is one other drug. Then intravitreal bevacizumab has been described in literature. Small case series have shown potential benefits of treating central serous retinopathy with intravitreal Avastin. However, another case series showed no beneficial effect of Avastin on CSC. In my opinion, since it's not an anti-VEGF related drug, so it does not show any, Avastin does not have any role in central serous retinopathy. The patient which must have benefited must be patient of pachychoroid disease or PCV patients which have benefited from this disease. Coming to PDT, PDT in chronic CSR acts by closing or narrowing vascular channels in choriocapillaries, but success is limited due to complication like choroidal ischemia, CNV or RP atrophy. Smithing et al. Utilized half-fluence PDT in cases of acute central serous retinopathy. We have a series of somewhere around 23 patients where we did low fluence full dose PDT for chronic central serous retinopathy. All patients except 2 responded to the treatment. Patient which did not respond to the treatment later turned out to be an PCV as it came with a large subretinal bleed. 2 patients had retinal schisis, responded to the treatment. There was no side effect seen in any of the patients. This is one of the juxtafoveal leaks, and we did a PDT in this patient. You can see a resolution of fluid, pre and post PDT OCT images. PDT is not available. The main problem is PDT is not available at the moment in the country. Anti-VEGF, which has action on choroid, can be considered. Drugs like aflibercept and brolucizumab can be given in these because it's a choroidal disease and it can penetrate into the choroid. This is one of the patients with the pachychoroid disease. We gave intravitreal brolucizumab, and you can see the retinal edema subsided on this. So to summarize, it is the fourth most common macular disorder in clinical practice. Diagnosis is clinical and with OCT. FFA is planned in non-resolving central serous retinopathy. 70% of CSER patients responds to supportive treatment. Focal laser is recommended for extrafoveal leaks. PDT is done in chronic recurrent or subfoveal leaks. In chronic and recurrent CSER, OCT EDI should be done to diagnose pachychoroid spectrum. In absence of PDT, newer anti-VEGF like brolucizumab or aflibercept should be tried. Thank you very much for your kind attention.
Thank you very much, sir, for a wonderful talk. Any questions for Dr. Gupta, please? Yeah.
No, no. It was for subfoveal leaks. See, you have to divide the leaks into subfoveal leaks and then extrafoveal leaks. If you have an extrafoveal leaks, then the treatment of choice is focal laser. PDT is only for patients of subfoveal leaks where you cannot do an focal laser, or in patients of where you have an juxtafoveal leaks, then only PDT is recommended. And that is also not full fluence PDT, it should be half fluence, full dose photodynamic therapy. First line of is observation for 2 months. If it doesn't resolve, do a fluorescein angiography, and if there is a extramacular leak, do a focal laser or a thermal laser in this patient.
Dr. Atul, can you use the microphone?
PDT is never given as acute CSC treatment. You wait at least 3 months chronicity. So for acute CSC, probably nothing. You just tell the patient to relax, sleep well. Lack of sleep is a major cause of CSC. People who have very poor sleep so sleep medicine comes in. So CSC, PDT is a very good treatment, as Avnender mentioned, for hemangiomas, for CSC, but unfortunately Novartis gave it up and we are in a soup, because actually photodynamic therapy is very effective. Even for neovascular AMD, PCV eyes who don't respond to anti-VEGF, the cost goes up. Then photodynamic therapy, reduced fluence usually, as Avnender mentioned, is a very good treatment modality. And all you have to do is cold laser for 83 seconds. But some of the dyes disappeared because probably not cost benefit to the companies.
Aplineron is a drug which is given for central serous retinopathy. There are two schools of thought. It's given in a dose of 50 milligram OD for a period of 4 weeks. There is a trial, what we call as a Vichy trial, which showed that aplineron does not have any role in resolution of central serous retinopathy. But there are multiple trials also available in the literature which says that aplineron do have a role in resolution of central serous retinopathy. So if you feel a patient does not want focal laser, you can give a therapeutic trial of aplineron. It's available with the name of Epitus. The dose is 25 milligram BD or 50 milligram OD.
And protocol T as well?
I'll
Make it quick.
Yeah. With multiple talks available, with multiple anti-VEGFs available, there are 3 most common used anti-VEGFs at the moment in diabetic retinopathy. One is aflibercept, bevacizumab, or ranibizumab. So anybody from the audience who can tell what is the first line of treatment in cases of diabetic macular edema? Ranibizumab, then anybody else? So that's what I'll be talking about, which anti-VEGF is the best and in which situation you should choose and which anti-VEGF. See, brolucizumab has just come into the market and FDA approval for diabetic macular edema has come a month back. So we are not using brolucizumab as a first line of treatment, what you asked. So the drug of choice at the moment are three. One is bevacizumab, the second is ranibizumab, and third is aflibercept. And we'll see in this protocol T which drug is the best. So the primary objective of this protocol T was comparison. Another important thing before going for anti-VEGF treatment is you have to define central in what Dr. Ajit Babu has told us, central involving macular edema and non-central involving macular edema. So anti-VEGFs are only given at the moment for central involving macular edema, and if you have a non-central involving macular edema, the first line of treatment is laser. That should be very clear. The concept going is ki anti-VEGF, no laser. Anti-VEGF is the line of treatment in diabetic macular edema. But if you have a non-central involving macular edema, the first line of treatment is laser. The comparison of intravitreal aflibercept, intravitreal bevacizumab, and intravitreal ranibizumab. 660 patients were taken in interventional randomized multicentric study in patients with type 1 and type 2 diabetes. Patients was randomized 1:1:1, and at the primary outcome was seen at 52 weeks. Patient was asked to visit every 4 weeks, and at 4 weeks, each visit refraction was done, OCT spectral domain was done, dilated ocular examination with color fundus photograph was done. Repeat injection at every 4 visit if eye improved or worsened. Otherwise, defer injections if either visual acuity you have achieved 20/20 vision or OCT CST is below 250 microns. At and after 24 weeks, visual acuity and OCT are stable after 2 consecutive injections. Resume injections if visual acuity or OCT has worsened. And how do you define improvement or worsening of diabetic macular edema? 5-letter change, that is 1 Snellen line change from last injection, or 10% increase or decrease in central subfoveal thickness on OCT from the last injection. Focal or grid laser was initiated at or after 24 weeks only if persistent DME was, patients with persistent DME was not improving after 2 or at least 2 injections. The importance here is that you should see in protocol T where the treatment of diabetic macular edema was primarily on anti-VEGF. They have used laser at 24 weeks and they have set this laser as rescue treatment. So if we see the results, 1-year results of protocol T, with aflibercept there was 13.3 letter gains, with ranibizumab there was 11.2 letter gains. The number of injections what are required is almost 9 injections in all the groups. So it's important that you should know that 1 injection is not going to make a difference. Multiple injections should be given in patients of diabetic macular edema. Another important thing, if you see this last line here, in aflibercept group, 36% patients needed laser treatment, rescue treatment at 24 weeks. The number of patients in bevacizumab group was 56% and 46%, meaning thereby the maximum drying effect came with aflibercept, while the drying effect with bevacizumab and ranibizumab was lesser as compared to aflibercept. So aflibercept results in complete resolution in 64% of patients as compared to 1/3 of the patient with Avastin and half the patient with Lucentis. If we see this graph, now there is a subgroup analysis. If the visual acuity is between 2032 to 2040, all the 3 drugs behaves the same. You can choose any other drug and the letter gain was +8. So if the vision is better than 612, then you can choose any drug, all will work the same. But the difference comes when the vision is less than 20/50 or less than 612. You can see with aflibercept, the increase in letter gain was 19 as compared to 14 in ranibizumab group and 12 in bevacizumab group. So the important message here is that if the visual loss is high, then the first line of treatment is aflibercept. And this was highly significant. Aflibercept with bevacizumab, p-value was 0.001%, and aflibercept with ranibizumab, it was not significant. And these are the comparative analysis of two graphs. And you can see the subfoveal thickness, the maximum drying effect came with of 169 microns came with aflibercept rather than with ranibizumab and bevacizumab. But after 2 years, the gap which was there between ranibizumab and aflibercept decreased from 12.8 to decreased by because ranibizumab caught up and the patients with aflibercept slightly declined. So the decrease was less as compared to after 2 years, and it was not statistically significant what it was there at 1 year. So what they came that the area under curve, meaning that patients with the greater visual loss, if treated with aflibercept, gained a better visual acuity earlier as compared to ranibizumab. So if you have a patient with a marked decrease in visual acuity, the first line of treatment is aflibercept. In the second year, you can see in the first year, the number of injections were 9. In the second year, the number of injections reduced to 5. And the third year, DRCR net protocol, the third year, the number increases to 3. And fourth year to 2. And similarly to fifth year, it decreases to 2. So if you tell the patient ki you get an loading dose or a good number of anti-VEGFs, then the disease has a finite end. This is one of the patients we gave an aflibercept. You can see a resolution of edema. Another patient of aflibercept, you can see a resolution of edema. All three anti-VEGF agents on average produce substantial visual acuity improvement by 1 month, sustained through 1 year. On average, greater improvement occurred with aflibercept, but relative effect varied by initial visual acuity gains. Statistically significant mean improvement of 18.9 for aflibercept versus 11.8 for bevacizumab and 14.2 with ranibizumab. Clinically meaningful improvement occurred with aflibercept, that is more than 15 letters. Bevacizumab had a lesser effect on reducing macular edema than the other two agents, regardless of starting acuity. Few eyes in any group had substantial visual acuity loss. Median number of injections were 9 to 10 in first year and 5 in second year. Fewer eyes in the aflibercept group received focal or grid laser for diabetic macular edema after 24 weeks, presumably because the greater percent of the eye in aflibercept group had resolution of central diabetic macular edema, which drives the decision to apply laser. Third question, when to stop an anti-VEGF agent if you have a dry fovea with normal foveal contour on 2 consecutive monthly visits with normal visual acuity or stable visual acuity with cause of visual loss explained is to ischemic maculopathy, then you can stop the disease. Even if the macula is not dry and the visual acuity and the OCT are stable, then also you can stop the injections. Aflibercept with this inhibition of VEGF and prostaglandin inhibition leads to disease modification, and this is one of the examples. You can see it's a severe non-proliferative diabetic retinopathy. On sustained anti-VEGF inhibition, there is a disease modification, and this from severe non-proliferative became to a moderate non-proliferative diabetic retinopathy. If we look at the various guidelines given with by various societies, the EURETINA guideline provides expert opinion when to use and what drug to use. Recommendations for anti-VEGF in diabetic macular edemas. Anti-VEGF therapy is recommended as first line of therapy. Aflibercept is preferred in eyes with baseline visual acuity score of less than 69 or 20/50 or worse. Aflibercept equivalent to other anti-VEGF agents in eye with baseline visual acuity of 20/30 to 20/40. These are the Asian guidelines, And anti-VEGF therapy should be given in the first line of treatment in patient with central involving diabetic macular edema. Choice of anti-VEGF depends on visual acuity, which we have discussed. Early intensive anti-VEGF therapy is important in patients of Asian origin. So to conclude, plethora of management techniques are available in our therapeutic armamentariums. Availability of aflibercept has added to a potent weapon which is, if used judiciously, can improve outcomes with optimum cost. With the price difference reducing after introduction of Eylea for U program, aflibercept has become the drug of choice, and focal laser can be combined with anti-VEGF to decrease the number of injections. This is very important. If you see leaks beyond 750 microns from the center of the fovea, once the thickness decreases, you can laser this microaneurysms, and by this you can decrease the number of injections. Patients and constant effort by all is needed, regardless of the drug use. It's a marathon and not a sprint. Thank you very much for your kind attention.
Are there any questions to Dr. Avanindra Gupta? Only this talk. Then we will move on to, thank you Avanindra. We will move on to the another important and second most common retinal disorder, that is vascular occlusions, and it will be delivered by Dr. Manoj Khatri.
Are we all awake? Huh?
Chai pili.
Or still post-lunch hyperglycemia is going on, I think. Thank you. Thank you, sir. The topic for me is retinal vascular occlusions. I have kept a very simplified exam-oriented approach talk, so no trials, nothing will be there to discuss. Just a gist of it, and let's have it as a bilateral discussion. I want you to respond to my questions whenever I'm asking, so that we have more interaction and keep learning from each other. No financial interest in my talk. Fortunate to have a small CME once long back, about 12 years back, with a doyen of ophthalmology, Professor Sohan Singh Haire, who has given us a lot of insights as to why these vascular occlusions occur, what is the pathoanatomic mechanism, what is the etiopathogenesis, and how should you manage. So first and foremost question is, how will you classify retinal vascular disorders? When we look at retinal vascular disorders, broadly they are categorized into three things: retinal vein occlusions, arterial occlusions, and very rare ocular ischemic syndrome and carotid ocular disease. But in post-COVID era, we have sometimes a mix and match of these occlusions, and which can present with varied sets of presentations. So we should be very much aware that sometimes this can be a sequelae of either a COVID-19 infection per se or a vaccination per se. So keep your eyes and mind open for all these things. So why it is important is we need to know the site of occlusion, the stage of occlusion, and then only you will be able to investigate and manage this patient further. Just a brief gist before we go into one of the occlusion sites. The ophthalmic artery gives away to the bifurcation to central retinal artery, and then we have an annulus of Zinn. We have a division called as a retrolaminar and prelaminar region. All these things are very, very important to understand, because once you understand the pathoanatomy, then only you'll be able to pinpoint the location of the occlusion, and then only take forward the management from that site. We should be aware, I think the blood supply to the retina is divided into two parts, outer retina and inner retina. All of us should be aware what is the supply for the inner retina and what is the blood supply for the outer retina. Outer retina is mainly by choriocapillaries, and inner retina is by the inner retinal vasculature. So let's come to the retinal vein occlusions. What do we mean by retinal vein occlusions? It is one of the second most common retinal vascular disease, secondary to age and systemic factors. But the most important thing here is, whenever you see a patient with retinal vein occlusion, don't concentrate only on the eye. You need to see patient as a whole. Why so? The patient has to be effectively treated to reduce the risk of cardiovascular and cerebrovascular comorbidities. To classify it further, we have ischemic, non-ischemic variety, and depending on the location, it can be either a complete occlusion or a hemicentral retinal vein occlusion or a branch. The branch retinal vein occlusions, depending on the site of occlusions, has been classified into various categories. The most commonest is the supratemporal occlusion. Okay, clear? So now central retinal vein occlusion, as we said, one of the most common retinal pathologies. Age is one of the major factor here, and males and females are equally affected. There is no specific predilection. So what are the risk factors of CRVO? Can you enumerate few? Loudly. Age, very good. Then, yeah, then diabetes, hyperlipidemia. Basically, according to age, we classify. The younger the patient, we look into more into detail. The older the patient, we don't have to look into more of detail, but we still have to look for the systemic risk factors, and also smoking, as well as what are the ocular risk factors? Which glaucoma? Primary open angle glaucoma. Other things? Any refractive error predilection? Hyperopia, not myopia, hyperopia. And then very rare causes, we have inflammatory and so on, and other things like very rare, but dehydration, smoking and so on should be considered. So what is the pathogenesis of CRVA? Why does it occur? Quickly. I have only 20 minutes and 20 questions are there. Pathophysiology of central retinal vein occlusions? Speak. Even if you are wrong, no one is going to punish. Very good. Yes. Compression. Yeah, compression. So retrolaminar and prelaminar, and based on the the occlusion, the type of occlusion, what you are saying, you classified it further whether the vascular wall abnormality is there, or the blood vessel, the blood constituents, they are at fault, or they are comorbid condition like diabetes, dyslipidemia, and hypertension. Why so? Because the every mechanism will alter the course of the disease, which is very important. You want to alter the course of the disease. You just don't want to keep injecting and so on. So pathogenesis mostly similar. However, another pathogenic mechanism which is very common is, this is one of the very commonest viva question, is they share a common adventitious sheath, both artery and vein. And whenever there is a change in the caliber of artery, it compresses on the vein, and which leads to a cascade of events, ultimately giving rise to a increased VEGF productions and causing a occlusion there. Okay, clear? Now what are the mechanism of macular edema? Why does macular edema occurs? We are saying here there is a compression, but why does macular edema occurs? Sorry? Ischemia 1, very good. Then before ischemia, there is a global hypoxia actually, because the blood is getting stagnated here, there is no drainage. So there what happens is there is a global hypoxia. Global hypoxia can trigger various cascadic mechanisms. The most common one is on the VEGF on one side, and the second, what you rightly pointed out, inflammation. Why we need to understand this is because most of the modalities of treatment will work for vein occlusions. Okay, so unless and until we do, we are not going to justify the management. So what are the types which I already highlighted? Okay, what are the difference? Quickly, 6 key difference which every postgraduate should be telling in exam. Ischemic versus non-ischemic. Very good. Before RAPD, visual acuity. RAPD, then? Very good. Extent of hemorrhages and ischemia. Okay, clinical examination. Then? Sorry? Yeah. ERG will come last. Very good. Then? Capillary non-perfusion areas. We need to know the perfusion, isn't it? We are dealing about vascular disorder. Anything vascular, you need to know whether the area is perfused or not perfused. Either you do it clinically, you do it angiographically, you do it ERG, choice is yours. But capillary non-perfusion areas, okay? So these are the various points, telling us that this is non-ischemic CRVO. Basically, the hemorrhages are few. The occlusion site is not that great, and looks like a fresh occlusion. What is the single most complications or treatment modality which you will be targeting at for non-ischemic central retinal vein occlusion? Correct, cystoid macular edema. Okay. What is in ischemic CRVO, what are we going to do? We are looking at the neovascularization. Okay, very good. And also ischemic CRVOs has most of the other presentations as well. Most acute stages will start to resolve after a year. Macula may become atrophic, RP, hyperplasia, epiretinal membrane, and so on. The list is endless. What is hemiretinal vein occlusion? Why does it occur? Hemiretinal vein occlusion. Now we have branch, we have full-blown CRVO, we have hemiretinal. Why does it occur? Why does it occur? So here at the bifurcation side, the compression is there on the both the end. So the artery is not compressing only on the one side, it is compressing on both the sides, so you get a hemiretinal vein occlusion. What is impending CRVO? You must have seen in notes, someone writing impending CRVO. Why it is important to know impending CRVO? Very good. What is impending CRVO? So basically it mimics CRVO, or it can be sometimes precursor for CRVO, okay? And it's specifically seen in younger patients, so we should be following these patients quite regularly. These patients can develop non-ischemic CRVO over a period of time, yet not been treated in time. What is papillophlebitis? And what is diabetic papillopathy? What is papillophlebitis? It is not as, it is not as equivalent to impending CRVO. Papillophlebitis is something different. Here, the risk factor remains the same, the age remains the same, but how you differentiate is basically a disc edema and inflammation and RAPD. It differentiates, you need to differentiate from diabetic papillopathy. Is the differentiating feature here is diabetic papillopathy will have a telangiectatic vessels. By somehow I got, my slides are missing, but we have very good photographic documentation of that. So diabetic papillopathy will have fine telangiectatic vessel on the optic nerve head, whereas papillophlebitis will not have. So this is one of the main differentiating features. Ocular evaluations for a patient with CRVO, you already pointed out, RAPD, IOP, fundus examination, and OCTA, and also on. I'm going to skip couple of slides which are not of our today's interest. All of us know like what is the importance of delayed feeling and looking for collaterals in these patients, and what is the importance of OCTA. Now come to the next question. What are the systemic investigations of a patient with retinal vein occlusion? Commonest VIVA question asked. Sorry, one by one, quickly. Hemogram. Start level 1, level 2, level 3. So let me simplify it. Level 1, level 2, level 3. Level 1 is your basic blood parameters, which includes blood pressure monitoring, ESR, CBC, and so on. And also plasma homocysteine should come here. It can come in level 1 and level 2 as well. And also plasma protein electrophoresis. And look for renal signs of renal failure. Level 2 indicates little more investigations where you are looking for specific infections if not been diagnosed clinically, and also in younger patients. And level 3, your rest of the other problems which can give rise to retinal vein occlusions. Management of CRVO, BRVO, non-ischemic ones. So many trials you are listening from the morning. Sorry? Anti-VEGF, one of the first mainstay of treatment. Then what are the other options? Okay, so let's divide into management into macular and non-macular causes. Macular causes, mainly you are worried about cystoid macular edema, or if there is optic nerve head swelling or optic disc edema, you need to treat accordingly. And secondary managers, which includes management of neovascular glaucoma, neovascular of angle, and neovascularization of disc. Okay. So these are the various different options available. Basically, you divide patients into good visual acuity and poor visual acuity. Even in non-ischemic CRVOs, patient with good visual acuity, you can still observe them if there is not much of a macular edema by controlling the systemic risk factors. But there is a debate. You can even start these patients on early on treatment with anti-VEGF. Definitely poor visual acuity patients, they need close monitoring and need further set of treatments. The BRVO treatment remains more or less the same. There are very subtle differentiations which you can read it. What is 100-day glaucoma? Neovascular glaucoma. Why does it occur? Very good. But why only at 3 months or 100 days? Why not earlier? Why not later? So the proposed mechanism is till that time the retinal vasculature can hold on the insult which has been happened to the compromised venous system, but beyond that it is not been able to handle it. So that's what is typically called as 3-month or a 100-day glaucoma. Basically we need to know this thing because the management is quite aggressive in these patients. Okay. Follow-up of a patient with retinal vein occlusion, how do you follow up these patients? Monthly follow-up for how long? Lifetime? So basically you divide into branch retinal vein occlusion or ischemic versus non-ischemic central retinal vein occlusion, and then monitoring is done for close to 2 years irrespective of the vein occlusions which has been involved. If non-ischemic cases you can do initial monthly follow-up, then later on 2 or 3 monthly, but ischemic CRVOs you follow them, or BRVOs you follow them very closely. What are the clinical trials? Can you just name a few? It's out of perspective of my talk, but just name a few trials for retinal vein occlusions. CVOS to start with, then BVOS, recent ones, Cruz, Geneva, Copernicus, SCORE. Okay, you should be knowing the aim, objective and the final outcome of these trials. I will not go in details. My presentation as it is, I am going to share with Rolika. She can share everything with you. Let's come to retinal artery occlusions. Why it is important to know retinal artery occlusions? Emergency. What kind of emergency it is? Just 2 minutes, 3 minutes rather. Ophthalmic emergencies, definitely post-COVID era, we also have a lot of different types of retinal artery occlusions. Importance of cherry red spot, why does it occur? We'll just see in a couple of minutes. What are the risk factors for retinal vein artery occlusion now? Very good. What else? Commonest risk factors. Atherosclerosis, what else? Age. Then what are the systemic comorbidities? Carotid artery disease. If you don't say carotid artery disease, you have a patient with CRAO, the examiner will not like it. The moment you see a patient with any arterial occlusion, first thing you have to rule out is carotid artery disease. Okay, carotid artery disease and then elevated cholesterol levels. Symptoms we all know. We basically have to differentiate between what? When you see a patient in the clinic with arterial occlusion, what you have to differentiate between? Whether the arterial occlusion is arthritic or non-arthritic, correct? Arthritic or non-arthritic. So what are the types of CRAOs? Non-arthritic or arthritic, and also cilioretinal artery sparing. Okay. So and there is also an entity called as transient CRVO or otherwise amaurosis fugax. What is the pathophysiology of central retinal artery occlusion? Why does it occur? Quickly. Kansky gives this. I am not asking anything out of the syllabus. Quickly, 4 causes. Thromboembolism, then thrombosis, emboli, then Holler's plaques, which are type of emboli, and rare causes of emboli like cardiac vegetations, fat myxoma. So you should be knowing all this. What is the amaurosis fugax? TIA. What is the significance? It can lead to CRAO in future. So if a patient presents to us with a history of TIA, we cannot just write them off. What is cherry red spot? Why did it occur? Name 3 conditions which can give rise to cherry red spot. CRAO. Very good. In neonates. So there are many causes, but what we are already or what we are interested in is taxide disease and so on. So the classification will be for neonates or for elderly population, and you should be classifying for that. What are the other features of CRAO? Basically, sometimes you can have a diffuse retinal whitening or a focal retinal whitening or a peripapillary whitening. The peripapillary whitening indicates more severe of a disease. Significant of cilioretinal artery. These are a couple of patients seen by us. It can give rise to blood supply which can be preserved over a period of time for a widespread of the retina. Sometimes it can even spare the fovea, so which is a very good thing for the patient. You preserve cilioretinal artery and you have a very good functional outcome for these patients in spite of no treatment. Can embolus be visualized in retinal artery occlusion? Yes. Where all you will look for embolus? Very good question, a very good answer that you said yes, but where all you will look for? Very good. So start looking from the optic nerve head. You do a careful slit lamp biomicroscopic examination. Start looking from the optic nerve head. This patient had a Holland's plaque sitting at the optic nerve head in the clinic, had a BRVO, a hemiretinal type of arterial occlusion, and we manage accordingly. Patient had 6/6 vision now. So very important to look for the site, the stage, and the type of occlusion. Okay, 3 things which I told you initially in my talk. Branch retinal occlusions mostly remains the same, so let's skip that. Is what is combined occlusion? So you have a CRAO as well as CRVO. Sometimes they can, coincide with each other. What is the significance of knowing it, whether it's a combined occlusion or not? One is definitely visual acuity will be, diminished, but what is the other significance? Systemic comorbidities are very high. Okay, very good answer. So these are one of the patient who had a combined occlusion. We managed accordingly, well in time. The patient had very good treatment. Ophthalmic artery occlusion, more ischemia, more vascular changes, and so on. And what are the FFA findings, which just are basically non-perfusion? What are the other findings on OCT in CRAO? What is PAM? PAAM. It can be asked as a short note. Yeah. So it is nothing but a paracentral middle maculopathy, which can be patchy in origin. It involves mostly the inner retina in a patchy geographic pattern, and it cannot be missed clinically if you do a good careful clinical examination as well as an OCT. The significance here is it is mostly associated with optic nerve head edema. Okay. How do you manage a CRAO or a BRAO? Huh? How do we manage? Patient is sitting in the clinic. State paracentesis. Okay, what is the timeline in which you want to manage this patient? What is called as golden hour for CRAO management? On the arterial occlusion, 90 minutes. You can't go wrong in these things. Okay, your favorite questions of examiners. 90 minutes. Within 90 minutes, you have to, treat this patient. It's called as golden hour. Irreversible damage can happen beyond 4 hours if not treated. Various management options available. We need to look for systemic evaluation as well as ophthalmic evaluation and treatment. The principle here is dislodgement of emboli and also thrombolysis if possible, and reduce the intraocular pressure at any cost, even if the IOP is normal. First is ocular massage, then carbogen inhalation, that means in the plastic bag. Hyperbaric oxygen, debatable thing, but vasodilators, they do really work, and IOP lowering maneuvers by any means. What is ocular ischemic syndrome? It is a severe variety of syndrome, occlusion, which mainly involves anterior segment as well, and most common in patients who have a lot of systemic comorbidities. We'll just skip this. The only thing here we should be knowing is all these patients need carotid workup, so you should not be forgetting a systemic workup. Even if the cardiologist says there is a cardiac function is normal, you tell them that you need a good carotid workup for these patients. So this treatment is more or less remains the same. Recent advances, many things are happening in retinal imaging, more so for retinal vascular disorders. Basically, you want to look for peripheral perfusion, which includes vein occlusion as well as arterial occlusions, and also a lot of newer anti-VEGFs are coming, and multi-spot laser as well as yellow laser, microplast G6 laser, that is for glaucoma, because most often or not these patients do need management from glaucoma colleagues as well, and a lot of glaucoma drainage devices are also available. Just to summarize, always look for the question asked, whether it is in theory or in practical. If it is a case given to you, look for the stage of the case, whether it's fresh occlusion, chronic, resolved, and so on. Analyze based on the etiology. Just don't go and tell that, okay, this is a BRBO case. You need to know the etiology. If your mind is quiet, you will be able to see where is the site of occlusion, which vessel is involving, what is abnormality. Plan the sequence of questions and event as a flow chart, what can be asked. Look for differential diagnosis, investigations, and don't panic to further plan the treatment. The secret of your success is determined by your hard work and strong focus on your goal. Best of luck for your exams. Thank you for a patient hearing.
Any more questions to Manas? He already asked so many questions to you. Okay. Thank you, Manoj. It's very well presented.
Thank you so much, sir. Thank you.
Now we will call upon Dr. Vishal Agarwal. He will be presenting on age-related macular degeneration. And all the best.
Okay. So good evening and thank you Dr. Santosh and team iFocus for having me here. So I'll be speaking on age-related macular degeneration, ARMD, and it's a huge topic and many books have been written on ARMD and it's impossible to cover it in one presentation. But I'll be covering, very briefly the most important points that are part of your postgraduate curriculum and what you need to know actually. So first, about the definition. So AMD is a multifactorial disease of aging, with an interplay of etiologies like environmental risk factors and genetic susceptibility causing central visual loss. So when I say there's an interplay of many complex etiology, it means that we don't know much about AMD. We know more than what we knew before, but still many questions are unanswered. AMD is a huge problem. So 10 to 13% of adults over 65 years are affected. The global prevalence is now reaching 9%. And as the life expectancy is increasing, there is a 50% increase in the number of AMD patients by 2040 to around 288 million. So increased prevalence is associated with the aging global population. So it's a huge treatment burden disease. Broadly, there are two types of AMD, and most of the AMD, 85% is dry AMD, and the minority, like 15%, is neovascular AMD. But having said that, neovascular AMD accounts for 90% of the vision loss as opposed to dry AMD. As I told you, with the projected number of people is exponentially rising and is predicted to be around 288 million by 2040. And if you see the graph here, it's very interesting to note. AMD was supposed to be known as a Caucasian disease. Now you see the graph, the Asian population is shooting up. So the old myth that AMD occurs more commonly in the Western population is now going, and we have so many patients in the Asian population, being affected by AMD and with the end stage atrophical stage. Coming to the risk factors. So apart from the aging, we'll have to divide the risk factors of AMD into modifiable and non-modifiable risk factors. So race, Caucasians, Northern Europeans are more susceptible to AMD. Family history, first degree relatives at higher risk. So there is a genetic foci involving the complement factor H, which is implicated in progressing to AMD. Smoking is a very important modifiable factor. So it's said that smokers are around, at a 2 to 3-fold higher risk of contracting AMD than non-smokers. And if you see smoking, and if you see smoking for 20-25 years, the risk almost reduces to that of non-smokers. Again, light exposure, high UV light, more than 8 hours a day, diet, high intake of fat, and low antioxidants are other risk factors. So these all are modifiable risk factors. The non-modifiable are age, race, and family history. Coming to pathophysiology and types. So this, there are many trials in ophthalmology, in retina also, but few trials you have to memorize. This is one of them, the ARED study, age-related eye disease study. It's a very important landmark trial and it can be asked in your exams. And it classifies AMD into no AMD, which constitutes no drusense, early AMD, multiple small drusense, a few intermediate drusense. Small drusense, can anybody tell me the definition of small drusen by the size? Good. And intermediate? Exactly. And intermediate AMD is intermediate drusense or more than one large drusen, that is more than 125 microns. Now, if I ask, it's not a practical definition, how can you measure a drusen, 125 microns, 63 microns? Exactly. Which vessel? Near the optic nerve head. That's approximately 125 microns. So you can compare that size to the drusen size and classify AMD into early, intermediate, and advanced. So advanced is again classified into two, dry AMD and neovascular AMD. Dry AMD, the final sequel is geographical atrophy, and neovascular AMD is a plethora of spectrum like choroidal neovascular membrane, hemorrhagic detachments, hard exudates, subretinal fibrovascular proliferation, and finally the legally blinding condition known as the disciform scar. So again a pictorial depiction, early AMD, few drusen, intermediate AMD, the drusens increase in size, they coalesce, leading to geographical atrophy in the advanced stage, or culminating into a wet AMD, causing a CNVM, and finally a disciform scar. So the final end result in both the AMDs is a legally blinding condition, either geographical atrophy in dry AMD or a disciform subretinal fibrotic scar in a wet AMD. Early AMD, multiple small drusens, intermediate AMD, multiple small drusens with the intermediate side drusens, and advanced AMD, the left side picture shows a geographical atrophy, also known as now C-RORA. Can you tell me the form of C-RORA? Excellent. And disciform scar in the case of neovascular AMD. So dry AMD consists of drusens, wet AMD, drusens plus CNV lesion. The prevalence is more in of dry AMD as compared to wet AMD. The disease progression is slow and insidious in dry AMD, whether in comparison to wet AMD, where it is acute and there is a rapid loss of vision because of the involvement of the foveal center. And the vision loss, as I told you before, is more percentage of patients is in wet AMD. Treatment, no approved therapies to reverse geographical atrophy at present is there, and we have a plethora of injections as been discussed in the previous presentations, the anti-VEGF agents for wet AMD. So this is very important now. What is causing? We are all aging. I'll age one day, you will age one day. Why some people are getting AMD, why some people are not getting AMD? So there are multiple factors involved. So it consists of oxidative stress, aging, inflammation, and the final culmination is hypoxia and VEGF release. So aging, what happens is the melanin decreases, there is photoreceptor loss, there is increased buildup of liposkin in the RPE. Then there is increased thickening and the lipid content also increase in the Brooks membranage, leading to basal linear and basal lamellar deposits. Combined with the oxidative stress because of aging, it leads to formation of radical oxygen species like H2O2, and with additional insults like environmental pollution, smoking, and UV light. Now what this all leads to is a photoreceptor loss, leads to inflammation, compounded by cytokines like IL-6. Then it leads to hypoxia, and hypoxia leads to a localized increase in VEGF expression in the retina, which finally leads to angiogenesis. Now, normally, angiogenesis also occurs, but the turnover of endothelial is many days, many months. And there is a dynamic equilibrium by TNF and PEDF as compared to VEGF. But when this dynamic equilibrium is changed in the favor of VEGF, that is the positive regulators, the endothelial cells will undergo rapid proliferation within a matter of few days during a spurt of angiogenesis. And that leads to choroidal neovascular membrane. So there is activation of endothelial cells, there is basement membrane degradation, there is increased vessel permeability, and then VEGF is secreted, which leads to increased permeability, increased proliferation, and increased inflammation. So there are many types of VEGF A, B, C. VEGF A is the most important, and the receptors, the most common, the most important are VEGF R and VEGF R2, R1 and R2. And binding of VEGF A to the receptors starts the process of angiogenesis. So that is the basic pathology. And so all the treatment based is based on this pathophysiology, that VEGF is the target for the treatment of neovascular AMD. So because neovascular AMD involves the growth of abnormal new blood vessels into the subretinal space and RPE. So it is the major factor promoting angiogenesis and vascular permeability, not just in neovascular AMD, but also in diabetic retinopathy. So as I told you, you should know the VEGF isoforms, and VEGF A consists of 165, 111, 121, etc. And the major function is angiogenesis. So the recap till now is AMD is the leading cause of permanent visual impairment in older people. And as the age increases, it increases in the magnitude, and people more than 65 years of age are more susceptible to people who are more than 50 years of age. Neovascular AMD causes vision loss due to abnormal blood vessel formation, and which is a minority of patients, but majority of the vision loss magnitude. And VEGF A is a central molecule in the angiogenic cascade that leads to the neovascularization and increased permeability. So diagnosis and classification of neovascular AMD. So what is the gold standard of diagnosis of neovascular AMD? What modality? OCT. But before OCT was invented, which was only in the recent past, we had many other investigating modalities also. So you don't directly jump to the OCT. You first do a vision assessment of the patient, right? You check the visual acuity, you check Amsler grid for the patient, and then there is retinal imaging, which again is subdivided into invasive and non-invasive modalities. Invasive is angiography and indocyanine green angiography. Non-invasive is OCT and OCT-A angiography. So visual acuity is very deceptive in the case of neovascular AMD. Even advanced form of AMD might have a good vision, even 6/9 and 6/12 vision. So you cannot always rely on the composite visual acuity on a Snellen chart. So more specific test is Amsler grid. So these are square math type charts, and you can just tell the patient to draw the line across it, and it's very good for home monitoring also. So the patient who is one-eyed or who has AMD in one eye and low vision, and you have to save the other eye, you tell him to or tell her to draw these line across these parallel lines, and if there is a distortion, the relatives can see them. He can show you to you in your next visit, and you can see that there is a progression of AMD in these patients. So abnormal lines are shaded or distorted and a precursor of AMD progression. Coming to FFA, so before OCT, we used to do FFA in all cases of AMD. Now we are doing FFA very exceedingly rarely because it's an invasive test, and OCT gives much more information. But because the treatment previously, before the anti-VEGF era, was based on FFA patterns, because there was no anti-VEGF, so the primary modality was laser, and we could not do a subfoveal laser. So on FFA, we used to see whether the lesion is extrafoveal or juxtafoveal. So on FFA, we can identify the neovascular area and the area of the leakage, and interpret the pattern and the timing of hyperfluorescence. So there are three categories. Extrafoveal CNVM is beyond 200 microns to 2500 microns from the center of FAZ. Juxtafoveal is within 200 microns in the center of FAZ, and subfoveal is the geometrical center of the FAZ. Coming to the second classification, there is a classical CNVM and there is a occult CNVM. So classical CNVM, where the lesion size is defined, it hyperfluoresces very early after the injection of the dye. There is a definite size which increases in the size and the intensity during the course of the injection. So that area is the lesion size, and if it is more than 50%, it is known as predominantly classic. Minimally classic if the area of the lesion consists of less than 50% of the classical CNVM size. What is occult? So occult is where there is no definite lesion and there is a late leakage, there is no early hyperfluorescence, and that late leakage is not from a definite source. So in classical, you see a definite source of leakage, it hyperfluoresces, it increases in size, it increases in intensity. In occult CNVMs, in FFA, you don't see hyperfluorescence in the early stages, you will see hyperfluorescence in the late stages, but the definite source will not be seen. A perfect example of occult CNVM, and here you can see the early phases of FFA, there is no leakage. In a very late stage phase, you can see some leakage, but still the membrane cannot be seen, because the membrane is behind the RPE. The membrane will only be seen on FFA in the early phases when the membrane is in front of the RPE. Okay? Classical CNVM, the lesion size is visible, the size is visible. You can see it clinically also. FFA just confirms it. There is hyperfluorescence with a lacy pattern in the early stage. The intensity increases with time. The size increases with time. Okay? So this is a classical, and this is in front of the RPE. Coming to the optical coherence tomography. So what used to be called as classical and occult is now called as type 1 and type 2 in the OCT classification. So when the anatomical location is below the RPE, which was occult in the FFA classification, is now known as the type 1 CNVM. So type 1 CNVM of OCT is equivalent to the occult CNVM of the FFA classification. So the membrane is behind the RPE. When it is above the RPE, it is known as the type 2 CNVM, which is equivalent to the classical membrane of the FFA classification. Okay? And there is a type 3 classification also known as RAP, retinal angiomatous proliferans, which is within the retina. This is an example of type 1 CNVM. You don't see a hyperreflective lesion above the RPE. There is fluid, and this is occult CNVM of the FFA classification. Here you can see a hyperreflective lesion above the RPE, and this is equivalent to the classical membrane on the FFA classification. This is type 2, this one was type 1. And these are associated with pigment epithelial detachments also. So pigment epithelial detachments are classified according to the content they contain. They can be serous, that is fluid, fibrovascular, drusenoid, or hemorrhagic. So these are the various forms of PED. So when you have a hypo lesion on the OCT, it is a serous PED. When you have a hyperreflective lesion on the OCT and a drusen, it's fibrovascular PEDs, drusenoid PEDs. And we have a heterogeneous reflection on the OCT is a fibrovascular PED. So in general, serous PEDs carry a good prognosis after anti-VEGF as compared to the fibrovascular PEDs, because the fibrovascular PEDs are associated more with occult CNVM. So occult CNVMs are in general more susceptible to progression to disciform scar as compared to, exactly. A newer modality, OCT angiography, it's picking up. It's still very expensive. Not many centers have it, but it's an excellent tool, at least for macular lesions. It's a novel dye-less imaging system. It enables visualization of the blood flow in the retinal and choroidal vasculature, and you can segment different layers. The retina can be segmented into 2 to 3 layers, the Brooks membrane area, the choroid area, and you can see the lesion in the choroid capillary in the third photograph towards the left, that there is a vascular network. And it's very useful in following up the patients after anti-VEGF therapy, whether the vascular network is there, whether there is a trunk formation. So OCT angiography is an ancillary test, a newer modality test you should all know. There's no need to go into detail at your level in this. Coming to a variant of neovascular AMD, it is PCV, and you should all know about polypoidal choroidal vasculopathy because it is now very common. It is very common, and almost 50 to 60% patients diagnosed with neovascular AMD in the Indian population are actually PCV. So pathogenesis remains unclear, and there is a branching vascular network. There are terminal aneurysm dilatation at the border of these vascular networks. Coming to the OCT feature, as I told you, type 2 CNVM we know, type 1 CNVM we know. In PCV, polypoidal choroidal vasculopathy, there is a thumb-like elevation of the RPE, and you can see the RPE duplication. So these are signs on the OCT which point the diagnosis towards PCV. There are certain diagnostic criteria. You can see the PCV picture here, and towards the left it's a treated PCV, towards the right it is the untreated PCV. So there are reddish orange subretinal nodules, maculopathy, serosanguinous, and hemorrhagic PEDs. This is the ICG, which shows grape-like clusters of PCV. Coming to the management, there is a long history. It went from laser to PDT to anti-VEGF. Coming to photocoagulation, as I told you, photocoagulation, the FFA classification of CNVM was based on photocoagulation. So when there was a juxtafoveal or extrafoveal membrane, you used to treat with photocoagulation, but now it is no longer used. Coming to photodynamic therapy, you used to inject a dye known as vertiporphin and used to irradiate it with the 689 nm laser light, which used to create a highly reactive oxygen molecule, which actually thrombosize the subretinal choroidal vasculature, leading to the reduction of the lesion size, but rarely resulted in significant improvement in visual acuity. It was used in IPCV, but right now the dye is not available anywhere, so we have stopped using PDT. Coming to the mainstay of therapy, the standard of care, OCT and anti-VEGF therapy together have revolutionized the treatment of exudative ARMD. I'll not go into the details because many presentations prior to me have discussed all these molecules, but you should know that approximately 6 molecules have been FDA approved for the treatment. 6 out of 4 which are available in India. So ranibizumab was approved in 2006. It's a monoclonal antibody fragment. Bevacizumab is not yet approved. It's an off-label indication. It again is a monoclonal antibody. Aflibercept was FDA approved in 2011 for the treatment of ARMD, and it is a fusion protein. Brolucizumab more recently in 2019. It's a single chain antibody fragment. You should know the names, you should know the approximate half-life and the action, whether they are active against all VEGF isomers, selectively active, and what is the dosage. I'll not go into the details of these tables, but you should know about the most common anti-VEGF agents used. And you should know about the latest drugs also. So this is Vabysmo, this is faricimab. It has been approved for AMD and diabetic retinopathy. And it is the only drug which acts against 2 molecules, the VEGF and the angiopoietin 2 inhibitor. It is yet not available in India, but it's very soon going to come into India, and it's manufactured by Genentech. The second newer drug for ARMD is Susvimo. Anybody knows about Susvimo? It's a PDS. It's not intravitreal, it's a PDS. It's a port delivery device system. So a short surgical procedure injects this port onto the sclera, and it's a reservoir. You fill the reservoir with ranibizumab, and it requires refilling every 6 months. So this is Susvimo, and there are many emerging treatments in the pipeline specifically for dry AMD. And you should know about some pivotal, the landmark studies like the TAP study, the CAT trial, only the names and the final conclusion. You don't need to go into details of these trials. And the supplementation we used for dry AMD. Now specifically we use the RS2 formulation, which has incorporated lutein and zeaxanthin. Previously beta-carotene was there in the RS formulation. Now beta-carotene has been deleted because of the risk of lung cancer. And in place of that, lutein and zeaxanthin have been incorporated. Finally, 2 questions for the residents. You will pass with flying colors if you answer questions about ARMD, but you will get the gold medal if you answer the following questions. Which FDA-approved treatment for neovascular AMD was recalled recently by the manufacturer? PDT? No, it's not recalled. The dye is not available. Nobody gets a gold medal. It's the PDS, the port delivery system. So the FDA did not recall. The manufacturer recalled it because of some problem with the efficiency of the drug delivery system. So it's still FDA approved. The FDA has not recalled it. But right now, it is not available for the short duration of time. Second gold medal question. Which novel therapy has been recently FDA approved for geographical atrophy? Recently. 1 month back. You are already passed. These are gold medal questions actually. बोलो क्या होता है ये अभी गूगल किया है ना तूने So FDA approved Safover, it's pegcetacoplan. It is the first and only treatment of geographical atrophy. It is a complement factor 3 inhibitor, and it reduces it will not reverse of course GA. It will reduce the progression of GA by around 20%. Thank you so much for your time.
Wonderful, Vishal. Covering the entire ARMD in 20 minutes is a huge task. Any questions for Dr. Vishal? I think there are no questions. So thank you so much, Vishal, once again. And with this, we'd like to conclude the session. We are overshoot by 1 hour, but we were given session 1.5 hours late. No problem. Thank you, Rolika, for the kind invitation. Thank you so very much once again.
Thank you so much. Thank you, sir, for actually managing and covering up the time. Thanks a lot. So we move on to our next session without any delay, and that is the Retina 3 session. And for that, may I request the chairs for the session, Dr. Atul Kumar, sir, and Dr. Dinesh Talwar, sir, to please join the dais. And Atul Kumar, sir, is an internationally acclaimed vitreoretina surgeon, and with extensive research experience, and he has been a very important part of RPC, and he has dedicated his entire career to RPC, and now he has his own institute, the AKI Institute. And welcome, sir. And Dr. Dinesh Talwar, sir, he has been a very important part of iFocus online as well. Thank you so much for being our backbone and our lifesaver at all times. So, and he is a vitreoretina consultant at CFS Delhi, Safdarjung Enclave. So over to both of you, and I request Dinesh sir to please take up the talk on retinal detachment, followed by decoding dilemmas in DME management in India. Over to you, sir.
So, late good evening. I know it's a little late, but as Rolika said that we have a little time problems. So now Dinesh is going to speak on retinal detachment, a very important topic. He's going to talk primarily of rheumatogenic retinal detachment, because that's a type of retinal detachment which you see as postgraduates and which you should know as for theory and as practicals. You should master indirect ophthalmoscopy, because until you master indirect ophthalmoscopy, this amount of reading from the book will help you. So please learn indirect ophthalmoscopy, and that means hours and hours of in the ward or in the outpatient. So Dinesh, are you ready? Yeah, okay, so Dinesh is getting ready, and I have taught postgraduates all my career, So maybe thousands of them as junior residents and senior residents in RP Center. I was a GR myself in RP Center, and then I became SR faculty, and I rose to become the chief. So I love teaching, and I enjoy others, watch others speak also. It's both ways. So Dinesh, please, we are looking forward to your talk.
Thank you, Atul. Since we are running out of time, we will not waste any time on preliminaries. Let's go straight to the topic. The topic was retinal detachment, and the first question is, what is a detachment? So a detachment is a separation of the inner 9 layers of the retina from the RP. Now the second question is, why does it occur? Well, basically during embryological development, the outer RP formation occurs from one layer of the optic vesicle, and then the optic vesicle is actually, it goes inside and then forms the eye, right? Now, so one layer of the optic vesicle is the RP, the other layer is the other 9 layers. So there's a potential space in between, and that's why there's always a chance of getting a retinal detachment. So what keeps it attached? Well, there are a number of factors. The first one is anatomical factors. Both the retina and the RP provide substantial resistance to water movement, so it doesn't come from either side. The intact vitreous gel plugs even retinal holes, so that also prevents the occurrence of retinal detachment. It's very important in buckling. In a buckling procedure, this plays a role. The most important factor is a metabolic factor. The RP pump, and this is important to keep in mind, can pump fluid at the rate of something like 0.3 microliter per hour per millimeters of RP. Now that translates, if you look at the total RP, which is around 1000 millimeters square, you have something like 300 microliters per hour, or 5 microliters per minute. That means it's more than double the aqueous drainage. So it's a huge amount of fluid that can be taken away from the RP, and that is the most important factor for keeping the 2 layers together, the 2 sets of layers together. And then you have physical factors. The outward movement of the fluid pushes the RP, the retina against the RP, and even there's a very small pressure difference in the neighborhood of 0.5 into 10 to the power minus 3 millimeters mercury. And this is sufficient to generate force to keep the retina firmly fixed against the wall of the eye. And last of all, you have the interphotoreceptor matrix, which is sort of, it's a sticky thing. It stretches markedly before it breaks, and as long as it's dehydrated, so as long as there's no fluid there, it will keep it stuck. And this is a combination of fibronectin, integrins, mannose, and all these things which keep this interphotoreceptor matrix there and keeps the retina stuck to the RP. Now what happens is, when there's a break, that area gets exposed and that area gets hydrated. As it's going to get hydrated, its stickiness will go away, and that's why the retinal detachment will start occurring in the area where there is exposure, where there's a retinal hole. Now, basically, a retinal detachment occurring is the result of a tug of war between the forces trying to keep the retina attached and those which are trying to detach it. On one side, you have the vitreous traction, which is pulling it off. The other side, you have the RP, POM, the interphotoreceptor matrix, the intact retina, all of which are preventing this entry. Now, all it needs is a hole. You get a hole, and now you've got fluid coming from the vitreous into the subretinal space. And as I said, the interphotoreceptor matrix will get hydrated, the fluid will keep on collecting. The RP pump will no longer be able to pump out the fluid at the rate at which it is coming into this subretinal space. So, you close the brake and the retina will settle. But there are different types of retinal detachments. You have, this was a rhegmatogenous retinal detachment, where the retinal brake allowed the fluid to go from the vitreous cavity into the subretinal space. But you can also have brute pull. The vitreous can have traction which can actually strip the retina off from the RPE by overcoming the adhesive forces. And finally, so one, you have brute force pulling it out, and the third, you can have fluid being pumped into the subretinal space by inflammation and tumors and all those things which can cause an exudative detachment to occur. So you have 3 different types. We want to differentiate that. We'll discuss that later on. But what are the symptoms that a patient of retinal detachment will come with? He doesn't come with anything written there कि मेरे को detachment है. He comes with either diminution of vision, which could be sudden onset, or sudden detection. Keep this sudden detection in mind. You know, if it's a very old detachment, patient not picked it up, say vision was poor from before only. You know, one day he closes the other eye and finds, hey, मुझे तो दिख नहीं रहा. Now suddenly you find, he says, no, I have a detachment, अब भी पता लगी है. But his visual prognosis is going to be very poor. So this historical fact you need to figure out. Is this sudden onset or a sudden detection? The second important thing is flashes. Now flashes are a sign of mechanical stimulation of the photoreceptors. It doesn't mean detachment. It means detachment can occur. Now you need to differentiate retinal flashes which are unformed, intermittent, like either like lightning or like, you know, something like this, or they are like sparks of light, right? So what happens in that? Now look, if you just to show you this, yeah. So if you look carefully, you'll see a chingari going. It's like, you know, a matchstick being thrown, just a flash, right? Now that is, these are unformed. These are retinal flashes, retinal photopsia. This is unlike a neurological flash, photopsia, which we'll discuss. The second thing is floaters, which is a sudden onset, often a shower. It's not one floater which I have for the last 1 year. No, that's not a floater. That's not relevant. The other thing is field loss. Field loss is a definite sign that there's a problem happening and probably retina is getting detached. And last thing is a veil-like sensation when a patient actually has some kind of a bullous detachment. You see, he sees this veil. So flashes, floaters, veil-like sensations, these are all signs of which suggest that there may be a rhegmatogenous detachment. Yeah. Now you can also have neurological flashes, and it's very important to differentiate that, because the visual pathway, if it's irritated, it can cause a flash which is regular, lasts for some time. It's like focal area of light or dark which maintains its relationship to the eye movement because it's within the visual pathway. So how will that look like? That will look something like this. It will be as comes, goes, comes, goes, comes, goes, stays for some time. This is actually a seizure, but there is no loss of consciousness. The patient could have headache after this finishes off. So be very careful to differentiate this from retinal photopsia. Now, what about examination of the anterior segment? You have a patient whom you're suspecting a detachment. It doesn't mean कि anterior segment में नहीं देखना है. You obviously want to check the visual acuity. If the PR is inaccurate, that doesn't normally happen in a detachment. PR inaccurate means either very long standing or some nerve involvement. Check if there's a trabeculectomy bleb, because that will affect how you manage the patient. Check for presence of scleral thinning. If there's a recent cataract surgery, you want to check the wound integrity. Cornea, is it clear or not? Angle, you want to rule out angle recession because it could be traumatic in nature. Again, for the pupil, look for sphincteric tears or anisocoria. Again, suggests you that this could be traumatic in nature. You want to see the degree of cataract. Depending on your visualization will get affected. If the patient is pseudophakic, you want to see the posterior capsular integrity, and if there is a rent, you want to see, is that smaller or bigger than the optic? If it's bigger than the optic and you put silicone oil, it could come anteriorly. So you want to know that. Or is the patient a phakic? And finally, the intraocular pressure. If the pressure is low, the patient may be having an associated choroidal detachment, changes your management. Or if it's very high, it needs to be managed. And it could also be a patient of glaucoma, but while there is a detachment, glaucoma may still be controlled. Now, you want to differentiate, as I said, an exudative detachment from a rhegmatogenous detachment. The most important thing is, if you see a tear, now you're dealing with a rhegmatogenous detachment, baat hi khatam ho gaya. Supposing the patient's, if it's an exudative detachment, it's a convex, bullous, smooth surface, whereas it's corrugated surface if it's a retinal rhegmatogenous detachment. Shifting of fluid is usually a characteristic sign of an exudative detachment, though some rhegmatogenous old detachments can also have shifting fluid. And Schaffer's sign, presence of pigment in the retrodental space, is characteristic of a rhegmatogenous detachment. Now, if you see a detachment like this, these corrugations are there. Even though it's bullous, you know, this is a rhegmatogenous detachment. You find a break, obviously it's rhegmatogenous. This kind of smooth, bullous detachment coming to the back of the lens, you see here there are some vascular anomalies. This is a exudative detachment. And finally, you could have a tractional detachment where it's just pulled off. Now, what is happening here? Here you see concave surfaces. So you have concave surfaces in between and pulled up surfaces in between. So this is a tractional detachment. Finally, you also want to differentiate it from a senile retinoschisis. A very old RD can be confused with a retinoschisis. And a retinoschisis is what? It's a splitting of the outer plexiform layer of the retina. It's an incidental finding, maybe bilateral in many cases. The two types, typical, which is a shallow elevation of the inner retinal layers, or a reticular form, which could be more bullous detachment. The important thing is the inner layer could look like beaten metal, as you see over here, or it has a pitted kind of appearance, minute glistening spots, and you can sometimes have large rolled posterior outer holes, as you see over here. So this is a retinoschisis. Now, how would you differentiate a retinoschisis from a detachment? The most important thing is, of course, Schaffer's sign is not there. The retinoschisis is almost transparent. The retinal detachment is more grayish. The retinoschisis is taut, smooth. But most important, you can't approximate the outer layer of a retinoschisis to the inner layer with scleral depression. So you know you're not dealing with a detachment. The other thing is you can do a laser inside a retinoschisis. You can't do that in a retinal detachment. And with a retinoschisis, you get an absolute field defect, where it's a relative field defect with progressive increase in its intensity in a detachment. So you can differentiate them. Now, once you've done this, the next thing is, what do you do when you have to approach the management? The first thing is you need to find where the break is. हमने बात किया था, you find a break, you close the break, your work is done. So first thing is look for the break. So what are the tips for looking for the break? Well, they were given by Linkoff initially, and we formulated some more after that, and that helps you to decide where it is. Because this closing of the hole is crucial, right? You close the hole and the retina will settle. So if you have a hole, if you have a total detachment or a superior detachment that crosses the midline, right? Now the position of the break in this will be in a triangle which is between the 12 o'clock position and at the equator 1 clock hour on either side. Okay, it's there in more than 93% of cases in this position. Now, if it's a superior detachment, either nasal or temporal, it will be on 1 clock hour, 1 to 1.5 clock hours, close to the nearest superior border, right? If you have an inferior detachment, wherever the detachment is higher, on that side inferiorly, you will find the break. And if you have an inferior detachment which is bullous, the chances are your primary hole is above the horizontal meridian. And finally, if you have an inferior shallow detachment equal on both sides, probably it's around the 6 o'clock. And if it's an inferior bullous detachment with equal bullae on both sides, look for a passage from the sides coming with a break somewhere at 12 o'clock. So you know where to look for that. The second important thing you want to see is the classification of proliferative vitreoretinopathy, because this will affect the management approach as well as the prognosis. So the old classification used to be A, B, C, D. A was Schaffer's sign, B was partial thickness retinal folds seen as corrugations in the retinal surface. C1 to C4 was star folds in 1 to 4 quadrants, and D1 to D3 was whether disc is visualized or there's a narrow funnel or you're not seeing it at all. And that's not because it's bullous, but it's because it's being pulled in because of proliferative changes. However, the newer classification is more accurate. It tells you about the degree of clock hours of involvement, and it tells you whether it's anterior or posterior. So you have circumferential, perpendicular, and anterior loop traction. Circumferential is when around the posterior vitreous base, you have it folding up. So what will happen when it folds up? It will cause irregular radial folds, right? If it's pulling into the center of the eye, what will happen? You'll get a perpendicular fold. Perpendicular traction will cause a circumferential fold at the posterior vitreous base. And when you have anterior loop traction, what is happening? From the posterior vitreous base, it's pulled anteriorly. So what happens? You have a circumferential fold, but which is being pulled into the periphery, and there's a peripheral anterior retinal trough with the posterior stretching of the ciliary processes. This is just to show it diagrammatically. This is anterior loop traction. You see this is circumferential fold, and it's being pulled anteriorly. When it's pulled anteriorly towards the aura, what will happen? You get this trough in the middle, and these are the vitreous fibers pulling it up. Now, if let's see the perpendicular traction, you see this area? This is all being pulled towards the center, perpendicular traction. And finally, you have this radial fold because of circumferential traction. And of course, a star fold if it's just pulled into the center. I'm just going to show you this now look carefully, you'll see this. Now I'm going to stop it here. Now you see this is actually perpendicular traction. There's this membrane which is going right into the center. We're cutting that. And as we cut that, you'll see that there are radial folds. You see these radial folds because there's also circumferential traction there, right? So because of that, you can see the circumferential traction also. And now, as you remove this, now at the posteriorly, at the disc, there is the membrane which is pulling the entire retina back. Now you pick it up and remove it, and you see that D3 configuration we were talking about. There is no disc visible, no? Now it's visible because this membrane has been removed. And the last thing is, of course, the anterior loop traction, which we are not going to be able to show just now, right? Now, so as I said, you can have focal traction because of star folds. You can have diffuse folds which are pulling the posterior retina down and you can't see the disc. Or you can have a subretinal band which causes either a napkin ring or it can cause a clothesline kind of appearance. But you only remove subretinal bands when they are causing traction. When they are preventing retina from settling down. So this is just a small, just to show this. You see there's a subretinal band. You put PFCL and you find that it is not settling down. It's causing a clothesline appearance. So you just make a small retinotomy and remove this. And that's it. And that removes the traction, right? So let's go ahead. Now basically the management of retinal detachment is on mathematically precise principles, and most of it is measurable. So it's a completely objective way. There's no subjectivity here. What is the objective of our treatment? Temporary closure of the retinal break. You close the break, the fluid will go away. But unless you find a way to keep it closed, it will open up again. So the second thing is to create an adhesion between the RPE and the inner 9 layers. Now how can you do that? Either with laser or cryo. So this will allow the retina to stay settled permanently. So final adhesive strength usually occurs by 2 weeks, but initial adhesive strength can occur within 24 hours with a laser, but takes a few days with cryo. So cryo is a little longer time for it to become adherent. Now, what are the ways of tamponading the break? You can either use pneumatic retinopexy, where the gas which you inject tamponades the break. You can use a scleral buckle, where the RPE moves forward, that posterior layer moves forward, and the vitreous from the other side plugs the break, and now you have an attachment. Or you can do a vitreous surgery which permanently removes your traction, and the gas or silicone oil is used for tamponade. Now, what are the different types of traction need different management. If you have circumferential traction, it will cause a radial fold. How do you manage that? If you're doing a buckling, you need a radial buckle. If you're doing vitreous membrane removal, vitreous surgery, in any way it will unfold. If you have perpendicular traction, then you need the encircling band. The encircling band will make the entire circumference less, so you will get decrease in the perpendicular traction. Or with vitreous traction, with vitreous removal, vitreous surgery, you just remove the whole vitreous. Finally, if you have anterior loop traction, there are various ways. You can do the buckle, which will also shorten the antero-posterior diameter. You can do scleral imbrication. That also does the same thing. Or you can do a vitreous removal. Sometimes even that doesn't happen. You're not able to remove the vitreous. You may have to do a retinectomy. And that's the last thing that you do for managing this traction. What are the advantages and disadvantages? How do you decide which procedure? You want to weigh what is the advantage, what is the disadvantage. So with buckling, the advantage is it's primarily extraocular, no effect on the lens, so no cataract will develop. Disadvantage is you can have accidental perforation of the globe during suturing. You will have a myopic shift. You will have buccal related risk like a buccal infection, very rarely even a CRAO. You can have, and then you have, most importantly, the risk of SRF drainage, like in retinal incarceration or subretinal hemorrhage. What are the advantages and disadvantages of VR surgery? Well, the advantages are it's a completely controlled procedure, tackles the primary pathology, as you saw, actually निकाल दिया, जड़ से निकाल दिया सब कुछ. Risk of subretinal hemorrhage is negligible, incarceration risk is zero, distortion is minimal, no buccal infection. But the disadvantages are it can cause a cataract in phakic patients. If you put silicone oil, that needs to be removed. And if you have gas, patient can't see for a month. And rehabilitation is going to happen only after that. Now, there are certain situations where vitreoretinal surgery you may use as a procedure of choice. And what do you do in that? You do internal removal of the traction by the vitrectomy. Sometimes you will use an encircling band to support the posterior vitreous base. You use either gas or silicone oil for internal tamponade, cryopexy or laser or both for permanent adhesion, and you remove the silicone oil if it's been put after 2-3 months. Some additional procedures you may do, which will, depending on some other factors, like if it's phakic, you would definitely may consider putting a band so that you need to do less of an anterior vitrectomy. If you're putting silicone oil, you need to shave the vitreous very close to the surface. You don't need to be that that aggressive when you're using gas. And you can use a 360-degree broad band of barrage laser or cryo in place of a band, but there is a claimed effect that this will cause more epiretinal membrane proliferation. So many people would like to avoid that. Now, if your break is anterior, buccal. Posterior, VR surgery. Few small breaks, buccal. Giant retinal tear, vitreoretinal surgery. Shallow detachment, buckling is adequate. Bullous or very severe PVR, vitreoretinal surgery. So these are the factors which determine what you will do. If you have a patient who's pseudophakic or a phakic, very often nowadays we will prefer vitreoretinal surgery. Now, you have a patient who's phakic, he's got a peripheral break anterior to the equator, moderate height of RD, not too much hypotony, and the 3 or 6, 9 o'clock meridian are involved in the RD. I would prefer to do a buckling procedure. So this is one place where I would consider buckling as the most indicated procedure. On the other hand, even if the patient is phakic, but if he has posterior breaks or a giant retinal tear or bullous detachment or a lot of hypotony, I would prefer to do a vitreoretinal surgery. For buckling, I modified the sequence of steps, but more or less you will put the encircling band and buccal sutures, then place the band and the buccal below the sutures without tightening, do your SRF drainage, tighten the band, tighten the and do the cryopexy, tighten the buccal sutures, and finally adjust the tightening of the encircling band, which is around less than 15% tightening, so that you have around 2 millimeters of indentation with the scleral encircling band, and then you close the conjunctiva. Which substitute to use, oil or gas? Well, the importance of gas is that it doesn't need removal, but there's post-operative very poor visualization and late rehabilitation. With oil, the vitreous removal has to be complete, otherwise you could get precipitation of more PVR. It needs removal, and it cannot tamponade in the shadow area of a pre-existing high buccal. So you have to keep this in mind. Surgical outcomes are in the neighborhood of 90% or more. The macular status is the most important predictor of the attachment rate. It's more than 99% if the macula is on. patients who've got a duration of more than 1 week of macular detachment will have less chance of getting a vision of more than 20/50. Success rates of 618 or more occur in 50% of or more of anatomically reattached eyes which had a macula of RD. When do you use a prophylaxis? So you know lattice, holes with operculum, horseshoe tears. When do these need a prophylaxis? Well, if the patient is symptomatic, has flashes, has acute onset of floaters, not that occasional floater floating around, it's an indication for treatment. Patient has a fellow eye of RD, needs a prophylaxis. A family history of RD, again needs a management. And other additional risk factors include myopia of 6 to 10 diopters, definite presence of traction, like for example horseshoe tears, or fluid already developing around a hole, equatorial or more posterior location of breaks. These are more likely to progress, and perivascular lesions again have more traction. Ladies and gentlemen, early detection of a detachment, early detection of predisposing factors allows optimum management, which is the key to optimizing outcomes in patients with retinal detachment. And that is what is important for all of you to keep in mind. Thank you very much. Should I start the other lecture, Atul?
Dinesh, we'll continue with you. You can have your water if you want. And you'll be talking on decoding dilemmas in DME management. So you want to tell us about DME management, what kind of dilemmas you have, and how do you solve those dilemmas?
Okay, thank you, Atul. You've heard about DME, diabetic retinopathy, protocol T. Let's come to what are the problems that we face day to day, which we want answers to. This is my disclaimer, and this is the financial disclosure, which is relevant over here. Now, the issues for us is genesis of diabetic macular edema. Why does it occur? What are the dilemmas I face as a treating physician? And can I predict the response to treatment? These are some of the things. Now, genesis of DME starts with hyperglycemia, which affects the polyol pathway, the advanced glycation end products pathway, protein kinase C pathway, and the hexosamine pathway, all of which together cause oxidative stress, inflammation, vascular dysfunction. So ultimately, the multifactorial approach is needed, because now, why are we getting DME? One is upregulation of VEGF production. Second is basement membrane thickening and loss of parasites, which cause loss of autoregulation and consequent hydrostatic effects. So it's not just VEGF, it's also hydrostatic effects. And finally, there is also a neural degeneration with apoptosis of the ganglion cells going on at the same time. So if you don't address the root cause, you're not going to get optimum results. So hyperglycemia, which is that root cause, needs to be addressed. And so it's not just blood sugar, but also the blood pressure because of the hydrostatic effects and the lipid control. All these things need to be kept in mind if you want optimal results. The second issue is, nowadays we say all lasers are obsolete. Are lasers obsolete? This is a myth which came based on this particular graph, which said deferred laser had better response compared to patients who had prompt laser along with anti-VEGF treatment. Now, keep it in mind that when you talk of center involving diabetic macular edema, right? The leak doesn't have to start in the center. The leak could start in the periphery also. For example, if you have a patient like this, right, the leak could start here. If the leak starts here, it's more than 1 disc diameter away from the foveal center. Can't it be lasered? It can. Am I speaking from my hat or just Anecdotally, no. The Restore and the Protocol I both showed that almost half the patients actually were amenable to focal macular laser. So keep this in mind. Now, the other thing you need to keep in mind is that it is not focal macular laser which caused the problem. You see, focal macular laser, no difference in response between early laser with anti-VEGF and deferred laser, no difference. But if you had diffuse diabetic macular edema where a grid would have been done, huge difference. So it is the grid which is a problem, not focal macular laser, and it's not laser per se which is an issue. So keep it in mind, focal macular laser does not influence the outcome negatively and may actually decrease the number of injections. The second important thing is you have patients who are not responders. Keep it in mind. It's been shown very often they have huge amount of peripheral capillary non-perfusion. Now, the protocol has showed that in patients with diabetic macular edema with PDR, when you gave only monotherapy, you needed 9 injections. And you combined PRP with the injections, what happened? The number of injections became half. The strongest possible data we have which says that maybe PRP can decrease the need for anti-VEGF treatment in DME when there are a lot of areas of capillary non-perfusion, because that is what is there in PDR patients. Then comes the question of which anti-VEGF to use and how. So before we come to that, the first thing is everyone says, oh, patients come with DME, immediately give the injection, give the injection. Is that so? No. Waiting for up to 1 year in the Restore and Protocol I, and then starting PRN treatment, in 3 years, all the groups were in the same group. Same outcomes. So no difference whether you wait up to 1 year. But then we have the Rise and Ride study, which showed if you wait 2 years, then the results are not as good. So there is no urgency. But it is not that you have to run after the treatment immediately, but you don't want this to delay beyond a few months. You definitely don't want it to delay 2 years. If you delay more than 1 year, between 1 to 2 years, the chances are the results will become suboptimal. Now, which anti-VEGF to use? So basically, if you see that the protocol T, it said, well, aflibercept was better than ranibizumab. But if you see further, over time, that difference became less. If you see patients with good visual acuity, better than 612, it made no difference whether you gave any of the anti-VEGF agents, they were all equally good. But in patients who had poorer vision, yes, aflibercept seemed to be doing better. But more importantly, in patients who had good visual acuity, those who got aflibercept or who got ranibizumab, there was no difference in the drying of the retina. The CST levels were the same in both, but bevacizumab is not as good. So bevacizumab is not a drug of choice, but either of the other two drugs are equally good. So this is what you must keep in mind. The other important thing, the patient cannot afford aflibercept. Then don't fret, because if you persist, the important thing is keep on trying, keep on trying, keep on trying. So if you give intensive anti-VEGF treatment, regardless of which drug you give, you will end up getting good outcomes over time. So even if you continued with 6 injections every month, even with bevacizumab you'll get, even with ranibizumab you can get good outcomes. The other important thing is that in patients who have bad visual acuity in the beginning, here also those who have less than 400 micron thickness, there both ranibizumab and aflibercept are equally good. So there it makes no difference. So keep this in mind. Of course, in patients who have very high central subfield thickness, aflibercept was better, specifically better than bevacizumab statistically, but even better than ranibizumab. Now, if the patient can't afford aflibercept, then if you put laser along with that, so laser with ranibizumab will give you the same outcome as you would get with aflibercept alone. So combination can give you the answer. So this helps you to break out of that dilemma. If you have a patient with better than 612 vision, it makes no difference. You get equally good results in visual outcomes and in drying of the retina, both with aflibercept and ranibizumab. If you have patients with less than 6 or equal to 615 vision, patients have more than 400 microns, start with thickness, start with aflibercept, And then you can shift to ranibizumab in the maintenance phase, you'll get the same effects. With those who have less than 400 micron thickness, you can start with either ranibizumab and aflibercept and get the same visual outcomes. And if you have a problem, you can combine focal macular laser, you'll get the same effects. Bevacizumab, of course, is not as good as the other two drugs. The important thing is the treatment is finite. You give the treatment properly, you need maybe 7-8 injections in the first year, goes down to 2-3 injections in the next year, and maybe 1 or 2 injections in the third year. But if you don't give persistent treatment, then you'll just have to keep on giving the treatment all over. Last thing, can you prognosticate? You know, the best prognosticating indicator is a therapeutic indicator, which is you give 3 injections. If the patient doesn't need an injection in the month 3 or month 4, that is the 4th injection or 5th injection, this guy is going to do very well. He will need an average of 4.3 injections over the year and have more than 2-line improvement as a rule. So this is the best prognosticator we have. Now there are 25% of patients who did not respond even to, who had less than 5-letter improvement on aflibercept also. Now in these patients, when they gave, if you see the response, you find these patients who had less than 5-letter improvement at week 12, in this specific group, ranibizumab seems to do better than aflibercept, though the difference is not statistically significant. It's only a trend. So keep this in mind. And last, we come to the economic issues. Fortunately for us, for our country, we now have a situation where there are a lot of patient support programs and biosimilars available. So today, if you take 2 vials of Eccentrix, the third becomes free. And that's equal to the cost of 3 injections of a biosimilar. So you can take the innovator drug for the same cost as a biosimilar. But there is also, by getting 2 + 1 free, there's a psychological push for the patient to continue treatment for at least 3 doses. So he makes sure he gets more optimal treatment. The other important thing, you know that if you have, with 2 you get 1 free. Now if you multiply this 2 times, this becomes more economical than giving a patient support program with aflibercept, where you get a total of 5 injections. Here you get 6. So you get 1 injection extra, and that becomes a more economic option during the maintenance phase, not the initial phase, but during the maintenance phase, where you want the injections to be always available, it gives you that extra injection. So there again, we have another way of making costs better for our patients. So to conclude, ladies and gentlemen, systemic control must be initiated early in the disease and continued over the long term. Ranibizumab and aflibercept give similar CST reduction in patients with vision better than 612. Both ranibizumab and aflibercept have similar efficacy if the vision is less than 612, but the CST is less than 400 micron. A combination of ranibizumab with focal macular laser or aflibercept monotherapy are equally good in causing the same degree of CST reduction in patients with less than 612 baseline vision. Finally, if you give your patients treatment regularly, you can sustain the visual clinical outcomes for up to 5 years, and you can achieve that with substantial decrease in injections. It's very important to remember. Unlike ARMD, here the number of injections will come back to 0 in most patients. So tell the patient, if you take treatment properly, this is a finite disease. Cost issues are no longer a deterrent to use of the innovator drugs. And remember, maybe in suboptimal responders, those who have less than 5-letter vision gain at 12 weeks, they may respond better to ranibizumab, though this is only a trend, was not shown to be statistically significant. Keep these points in mind, and thank you very much for your attention.
Thank you, Dinesh, for your 2 talks. I think they were widely appreciated. Now we'll move on to, before any waste of time, we'll move on to Prashant Bhawankole. He's a vitreoretinal surgeon from Nagpur, and he's going to talk on pharmacotherapy in vitreoretinal disorders, both injections and implants. Also implants which are slow release. So he'll talk about those slow release implants. So over to Prashant Bhawankole.
Yes, sir. So, good evening, friends, and thank you, Talwar sir and Atul sir, for this opportunity, and in fact, Rolika and Santosh sir for this opportunity, and the CFS team. Yes, friends, now I would be speaking basically on pharmacotherapy in vitreoretinal disorders. My job has been made quite easy by Dr. Manoj, Dr. Vishal, and Dr. Dinesh sir by already speaking upon the role of various anti-VEGFs in venous occlusions, diabetics, and detachment cases. Well, what are the various routes of administration of drugs which can reach into the vitreous cavity and achieve its target? And thing is, we have systemic way, we have intraocular injections, which we will be talking in details about. The other mode is topical drops. Can those drugs reach in adequate concentration into the vitreous cavity, and the periocular route? So these are the various routes by which we can reach out into the vitreous cavity. Now look at the various barriers which come into the bioavailability at the target tissue. Let's come first to the systemic route. Systemic route is the oldest and the most preferred route for most of the systemic diseases. Well, you can give orally or intravenous. But the challenges to the bioavailability is because the drug itself gets bound to the protein of it gets bound to the blood itself, leading to less availability of the tissue besides the role of ocular barriers. So what happens, the drug might go into with the blood over there, but it cannot percolate the blood aqueous barrier, which is constituted basically by the zona occludens at the RP level, or at the non-pigmented epithelial layer of the ciliary body and the iris tissue. But importantly, this barrier is more stronger for the hydrophilic drug. And if it comes to the vitreous cavity, the blood retinal barrier, which is again constituted by the endothelium of the cells and the outer RP. And these are the two barriers which the drug has to overcome when it comes from a systemic administration. And that's why most of the drugs cannot reach an adequate minimal inhibitory concentration, which is essential for its proper functioning. Means the minimal dose which is required, except for these two antibiotics, that is ofloxacillin and moxifloxacillin. Rest of the antibiotics cannot reach in an adequate concentration to achieve its target reaction. Now coming to the second mode of action, which is most commonest in ophthalmic, is topicals. Well, what are the barriers? There are topical, whatever it does not reach into vitreous cavity in adequate concentration because of the anatomical barriers and the physiological barriers. The anatomical barriers can be in the form of static and dynamic, while the physiological. So what are the anatomical barriers? So these are the tissues which come across the topical drug, which come when the drop is put into conjunctival cul-de-sac. It is the conjunctiva, corneal epithelium, stroma of the cornea, and the sclera which it has to pervade through. And the dynamic things which are going on into the conjunctival cul-de-sac are this: tear drainage, conjunctival blood and lymph flow, iris blood vessels, which are ready to take away the drug which has been put into the conjunctival cul-de-sac. So let's move one by one. So how does the cornea affect? The epithelium itself has a lipophilic nature, thereby it reduces the diffusion of the drug put into the conjunctival cul-de-sac going into the antechamber. Hydrophilics are less permeable. Then how do you counteract? So you have an ATP pump built inside the endothelium which actively pushes the drug, picks up the drug from the conjunctival cul-de-sac and gets it into aqueous chamber. Then the stroma. Stroma collagen lamellae again acts as a barrier, and it acts as a barrier more so for a hydrophilic drug. Endothelium, well, again it acts as a barrier, and remember it functions because it is slightly more leaky compared to it, but because of the ATP pump you can pick up the drug from the conjunctival cul-de-sac which goes into aqueous chamber. Now look at the cornea as a cornea to aqueous. What are the barriers now? It is the hydrostatic, because the aqueous inside the antechamber is at a intraocular pressure of 15 to 20 millimeter. So hydrostatically the drug which is into conjunctival cul-de-sac cannot go by the pressure gradient. So how is it counteracted? The only two ways to counteract is by active transport by an ATP pump and by the osmosis. And this again comes. Now look at the other barriers of bioavailability into antechamber. There is continuously a secretion of tears. Tears are produced at the rate of 1.2 microliters, and the conjunctival cul-de-sac capacity is 7 to 2 microliters. So that means, and if you are blinking at 12 to 18 times per minute, less than 5% of the drug would reach intraocular tissues. Plus, whatever drug is put into the conjunctival cul-de-sac, 90% is drained by the nasolacrimal duct, and therefore the tear turnover time is only 5 to 7 minutes. That practically means very less amount of the drug is going to go intraocularly. The other factors which influence the availability of the drug or perfusion of the drug from conjunctiva into the antechamber is the size, molecular size. Conjunctiva, cornea, these are the sizes of molecule. If the drug molecule is bigger than this, it cannot percolate. Besides that, the tonicity of the drug also affects, isotonic drugs are better absorbed through the cornea compared to the conjunctiva. Importantly, the conjunctival fluid also has, rather the tears also has enzymes like this, which further decreases the bioavailability of the drug. And therefore, if you look at how the topical drugs behave, you look at it, almost 95% of the drug is eliminated by various this physiological and anatomical barrier, while only 5% is absorbed through either through cornea, through a small lipophilic drug, while through conjunctiva and sclera, the large hydrophilic drugs are absorbed. And therefore, the amount of drug which goes into antechamber is quite less, even if you administer it topically. Subconjunctivally, can we achieve a good concentration of the drug in the antechamber? Well, sclera allows the molecules as big as 150 kilodaltons, while choriocapillaries, remember, but sclera is immediately adjacent to uveal tissue. So, moment the sclera it goes through, the choriocapillaries, which is the highest vascular supplied tissue in the body, pulls up the drug and it takes it away. And therefore, it can achieve a concentration higher than a topical, but it is very fleeting in nature. Now, the other way periocularly you can do is inject subtenance. But again, remember, it is once it gets absorbed through the sclera, the choriocapillary really drains it away at a very fast pace, and therefore, again, the amount of concentration which comes into the vitreous cavity is quite pathetic. Now, intracameral things. Can we inject directly into antechamber and achieve a desired effect? Well, remember, aqueous inside is produced at the rate of 2.3 to 2.4 microliters per minute. And the total volume on an average is around 310 microliters of an antechamber. So that means within 2 hours, the whole of the antechamber aqueous humor is drained off. Importantly, whatever that drug is there is also taken away by the drained out through the iris and ciliary body. So practically it means the washout time of any drug which is injected into antechamber is less than 10 minutes. And therefore the concentration of the drug to be maintained in the antechamber is not sufficient enough. Yes, some of the lesions which are placed in the antechamber needing some antibiotics like cephalosporin, vancomycin and moxifloxacillin can be injected intracamerally and they can be tolerated by the endothelium. Okay, so these are the things. So that is the reason in vitreoretinal disorders, the preferred destination where the drug should land is a vitreous cavity. And this is more so in favor because vitreous cavity is quite proximal to the tissue where we want an action. Second most important thing is the characteristic of a vitreous. It is avascular, so it means it is not drained out. It is formed of collagen and hyaluronic acid, which acts like a sponge to keep the drug with it and leads to sustained release over a period of time. It has poorly developed local immune mechanism. So if you inject some proteins, biologics, they will have less chances of having immune mediated reactions. And that is the reason vitreous cavity is a preferred destination for delivery and deposition of the drugs. But still, it also has its own challenges of bioavailability. Remember, even in vitreous cavity, there is a washout through anterior route. Through the anterior route, the larger molecules by passive diffusion are drawn out of the Schlems canals, while the posterior route, the smaller molecules are drained out by active transport. And also the size of the molecule, weight of the molecule also decides upon the bioavailability of the drug and for how long. Similarly, the tonicity of the drug, the cationic drugs pass through passive diffusion into the aqueous, anionic drugs. So the type of tonicity of the drug or the whatever is going to be deposited also decides that hours or the duration of the action that drug would have, besides the solubility coefficient like lipophilic water solubles. These are how it is done. Importantly, whatever drug, if it is a protein in nature, will have an anti-drug antibodies which will further lead to destabilizing the role of that particular things. So these are the challenges which you have, but in spite of that, vitreous has a longer duration of retention of the drug, and being proximal to the ciliary body, retina and choroid is better preferred site. These are the other factors which can affect the bioavailability of the drug which is deposited into vitreous. One is vitreous liquefaction. If the vitreous is liquid, it has a shorter half-life. If the tissues are inflamed, again it has a shorter half-life. Surgical status, if it is a aphakic or a vitrectomized eye, the half-life of the drug inside the vitreous cavity, though you inject in an adequate concentration, will be shortened by almost 10 times shorter. So you look at this various combinations, these charts would be available in any book. You look at the half-life of the drug, and this half-life of the drug which is deposited into vitreous cavities, you should be aware, basically because that will decide upon the need of further injections at what duration it has to be done. Now coming to the history. So vitreous, which was a sacrosanct entity, was first invaded by Dushman-Ohm to inject an air bubble in a form of a pneumoretinopexy, though it got labeled later on. And the first drug which was injected inside was intravitreal antibiotic by Peeman et al. For bacterial and fungal endophthalmitis, and the first drug which was injected for treating macular edema was what triamcinolone acetate. You should remember these three events which have been done, you might have in the questions. Pneumatic retinopexy, I think I will just run through these slides because Dr. Dinesh Talwar sir has already spoken about it. So what happens? A volume of gas is injected which tamponates the brake and lets the fluid absorb, and by that time the laser will take effect, and that is how a retinal detachment which is subclinical in nature with a brake which are within 2 clock hours or 3 clock hours superiorly can be tackled by avoiding a major surgery. And this is the drugs, these are the gases which are available with the duration for which it can tamponate in this chart, which is available with any standard textbooks. Now the other drugs, most important is in the management of endophthalmitis. And what is medical management? It is the injection of the drug into the vitreous cavity. And usually, how do you decide which drug has to be used? You have to look at the gram-positive, gram-negative spectrum of it, as well as in the first dose, you try to cover up antifungals also. And regarding putting of the steroids, intravitreal steroids, in a management of endophthalmitis is a matter of debate. And this is how the spectrum of the disease can be decided, which combination has to be injected for treating an endophthalmitis. So regarding the role of steroids, if it is a fungal or a chronic endophthalmitis, intravitreal steroid can be avoided in the first case. But in subsequent cases, if it is a non-fungal, intravitreal triamcinolone can be added along with the antivitreal things. Why is steroids injected intravitreally? Because it is not necessary the infection might kill the intraocular tissues, but it is the inflammation sometimes which can be more damaging, and that's the reason why you have to combine these antibiotics to tackle the inflammation secondary to infection by use of steroids. When do we repeat the intravitreal injection? And for that you should be aware of what is the half-life of the drug, and usually it is done around 40 to 72 hours. If you do not see adequate recovery of the disease, and based on the culture sensitivity, these are the drugs which are to be injected, and this is the half-life, how we decide when to inject. And so these are the spectrum of the drugs which I would just run through. This is with their half-life when has to be. So on an average, it is repeated around 36 to 48 hours if it has not given you an adequate response after first intravitreal injections. Standard injections which you are aware, these are the difficult, there are certain bugs which are difficult to routine standard management antibiotics, and these are the drugs which can be used in certain cases like colistin in Pseudomonas, imipenem and meropenem in E. coli, daptomycin in methicillin resistant Staph aureus, piperacillin in Enterobacter, ticaracillin in Klebsiella, azironam. These all drugs are available which will be available to you, and you can look at it anywhere. So this is what the actions is. Now regarding use of antiviral drugs in conditions like CMV retinitis, HSV retinitis, PON, ARN, you can inject directly into the intravitreal, and this is the dosages of the drug which are available for various viruses. And look at the half-life, that will decide when you will be injecting upon the next dose of injections. Most of the times, in a viral conditions, you need a systemic adjuvant along with it. We also have ganciclovir implant, which releases the drug over a period of time by the name Vitrasert, which you should be aware. And it has a dose of 4.5 milligram, and it sustains the dose of the ganciclovir intravitreally for 6 months. Now coming to anti-VEGF, this is the most important thing which is happening, which previous speakers have already alluded to. These are the indications which I will not run, I will just run through. These are the molecules which are available, the structures and all are available to you. But the newer kid on the block is brolucizumab, which is lately Dr. Dinesh sir spoke about it. And the newer kid which is on the way, which is knocking the door, is faricimab, which you should be aware of. And the trials I have already put into the slide, which every one of you should at least remember what are the names of those trials, because that might be asked by your examiner. Now, what are biosimilars? Biosimilars are not the identical copy chemically done with the help of this biosimilars proteins. But remember, they can cause reactions in certain cases. We will just run through it. So look at the half-life of this. And so based on the half-life, if they have a more half-life systemic like bevacizumab, it can lead to more of a systemic adverse events. While the molecules like ranibizumab and pegactinib has a lesser half-life, so they are less likely to cause the systemic side effect in the form of thromboembolic episodes. While inside the vitreous cavity also you should be aware of the half-life, because that will decide upon when the next injection has to be given in this vascular retinopathies and all. Protocols, well, it is the PRN and treat and extend, which you should be knowing it. There might be some short notes on it, but I will not run through. So for anti-VEGFs in DME, these are various studies where even an Einstein might get confused. So what you need to remember is, these are the pre-treatment, post-treatment photographs. What we learned is that important is anti-VEGFs cause sustained visual gain that are superior to laser. Vision gain is sustained for longer time, up to 5 years. This is what Restore taught us. Requirement of injection reduces every year, but need of injection in year 2 and 3 are important. Combining laser does not necessarily reduce the burden of injections or give better visual acuity. And in untreated eyes, it is never too late to start an inflation. So this is what we learned. This is just the gist of what all these studies told us. And based on this, we decide how to use the anti-VEGFs. Now, there are certain DME biomarkers on OCT which might guide you regarding which injections you should use. If you have a SRD or if you have a HRDs like this, then it means they are inflammatory in nature. In these cases, steroid is probably the molecule of choice for us. But if you see something drilled and all, anti-VEGF can be a modality of treatment. Now, these are in anti-VEGFs in AMD. I think Dr. Manoj has already spoken, Vishal has already spoken. This is the large neovascular complex on an octa which has regressed after an anti-VEGF. I will again just show you, these are the various studies which are available, which are as confusing to you as well as to me. But this is what we learn from various studies. This you should remember. This is the gist that any of these molecules are going to do. And these are the OCT biomarkers which you should be aware, which can guide you regarding the prognosis of this particular treatments. Now coming to the refractory tachyphilic, coming to combination therapy, I think I will just run through it. So coming to other indications of anti-VEGFs is in proliferative diabetic retinopathy. Yes, all studies initially spoke about treating diabetic macular edema. Now in diabetic retinopathy, it is protocol S. This is the study, and what we learned was that anti-VEGFs can be helpful and avoid the lasers. This is how it responds in a case of ultra-responders. Clarity is another study which showed the role of anti-VEGFs in management of diabetic retinopathy. But remember, it can be short-term effect, it can lead to a crunch phenomenon, and non-compliant patients can land up. And therefore, still most of the times, we do laser in such cases. Can we use anti-VEGFs in vitreous hemorrhages? This is what the various studies show. I will not run through it. All molecules have their own adverse effects which you should be aware. Newer agent is available on the side margin. Anti-VEGFs are also used in the management of ROP, BEAT ROP trial and Rainbow trial, you should be aware. And these are the advantages. You get a regression, you can preserve the field, you can have less myopia, but these are the adverse events which you should not ignore. And so what we should remember is, these are the current indications where we use anti-VEGF. It is a half-zone disease, APROP, or zone 1 disease where the anti-VEGF is a modality of treatment. Rest of the conditions we still use lasers. Now coming to steroid injections, I think this was how it responds. This is the first drug which was used intravitreally, the DME intravitreal. I will just run through it. The Retisert came, it has been withdrawn, Iluvin has been withdrawn. Ozidrex is intravitreal dexamethasone, which is a sustained release. It's still in vogue. It has an effect for 8 to 12 weeks. Now coming to other drugs which are used. You can use intravitreal drugs to liquefy the vitreous, thereby permit management of vitreous hemorrhage or epiretinal membrane, which can be peeled off, and to some extent in vitreomacular tractions. TPA, you should be aware. Pneumatic displacement, already I think we had a discussion previously. And ochriplasmine, you should remember that study over there, and it leads to edema, and that's why it is not much popular now. These are the newer drugs which are knocking the drugs which can be used intravitreally for achieving liquefaction of the membrane as well as induction of PVD. Antimetabolites are used in certain cases of lymphomas like methotrexate, melphalan, and along with the systemic therapy. I will just have a look at it, which are given. Procedure per se, you should check ROPLAS, informed consent, check patient name. Injection site and entry has to be done about this millimeters when you are treating a baby or a elderly. And these are the two techniques. You can go directly or you can get a step pattern. Remember, intravitreal injections, though lucrative, but it has its own set of complications and it should not be taken lightly. Proper asepsis is absolutely important. Drawbacks I have already spoken about. Newer drug systems like hydrogel, polymerase, microneedles, microcannulas, iontophoresis, and some of these things, nanoparticles, are knocking the door for better delivery and prolonged delivery. So remember, intravitreal is the best way because it achieves a good concentration into vitreous cavity, and it is a preferred destination when you are treating a vitreoretinal disorders. Blood aqueous and blood retinal barrier can reduce the absorption, and intravitreals being proximal gives you maximum. Thank you. I'm really sorry I had to rush through because it is a vast topic.
Thank you so much, Prashant. That was a very enlightening and long lecture. So I think the postgraduates must have imbibed a lot of information in there.
Exhausted.
Yeah. So
I think we are running out of time,
so
so
now
let's go to the next topic. We won't be able to do discussion right now. So we have Dr. Ajay Purohit, who is a consultant in CFS Jodhpur, and he did his fellowship with us. He's going to talk about overview of lasers in vitreoretinal disorders.
Good evening, everyone. I hope everyone's there. If someone needs a cup of coffee, please get it. So I'll be starting my topic, the overview of lasers in vitreoretinal surgery diseases. So starting with the brief history, the concept of laser was given in 1917 by Albert Einstein, which was confirmed, the existence was confirmed by Ledenberg in 1928. But the first use of light photocoagulation in retinal disease was used by German ophthalmologist Gerd Meyer Quitzkerath, in which he used a natural sunlight to photocoagulate the retina. In childhood, we might have done photocoagulation with the help of a magnifying glass, and we'll use the sun rays to burn the laser. This was the same concept which was used by Dr. Gerd Meyer. He noticed that in patients of solar retinopathy, there were retinal scars which were there. So with this concept, he treated the patients with sunlight, and he treated the melanomas of such patients. This is an actual picture of Gerd Meyer using Galileo telescope in his OR and directing sunlight to treat the melanomas. But in 1960, it was Theodor Maiman which first introduced first laser machine using a ruby crystal medium. This is a small machine, which is the first laser machine. In the clinical practice or the medical use, it was Dr. Leon Goldman who used carbon dioxide laser to photocoagulate the human tissues. So it was in 1964 the first laser was used by Leon Goldman. So I'm not going into major details of laser, but this is the three main components of every laser machine you will see. Going to technical details is not for medical use, but the three components of lasers are there needs to be a laser material where laser energy is stored, and there means to be a way to replenish that energy so that the laser keeps going on. It's not that once you use a laser, the machine is useless. And there must be a method to retain a fraction of light which can re-stimulate the laser for further use. So this is a basic component of laser machine which is there in each and every machine. And how does the laser interact with tissues? There are three major interactions: the thermal interaction, the photochemical interaction, and then ionizing effect. But for retinal photocoagulation, the only thing we'll be discussing is the thermal effect. And even in thermal effect, we'll be discussing more of a photocoagulation. And rest all are used in ophthalmology, but not in retinal disorders. So what does photocoagulation retina does? It converts the light energy, which is a laser, into a heat energy. So when you apply a laser to retinal tissues, it denatures the protein and coagulates the tissue. And that it raises the temperature from body temperature of around 37 degrees Celsius to around 57 to 60 degrees Celsius. And why does it does? Because there are certain pigments in the retina which absorb these lasers and they photocoagulate. These pigments are melanin, xanthophyll, and they are hemoglobin pigments. So it's important to discuss. It is important from theoretical point of view also and from viva point of view also. These pigments, they absorb specific light. So not all pigments absorb everything. So if you see the melanin, which absorbs universal light spectrum from 400 nanometers to around 700 nanometers. And melanin is present in trabecular meshwork as melanosomes in RPE and as melanocytes in choroid. Then there is xanthophyll, which is present in the macular area in the outer and inner plexiform layer, and it only absorbs blue light. It doesn't absorb any other light. And hemoglobin, which we all know because retina is a vascular component, it absorbs blue, green, and yellow light, but it does not absorb red and infrared light. So when we talk about lasers, the lasers can be delivered by two systems. Either it can be a laser indirect ophthalmoscope, where a indirect ophthalmoscope is used and the laser is connected to that, and then we use a condensing lens around 20D or a 28D lens to deliver those lasers. But in an indirect laser system, the spot size are fixed. We can only maneuver the magnification of the spots. And the other is a slit lamp based delivery system in which we use lenses. Either we use a plano-concave lens which gives an upright image, but a very small field of view. But it's a very clean and crisp image. So these lenses are usually used in cases of macular lasers. And the other is a high plus power lenses, which gives a wider view, but gives an inverted image. So when you see from these lenses, the image is completely inverted. So you need to maneuver your lasers according to that. But the final resolutions are slightly lost. And there are four important lasers which we use in retina. These are the argon green laser, the frequency doubled ND arc laser, which we also call as the green laser, one of the most frequently used, the krypton red laser, and diode laser. So we'll discuss these lasers because these are actually important from theoretical point of view. The argon green laser, which is a 514 nanometer laser, it is selectively absorbed by RPE, hemoglobin pigments, choriocapillaries, rods and cones, and outer and inner nuclear layers. And the melanin is a pigment which readily absorbs the green laser. What it does, you see this structure, this is a complete retina structure. What argon green laser does, it coagulates from the choriocapillary up to the inner nuclear layer. So you see the inner nuclear layer, it gives a big laser scar which is there, which it does. And so it is suitable in lesions which are there at the RP, the choroid, and at the blood vessel levels, because it's giving the complete laser burn. Another laser is frequency doubled ND arc laser, or the 532 nanometer laser. You must have seen in most of your OPDs or in the OTs, we have a 532 nanometer laser, which is a green laser, we say. It is absorbed at the hemoglobin, melanin and RP, and the trabecular meshwork. What it does, it coagulates the retina from the choriocapillary up to the outer nuclear layer. So the laser burn is slightly less, and it does not spread. The quality of this, the property of this laser, it does not go for a collateral damage. So it will damage the particular area. It won't damage the collateral area. So this laser can also be used in to laser the macular lesions. So it won't spread and involve the fovea. And the krypton red laser is only been absorbed by the melanin granules and not absorbed by hemoglobin or xanthophylls. So this quality of xanthophylls, which it doesn't absorb the red laser, we can use this laser to treat macular subfoveal CNVMs, because it won't affect the xanthophylls or the normal pigments of the macula. And it, because the wavelength is more, it will go deeper into the RP and the choroid and cause more burns. But it doesn't have any significant role in retinal vasculature. It causes more deep and extensive burns. So if you see patients with extensive deep burns, it could be a red laser burns or it could be a diode laser burns. So diode laser, another laser is it was previously routinely used, still used in some centers, and it's a 10 nanometer laser. It is semiconductor laser, and it's poorly absorbed by hemoglobin, and hence it cannot be used to photocoagulate or obliterate the microaneurysms. One advantage of a diode laser is there is no flash of light when we deliver the laser. But one of the major disadvantages is causes a lot of pain for the patient because it penetrates deep into the choroid. Sometimes some surgeons, they also use to give a peripheral block before lasering these patients because it's so painful. Another laser is a transpupillary thermotherapy, or the TTT, which is again a 810 nanometer laser. But it is mostly used in treating choroidal melanomas or retinal tumors. In this, the beam size is larger, around 0.8 to 3 nanometers. The power is more, around 250 to 750 megawatt, and the exposure time is more. But the advantage is that it won't damage the retina. It will only increase the temperature of choroid and will destroy the tumor which is there. Another which we have discussed before also in previous talks is the photodynamic therapy, or the PDT. Sadly, it's not available in India right now because of the lack of dye. There are multiple uses of PDT now. The CNVM was there, then non-dissolving CSR, PCV, ocular histoplasmosis, and many more tumors which was there. It is basically a photosensitive laser, photosensitive dye or vertiporphyrin injected IV. And this vertiporphyrin, what it does, it goes and adheres to the endothelium of the vascular network. And when we apply the PDT or the laser to that particular area, what it does, it releases free radicals, and these free radicals, they coagulates the vascular networks and decreases the CNVM part. So this is what PDT used to do. But the only disadvantage was it's a photosensitive dye. The patient needs to be completely covered after PDT, and no exposure of any kind of light is allowed for maybe next 24 to 48 hours. Another important Viva question or a theoretical question is the grading of the laser burns which is there. There are 4 kinds of grades: grade 1, 2, 3, and 4. Grade 1 is a very light burn, it's just barely visible burn. It is good for focal or a grid laser. Grade 2 is a hazy, faint, whitish retinal burn. And most commonly done is a grade 3 burn, which we usually use in cases of PRP, for panretinal photocoagulation, or in cases of barrage laser when we barrage the retinal hole. And the grade 4 is a very dense, chalky white burn. We need to be extremely careful with such burns because it can cause a full thickness retinal break also. Now, we have discussed the complications of photocoagulation before in previous slides, but most of the complications of photocoagulation, they happen because of inadvertent firing of the lasers to these areas. It could be over the cornea, it could be over the iris, it could be over the lens, it could be over the posterior ciliary vessels, which can cause permanent mydriasis, loss of accommodation, and it can even cause a dryness in some patients post-laser. One of the another complication is Brooks membrane rupture. In cases where a very small or a small laser size is done and very high laser intensity is used, it can go up to the Brooks membrane and cause a rupture of the Brooks membrane. These Brooks membrane ruptures can in future lead to secondary CNVN formation. And sometimes when the patient is subjected to a very intense PRP, single sitting or maybe a high volume energy, it can cause choroidal or exudative retinal detachment, which in case can cause increase in IOP, or it could also cause ciliary misdirection. So how do we clinically apply these? We know theoretically that these lasers are used in PDR and barrage laser, but what are the clinical application? What is the mechanism of action? So when we do PRP in PDR patients, we are actually, what we are doing, we are actually destroying the photoreceptor layer, and diabetic retinopathy being an inner retinal pathology, the oxygen supply from the choroidal circulation is increased up to the inner retina. So when the oxygen supply is increased to the inner retina, what these increased oxygen supply it does, it decreases the VEGF load, and the endothelial proliferation also goes off, and the new vasculation decreases. Also, when the oxygenation increases, there is an auto-regulation of vasoconstriction. So vasoconstriction will lead to decrease fluid in the extracellular space, and hence it will decrease the edema part also. So both neovascularization and edema is decreased. What Dinesh sir was talking about, peripheral photocoagulation will decrease the macular edema also. This is the mechanism which helps in decreasing the macular edema. How does the focal laser? So the PRP works in a different way, and the focal or the grid laser works in a different way. Whereas the PRP was decreasing VEGF load, what focal laser does, it remodels the RP. So if the focal burns are less than 125 microns, the RP will spread laterally and will help to increasing cytokines, will decrease the edema. And if the lesion is more than 125 microns, there is a reproliferation of RP. And new RP proliferation will cause more cytokines release and will antagonize the VEGF and will reduce the macular edema. And we have already discussed in previous slides the indications of PRP. These are NVD or vitreous hemorrhage, peritoneal hemorrhage. There's NVE, there's rubeosis of iris, and the eyes with extensive capillary retinal ischemia, and patients with severe PDN in the other eye. So we'll see some clinical cases where we can actually apply lasers and how lasers actually work. And this is how PRP is done. We need to spare the 500 microns nasal to the disc and up to 3000 microns superior temporal and inferior to center of macula. And then we laser the rest of the area up to the equator or beyond the equator or up to the ora if you can. The spot size is usually 100 to 200 microns which you can use, and it needs to be 1 to 2 spot or 1.5 spots away. So this is what a good PRP looks like. These are the PRP areas. You can see this is near about 500 microns nasal to disc margin, and the spot size is around 150 to 200 microns, and these are near about 1.5 to 2 laser spots apart. This is what a PRP looks like. So we'll discuss some cases. This is case 1. This is a one-eyed female patient with non-controlled diabetes. You can see the central area is completely non-perfused. The complete macular ischemia is there, and the areas beyond the arcades are also completely non-perfused. So this is an example of extensive retinal ischemia which needs laser. Another case, we can see there are multiple areas of extensive areas of capillary non-perfusion. There is no neovascularization in this patient, but there are extensive non-perfusion areas, and hence the patient should be given PRP treatment. So this is a case of this is another case with NV eyes in both the eyes. You can see the neovascularization both the sides. So this patient in octa we can see extensive capillary non-perfusion on the lower side. We can see the NVD both the sides. So this patient was subjected to anti-VEGF injections. The NVI is decreased in both eyes after 1 week of anti-VEGF, and you can see after PRP the NVD has also regressed completely. The other eye of the same patient, you see the red areas. The NVD is completely regressed. What the PRP does, you see this patient. This is pre-PRP. We can see these vascular networks, the NVEs, and post 1 month of 3 sittings of PRP, we can see actually the neovascular patches has gone down. Both the patches, you see the crowding of vessels has gone down. So PRP is actually working in these patients. Another, the patient is a big fibrovascular front is there. There are multiple NVEs which are there, and post PRP, you can see the NVEs have regressed drastically. And we can also do a focal or a grid laser. We can do an angiogram in patients with non-resolving macular edema, or we can do an angiogram. We can see all the leaking areas, and we can go and laser those leaking areas, which this all has been discussed before. Do a focal grid laser also. So this was a patient in which there was a bunch of microorganisms which was visible on octa. Grid laser was done, and 8 weeks post, you can see the microorganisms are completely obliterated. Another lasers and vascular disorders, as discussed before, BRVO and CRVO, they'll reduce incidence of neovascularization traction and neovascular glaucoma. Like in patients, there's a superior temporal BRVO. You see NVE patches, small NVE patches, non-perfused areas. Another case of superior temporal BRVO, extensive ischemic area needs to be, these areas needs to be lasered for preventing any neovascularization. Another is the infratemporal BRVO. We can see the completely non-perfused infratemporal retina. And we've seen in previous talks also, in cases of CSCR, we use focal laser in non-resolving cases. In this case, there was a focal leak. The laser was done and the SRF has gone down. This PDT was done in this patient, and we can see with time the fluid has completely gone down. In retinal breaks also, as discussed by Talwar sir, lasers play a very important role. You see, this is a horseshoe tear with minimal SRF. 2 to 3 rows of laser should be done, and the lesion should be completely covered 360 degree. There should not be space left, or else the fluid will seep in and will cause detachment. And this is a retinal tear, retinal hole, sorry, which has been lasered. And this is the old retinal hole. You can see the laser scar which is there, and there is an operculum over the retinal hole which needs to be lasered. Do not laser the operculum, please. It will cause more traction. As discussed before by Mangat sir, Coats disease is a kind of exudative retinal vascular disorder. It can be lasered. There are retinal macroaneurysm which can be lasered, capillary hemangiomas. Laser photo can be directly done on these leaking vessels, and they promote thrombosis. One of the cases of Coats disease, you see the telangiectasis vessels and exudation. Laser was performed, and the telangiectasis vessels and exudation has decreased. In cases of CNVM, anti-VEGF is the treatment of childbirth. Extrafoveal CNVMs or the polyps can be still lasered. Like in this case, you can see the polyps, which extrafoveal polyps are there, and the central part is more of exudation is there. So these polyps were lasered, and you can see these laser scars which was there, and the exudation part has also gone down. So this is pre-laser, and this is what has happened in the post-laser. The polyps has gone down, the exudation has gone down. In cases of retinal vasculitis, when the vascular inflammatory component has gone down after the oral steroids, these areas, ischemic areas need to be lasered, like what we do in cases of BRVOs. Extremely important is retinopathy of prematurity, as discussed by Mangat sir. Laser still plays a very important and a permanent role in such patient. The laser needs to be confluent, and it needs to be anterior to the mesenchymal ridge. Do not laser the mesenchymal ridge or posterior to the mesenchymal ridge. Thank you, and all the best for it.
Thank you, Ajay. I think we will move quickly to the next topic. We have now Dr. Atul Kumar, who was the former chief of RP Center and is now in practice. He has his own center called the AKI Institute. Dr. Atul Kumar is probably the best person to talk about ultrasound for us. I have seen him doing ultrasound, and being, this was one of his special interests right from the time when he was a senior resident. So it's a long period, and I think he's probably the best person to tell us about how to go about managing patients using ultrasound.
So I know you've been into fag end of the day, and you must be all tired mentally as well as physically. So I won't take much time, and I'll run through my slides. And I'm sure you'll be able to take some tips and tricks from this. So you've got to understand the basic principles of ophthalmic ultrasound. The ultrasound is anything inaudible which is greater than 20,000 cycles per second. But the frequencies we use is about very high, 10 to 20 megahertz. So this is extremely high sound waves of the frequency of 10 to 20 megahertz, which is generated by a piezoelectric crystal in a transducer probe. So it's probably one of the investigative modalities, imaging modalities in retina, which you should know, because if you get a opaque media, you don't know whether it's a vitreous hemorrhage, you get a lot of road traffic accidents. The last 3-4 days, 2-3 cases came, the media was opaque. So we didn't know what to do. So only thing you get information from, get his RAPD check his ultrasound, get his VER done. All that is subjective, PR of course, but this is the important thing. So the piezoelectric crystal in the transducer, which is the probe which you hold in your hand, is via the contact jelly. You've seen this being done, I'm sure, in your respective centers or hospitals. And it travels. You can't. Sound doesn't travel through air. It's like a submarine principle sonar. So it travels in and then strikes back the transducer itself, and the light can be the sound can be either scattered, reflected or refracted, depending, and the sound signal comes back. It is basically generated onto an oscilloscope where you can get a hyperopic, hypoic or anechoic sound signal. You can get shadowing behind it. So this is a typical ultrasound machine. The US waves from the transducer is a transducer on the side, and this is a kind of a normal scan. You get this orbit, and ideally you should get the acute angle from the optic nerve, And this is the empty vitreous cavity, and this is the lens. If you want to study the anterior segment, you got the UVM, but I'm talking about the ophthalmic B scan because that's relevant to the retina. So this is a time amplitude scan, not so important, but you can combine it with the B scan, become a vector scanning. So this is a B scan with the A scan also vector going along. So combine the A and B together and you'll get a lot of information. So this is a vector scanning. You see, don't look at the B scan only, look at the vector A. So wherever there is an interface, acoustic impedance is there, the sound suddenly reaches a resistance and there is a sudden signal which goes up. So that generates the sound waves, and as you go inwards, the sound does pass through, but it's going through the orbital fat. So it's gradually getting attenuated. So this is the way we do. You don't have to do it on the conjunctiva. Just put some. You don't need to put any anesthetic drops. Just ask the patient to be gently close the eye. Tell them, reassure them. Always try and reassure your patient. Don't take them as just an object or something. Tell them that there's nothing to worry. There's going to be no pain. We give you intravitreal injection or doing anything. Patient needs to get a reassurance. It's a question. It's the role of the ophthalmologist. It's your role. You're the next generation. So you got to make sure the patient is lying or sitting, and make them sit on a chair, head back, put the contact jelly, quickly put the transducer, make sure your mark is in the inside depending on where you want to see the scan. So I'll tell you what this is. So this is some lesion over here, and this lesion is linear, very highly reflective. I mean, it's showing a very high, strong sound signal, and it's like kind of attached to the optic nerve head. This is the optic nerve, and it's kind of attached to the optic nerve head, and it's got a very strong signal. If you see the vector A, it's got a spike which is going as high as the scleral spike. So what could it be? So there you are, 100 out of 100. So there's another case recently, last month. So we had this huge retinal detachment, and picture on one side, ultrasound on the other side. There's some retina over here. It's got a little funny appearance, not like one in before. So what could it be? Anybody else? Not yet. It's a giant tear. You see, what has happened is, you see this? See this? This is the retina which is folded over from the optic nerve head. This retina was attached over here. So when it got torn from one edge, 180 degrees, this is a 180 degree giant tear, it got folded onto itself. This is the back side of the retina. This is the front side. So the retina folded onto itself, and this is the folding of the retina. This is a 180 degree giant tear, went like this. See, the whole flap goes like this. It's so often we see 180. In your practice, you'd see 180. This was actually 240. On one side it was 180, the other side there was a 50-60 degree giant tear also. So it was a very shocking case for me, but I did it, and with God's grace. So this is a giant tear. So don't miss these findings on ultrasound. So this was a giant tear which we did, and luckily we got it to settle. We did pre-FCL oil exchanges. So this is another case where you have A and B. There's something which is coming out from the optic nerve head. This is the optic nerve head, and it's going straight on and going onto the sides. What could it be? The A scan showing very high amplitude spikes from the linear echoes going each side, and also from the stump-like thing. What could it be? Pardon? Yeah, that's correct. It's a closed funnel RD. That's correct. So there's another case. Patient is having loss of vision, and there is a finding which shows some linear echoes on both sides, and which is going and another one which is going perpendicular to the retina, and there's some vitreous attraction also on it. So what is this? So this is a traction retinal detachment. Always a traction retinal detachment is concave forwards. It is concave forwards. Unlike a rhegmatogenous detachment or exudate detachment, it is convex forwards, classically speaking. Okay. So we go on further. This is another case dense vitreous hemorrhage, recently came to me, and he had some fibrovascular tissue here, fibrovascular proliferation, some organization, fibrotic tissue here, and so I marked it. And the same fibrovascular proliferation which is over here is marked here. So what is this? Subhyaloid hemorrhage only. Now you're getting overexcited, you're answering correctly, but you have to tell me the entire diagnosis. No piecemeal diagnosis. This is retrohyaloid or subhyaloid hemorrhage, which is caught behind the ILM. This is sub-ILM, so it's caught behind the ILM. So I agree it's a subhyaloid hemorrhage, but this is a tractional RD. You see it's concave forward. It's concave forward. This is a pull on the retina, perpendicular pull. So this is a diabetic traction RD with retrohyaloid heme or a subhyaloid heme, which is trapped. This kind of hemorrhage needs to be taken out and the traction has to be relieved. This patient had a chronic kidney disease and very severe diabetic. Face was all puffy, so we had to do it because of the TRD. So this is 2 weeks later, she got a vision of 624. She had even NVI. So we did an anterior-retinal cryopexy. Anterior-retinal cryopexy very useful. So we did laser also, the previous laser marks, but we did laser, we put oil inside. We had NVI also extensive and TRD. So the TRD area, we settled it back, put some gentle laser, and the reflections which you see are from the oil. Okay, so this is another case, quickly answers. So now don't get so wary about this. So this is concave forward with traction. So tabletop TRD. The whole thing is pulled forward, very bad TRD. This is one of the worst. So I thought I'll put it in the later part of the diabetics. So this is the RD where there's convex forward and it's totally tense, no corrugations, no bully, no undulating folds. And the retina is kind of attached to the back and then it goes off right in front. The patient was a chronic, very severe hypertensive, grade 4 hypertensive retinopathy, choroidopathy, Elschnig spots, everything. And he had come from Batinda and we couldn't do much about him because we just asked him to control his hypertension. So this was a classical case of a exudative RD. So please don't start operating such cases. If you get such a case, ask his history carefully and then see the ultrasound carefully. See the clinical picture, wide field carefully. So it's got to be a multimodal, multi-dimensional approach, and the history is very important. So this is of course a metastatic end-off. I didn't write. This is a metastatic end-off with the RD at the back. So the exudates at the behind the retina. Okay. Next one, this is also a vitreous hemorrhage, so very easy. You got tiny dot-like echos. They're not reaching till the top. So it's not overloaded or reaching 100%. So this is vitreous hemorrhage with no PVD. Fine. Now this one you tell me. If you can tell me this one, this has got a lot of hemorrhage, probably a lot of echos, and there's probably a retinal attachment here because there's a very high spike here. So look at the A scan. I'm passing the vector of the A scan along this line, directly perpendicular to this line. So it shows a very high amplitude spike. So there's something here, and then there's echos here, echos there. What could that be? Okay, I'll give you a hint. What degenerative condition could cause this? So a PCV or a neovascular AMD can have a breakthrough bleed. Polypoidal choroidal vasculopathy, which is part of the pachychoroid spectrum, is known to produce bleeds and known to produce breakthrough bleeds also. I've done so many of them in RP center as well as now in this center. Regularly I do submacular bleeds or breakthrough bleeds. In breakthrough bleeds, it's a little more tough because you have to do vitrectomy, and of course you have to inject TPA into the subretinal space. But in the just the submacular bleeds, you may inject intravitreal TPA with gas and an anti-VEGF. But with the breakthrough bleed, you have to do vitrectomy and explain the prognosis to the patient, because what you can do is for the subretinal bleed is inject TPA. TPA is tissue plastinogen activator, recombinant we inject, about 50 micrograms upper limit. So we take out 12.5 microgram in 0.01 ml and along with Avastin and air. This is Tamer Mahmood's technique, so this works well. So this is a mix of a submacular bleed with an intravitreal bleed. So patient has to be taken up for surgery quickly. Otherwise, the submacular bleed will organize and cement and shear off the photoreceptors. Patient will have complete loss of vision. And nutrition to the retina gets affected. So this is taken as a relative emergency. You don't have to scare the patient कि अभी यहीं से सर्जरी करा लो, अगर बाहर चल जाओगे तो आपकी आँख खत्म हो जाएगी. So we don't have to have a professional approach. So this is another case where you can see a PVD which actually can mimic an RD, but if you ask the patient to kinetic echography, look up, down, and so the vitreous moves forward. The RD will never move from its attachment to the disc. So now this is very interesting. Now tell me, what is this? There is a very highly strong echos, highly refractile body over here with some echos at the back. Pardon? Foreign body. So foreign body, and it's got reverberation echos at the back. There's a glass foreign body in the patient who's still so scared of getting it done, he's still postponing his surgery because he says my glass piece. So it's difficult to take out a glass foreign body, but it can damage the retina, it can cause tears in the retina. It's an intravitreal foreign body, and so it's got these are not part of the pathological thing. It's just reverberation echoes from the foreign body, solid foreign body. So this is another with reverberation echoes. So overloaded spike with reverberation echoes. So this is a very interesting one. We're going on to tougher ones as you're ending this talk. Now this is a kind of a oval lesion over here. Can you just let me finish? So there is one linear oval shaped lesion over here which is not attached to the retina so well. So it's not coming from the optic nerve from the back, and there is some kind of an excavation of the retina. So two diseases occur in this retina. One is an excavation at the posterior pole. I'm giving you enough hints, and there's something dropped at the back. So this is a nucleus drop with the iris coloboma. This is an excavation in the posterior pole, and there is a dropped nucleus, which is this. Partly it's cataractus. So you see, when you see something, see in the entirety. Does he have trauma? Does he have coloma in the fellow eye? May or may not. But you look at the coloma, it's very classic. It's got a punched out like appearance from the edges. It's going backwards, and the nucleus is separate from it. There's no optic nerve attachment or this optic nerve. Okay? So this is a little tough one, so I can imagine it'll be easy. But once you start doing it, this is, what is this? So it's a hemorrhagic choroidal detachment. Serious choroidal detachment, hemorrhagic choroidal detachment. Okay, so this is a hemorrhagic choroidal detachment. Okay, this is easy. Cysticercus, because it's got a scolex in it. Presence of a scolex is classical, it's attached to the retinal surface. It's got some membranes over it. So you probably it'll start leaking. It's very highly allergic fluid, which is very irritant. So you got to take it out and make sure you don't cause if there's a detachment, you have to manage it. So this is towards the end of the talk, and this is very obvious. You have a spike from a lesion, collar stud like lesion, and it's breaking through the retina is detached. It's like a endophytic type, and it's got an initial high spike and large angle kappa. Large angle kappa is a gradual sound attenuation this way. It goes up and then goes downwards, strong sound attenuation. This is typical of a choroidal melanoma, and there's near the angle also the ciliary body is showing the similar. From the surface of the melanoma of the ciliary body, there's a high spike, and then there's a gradual decrease of spikes which will produce a large angle kappa. So this is combined choroidal melanoma and a ciliary body melanoma. So thank you.
Thank you, Atul. That
If
was a
Dinesh
great-
permits, can I finish my second also?
So please go ahead with your second talk for vitreoretinal surgery, video assisted overview.
Thank you. I hope you found the first interesting. So this is talk on basic principles and techniques of retinal surgery, something very dear to me. I've been into retina for the last 35 years, and I've been teaching postgraduates at RP Center because I was there, and right till the final stage of my chief, I became the chief. I joined as a junior resident, MD. So I have no financial, you may hear some company names, but that's not relevant to my finance because I don't take money from anybody. So that's my motto. If I speak for a particular drug or a machine, I speak from my own this thing, but I don't take any money from them. So I give the entire credit for vitrectomy to this gentleman he's basically from the North Carolina. He's a very famous surgeon, Duke University, and he first devised a vitrectomy machine using an egg in his house garage. Robert Macamar and this great German-American, most of the Americans actually migrated from Germany after the World War II. So the brains were in the Germans, but they gave it to the Americans. The Americans are smart enough to take it. Indians are not that smart. They'll throw them back. So that's what the Americans did. They took all the German physicists and the doctors, and they came. Charles Keepens was the father of retinal surgery, came from Belgium. So everybody migrated over to USA, and it actually became an American innovation. So this is he first performed the first vitrectomy, and we must, kind of worship him in the first slide. And then only will you learn retina, vitreous surgery. Until you don't bow down to the person who's done it, you don't learn the other things. This I can tell you. So, and also take care of your equipment is very important. So vitreal surgery is fundamentally different from other microsurgeries. Posterior fundus cannot be seen without adjuncts. You have to neutralize the corneal curvature and the corneal power. So you have to put contact lenses or non-contact lenses. Otherwise, retina is not visible with the microscope. So either you use contact lenses like this. We can use a contact lens like this. There used to be an irrigating contact lens in the beginning. Appa Swami still makes it. Or you can have self-retaining, which are very useful. They have flanges. They're called KV Chalam's lenses. I like them so much. And I thank KV Chalam with all my bottom of my heart. He's in USA, but he's an Indian, and that's why I feel so excited about it. The KV Chalams, the flange can be moved on the side, and the flange makes sure the central viewing area does not move, because the flange kind of grips the sclera from all four sides, a four-flanged lens. So it neutralizes the cornea power. So very good for magnified macular viewing. I always use it. And this is the wide-angle viewing for the whole retina, because panoramic viewing is the idea behind good vitreous surgery. Because suppose you are handling one area at 3 o'clock and you pull, what happens to the other 9 o'clock? There may be a tear there when you pull. So everybody would like to have a panoramic viewing. I can see this, I can see that, I can see this, I can see that, everywhere. So this is a panoramic viewing. Either you can do a non-contact wide-angle viewing system as is attached to this microscope. It's a Zeiss microscope. It's a Resight. Again, I said I have no financial interest. Or you can have a Rolls by Vogue company, because many of you may be interested in the companies and you want to buy things for yourself. So this is the Vogue, very good lens, and a set of 3, but the Mini Quad XL is the best. It gives you 130, 140 degree view. So it's a wonderful thing, and it's got a handle, but you need an assistant. So this is the ideal vitrectomy machine which you should ideally have, which is linear suction cutting or a dual dynamic drive. That's it. You press the foot pedal, the car jumps and accelerates. Same way the suction and the cutting keeps on increasing. So, but you can decrease and increase depending on the pressure on the foot switch. So you don't run the car as BMW and crash. So you gently increase as you're going close to the retina. Though you have got very high cut rate, because of high cut rate, there's less jump of the retinal tissue. Because the cut rate is so high, the cutting is quickly, closes the orifice of the cutter. So the tissue doesn't get in. So you have to use high cut rate, low suction near the retinal surface. We call it shave. We tell the sister, put it on shave. So how we get to do this shave thing? This is a duty cycle control. It's a scientifically designed control in which at high cut rate, the orifice is narrowed, and very little of the retinal, the abnormal fibrovascular tissue or any epiretinal tissue gets into the port. So it's a shave. We say core. So that way the core is the center. There more suction is used. But when you go close to the retina and immediately shout, sister shave, she put it the duty cycle on shave. Okay, so this is incorporated in this particular vitrectomy machine. I again will have to take names. It's called Constellation by Alcon. No financial interest, but this is the kind of equipment which you should be ideally having. Ideally, you should be having this. And it has xenon light, which suffices. You may have LED light in a dark machine, but xenon light I use, it's perfect. It doesn't cause any damage. You should have a vented for VFI, VFE. This is basically to inject viscous oil. At the end of surgery, sometimes you put gas, that's no problem. But sometimes you need to put oil. You have only two choices, gas or oil. And most of the gases are SF6 or C3F, depending on the longevity. And other is oil. So oil, when you use, you have to have a automated injector. So automated injectors are there with this. So all these things you have to look for when you buy a machine. Flow suction control should be there. VGFI is you're doing a diabetic vitrectomy, suddenly there's bleeding. So you can, from the bottle, which is, I use BSS Plus. I don't compromise on the fluid. I don't use wrinkle lactate. Finish. So I use BSS Plus. On top of that, there is a air column. So the vented gas force infusion presses air into the fluid, and the pressure of the eye goes up to 60 for a momentary period. The blood bleeding stops. And then I cauterize or whatever, and then I bring it back to 40. 40 under air and 20, 25 under fluid. That's my working pressure, 25 millimeters mercury under fluid, or 40 under air. And I bring it to 60 whenever I feel like, with a touch of a foot pedal. So it's a foot control system. So that's very nice for me, because I know my hands are already holding. One is an illuminator, other is a cutter. If I'm not doing unimanual, if I'm doing bimanual, I have a chandelier. So that's the build. And then I have to have a laser inside. I don't want to have a separate laser, because when the surgery is going on, quickly you want to finish also, and you don't want to wait. Laser chal raha hai ki nahi chal raha, usko aage lao, ye karo. I've seen those things happening in RP center before. So now when I was a chief, I made sure all the 532 came with it. It's the LXT model which gets a 532 built in. So just the wire is given to me. And it's a curved laser probe. It's very nice. It reaches the aura. So if the tear is near the aura, or if I have to diabetic laser near the aura, it's perfect. Chandelier light. Okay, I'll go faster. This is a cutter. It's light. And it's got a stiffening sleeve over here so that it doesn't get bent. So it should be light in weight and dumbbell shaped. It doesn't slip off your hand. Should be light in weight, shouldn't trouble you. People must have told you about hypersonic vitrectomy. The probes are very heavy. Ultrasonic, this thing, there's a slight advantage that you can cut faster because ultrasonic waves shear. But the thing is, a very heavy probe, and you have to be very close to the retina. You have to be very, very careful. You may cut the retina because at the high cut rate. So that's many things innovate, but sometimes the over innovation can also be dangerous for the patient. So actually this I'll tell you, surgical learning should be by the simulators, just like a pilot learns it by simulators, or astronaut learns how to fly. You can't actually do a vitrectomy in a patient for learning. So ideally it is, of course you can do step by step, but this is an expensive proposition, and ISI is a good make where you can learn. It's just similar to doing vitrectomy but on a model. So to start vitrectomy is a 4-limb this thing. Foot control and hand control synchronization is very important, just like you drive a car. Both hands, both feet, totally in control. So you have to have 4-limb control plus eyes. So everything should be well under control. Otherwise, so exercise well. If you want to be a retina surgeon, keep your legs and feet, hands and no shaking, no hand shaking, no smoking. Alcohol should be reduced because we don't want trembling hands. So sutureless, now you've shifted to minimal gauge vitreous surgery, MIVS, where you use sutureless, less scarring. Sometimes you put a suture, but scarring is less. There's no astigmatism, there's no dry eye. So you just come in, come out. So previously it was very cumbersome, and it was messy. So now it's very clean. You just put a trocar cannula, I'll show you how. So this is how we put a closed vitrectomy system, less scarring. So I'll show you how we do it. So this is the way trocar cannula is put. It's a two-step. I go in at 20, 30 degrees and then 70 degrees, 30, 70. 30, if this is the globe, I'll go 30 this way. So I enter along this passage and then I'll go this way. Not totally 90, I'll go at 70. 30, 70. So there are two track. So what happens, the inside fluid will not come out. It's a cell valvular opening. It's created cell valve. So the wound construction in a minimally invasive vitreous surgery. Don't say anything else. Just say minimally invasive vitreous surgery. Don't say it's conjunctival sparing or anything. But this is just minimally invasive vitreous surgery means 23, 25, 27 right now. If any other gauge comes, I don't know. But this is the way it should be done. So the entry port should be very carefully made. This is the way. This is the way you enter. And the cannula stays back, the trocar comes out. So this is another one. Move the conjunctiva forward, put it. Why you move the conjunctiva forward? Later on the conjunctiva goes back, covers the entry point. No chance of infection. No endophthalmitis. So displace conjunctiva, put the trocar. Displace conjunctiva, two-step, put the trocar. This way. This you can learn in the beginning. Then you put the illuminator from one side. You see submacular bleed is there. Anyway, we're not discussing submacular bleed just now. So this is the present pneumatic probe is the best. There's a spring. This is the air pushes the cutter back and forth. So this is a 23, 25, 27. 20 is now ancient. 23, 25, 27, the port sizes. This you can see from the book. So endolaser is very important. I'll talk about it. And cryo sometimes I use for ARC, anterolateral cryovaccine diabetics, or buckling procedures. Oil or gas, depending on whether your patient's got you got PVR, multiple tears, traumatic RDs, and resurgeries, children who are not going to cooperate, one-eyed patients because they have to see something. If you put gas in a one-eyed patient, he's not going to see anything for at least, if it's C3F8, about 2-3 weeks. So gas can be in fresh RDs. I often use gas, but for macular surgery is always gas. Fresh RDs, of course, gas is the preferred. So this is how we fill in gas. We fill in gas like this. Small canisters are there. This made in France, and then leave a little bit of gas out. Rest you fill in. Or the oil is filled in, and then automated. Like I said, you have VFI and VFE. Vented this thing. You inject the oil through a automated system. So this is the same case I'm going to show you how we did it. This is a giant tear, that's the same which I was talking about in the ultrasound lecture. So you see this is a giant tear, 180 degrees on one side. So we've cleaned it out. I'm editing it heavily so that we don't spend too much time on it. We put some tricord just to make sure the PVD is there. So you use a gentle suction because you'll catch the retina into your port. At this stage, I'm not putting any PFCL, but I'm going to start putting PFCL very soon. So the tricord gets aspirated gently, and you can get to know some part of the tricord's gone under the flap. This is the everted flap which you were seeing on the ultrasound. You saw, remember? So now I'm starting to put PFCL. Perfluoride liquid is a heavy liquid by Stanley Chang in New York, and I saw him operate in New York, and I spent a year in Baltimore during my fellowship, so I went over and spent some time. A super wonderful surgeon, very calm and composed, and he put this perfluoride liquid in nearly all his cases because it was his innovation. And so you see this perfluoride liquid gradually go up. So I'll spend 2 seconds here to show you how the PFCL unrolls the flap. So you don't mechanically unroll a giant tear. To see the giant tear, you have to have a vitrectomy setup where you have availability of all this. All the substitutes, good light, then you need to have chandelier. See, I've got a chandelier here. Now I'm shaving the base of the retina or the base of the vitreous. This is close to the aura. So I just want the retina there, and I don't want any vitreous attachments to it because these giant tears are known to produce recurrent PVR. So this is now PFCLs filled up, and now I hope, yeah. You see the retina is all unrolled. Now we've got back, it's back into position. Now if you do ultrasound, there won't be any flap. So okay, now we're doing laser. This is the Alcon concentration LXT model laser, which just gives you the laser on each side, and then finally you put in oil. So I'll just show you oil. Now oil goes in. So it's a PFCL oil exchange. The PFCL keeps the retina folded anteriorly, back into its normal position. If I put air, it'll slip. So to prevent slippage, I put a heavy liquid PFCL Stanley Chang, and then quickly replace it with oil after laser. So then the retina stays in position, and you get a good post-op result. So this is another case which I'll skip. It's a failed macular hole recently we did, so I like to show you this. So your macular hole can also be a tricky surgery, but you got to be careful. I like to calculate the MHI, which is the height upon the base. It's American Journal of Ophthalmology article which told me that the macular hole index is very useful. So I've kind of relied on it. But every surgeon, I think, has his own parameters, which are all equally good. It's just that every surgeon has his own whims and fancies. So I like to stain with brilliant blue G dye. This is made by Aravind. Luckily, it's freely available. And so I put a little extra dye, and it was a failed surgery. And most of the ILM has already been peeled. So I just try to restain to see as much fragments of the ILM I'll be able to see. This is using a wide angle system. You see, the wide angle system I'm seeing from here to here. So this is a wide angle system advantage. So now I've used the Chalam lens. Now I've come to the macular lens. So with the Tanos, I'm trying to slip the hole a little closer. I'm massaging the hole to make it little, less stiff. You kind of understand what I mean. And then I'm bringing the flaps which are further away under PFCL and put them over the hole. Okay. One small flap has come on. You can see the blue colored flap on it with my ILM forceps. This is all from Alcon. So this is another pedicle of the flap which I try to raise pedicles from the periphery, just like a pedicle graft you use in surgery. So this pedicle has been raised. It's not independent, but it's not attached to the retina, but it's come onto the retina. It's come onto the center, the fovea. And so I hope this case would do well. So these re-surgeries are we often see these. So and then we just go on further. This is the post-op 4 weeks. You can see the ILM over here a little bit. The hole's closed. Okay. So now I use 3D surgery. I don't do microscopic surgery. So I somehow have got adapted to not looking through the eyepiece. This is the eyepiece. I put the high definition camera and I look at the screen. This is, I'm sitting here. I'm looking through passive polarized glasses. I'm looking at the screen with the IOCT. I have an IOCT which gives me tells me about the status of the retina and macular surgeries. So this is how we see. So we're not looking at this is the eyepiece. You'll have to peer to the eyepiece, but that's not my way of doing. I like to look at the screen. This has started 5 years back. I was one of the first to do 3D surgery in India. And I pioneered it, and somehow, I don't mind boasting about it because, there are very few chances where you get the podium, for me now, once I'm ex-chief. So nobody calls you. So Santosh has been very grateful. I'm grateful to Santosh and Mahipal that they've called me here to just show what I feel for postgraduates because I love teaching. So this is how I do at AKIO. This is the screen. This is my fellow over here. She's learned a lot. She's from Rohtak and she's learnt a lot. So that's it. We're just finishing. So this is, from the screen I've taken a video. I've taken a video from the screen. This is a diabetic. So this is 27 gauge. This is a sheet, fibrous sheet. So I'm cutting it. It's like segmentation. Can I take 1 minute? 1 minute? Now I understand why the previous speaker didn't say anything. So here you see, I'm going very gradually. I don't want to create breaks. So I'm going very gradually with a 27 gauge cutter. I use a lot of 27 gauge in macula in diabetic vitrectomies. So a little bit of bleeding, don't worry. So ergonomics, very good, no cervical spine problem. I look hyperextended or straightforward in the 3D. So this is the chandelier light. I always use it's not the fourth port, but it's just the chandelier light. And this is the diabetic TRD, which will show you short lip and a length, because this is important. So diabetic vitrectomies we see often, and you don't have to do any classical method which has been described by somebody in Belgium or Karl Klaas or something. You devise your technique which is best. So don't look up to every white skin, you know. Okay, my conference will be bigger because I have foreign speakers. I think we can do a better job than them. I think so. At least I'm sure about myself. You put me against Karl Klaas, I'll also do surgery. So you see, I do a little bit of peeling, then I cut. And then I do segment. I do multiple, because the same cutter I use for peeling, segmentation, and also for delamination. With the forceps, I use delamination also if I use bimanual. So I don't need to follow somebody's, slow curved scissors, cut, spend 1 hour. It's okay. You can do it in your way, as long as you get results. So you don't have to follow somebody, and I think we Indians are very good at it. So this is the same video shot from the screen. So we've gone here, we glutoned the membrane from the disc, and just from now I'll go around and cut this. So at least the disc is separate. Disc is safe. And then I'll go outwards and I'll clean off this membrane. So this is the way it's done, and it works very well. Endophthalmitis is fine, you know about it. Thank you so much. It's a book I had written. There's a volume 2. It's 2022 edition. In case you want to see few of my tips, if you're interested, it's available from JP. Thank you so much.
Thank you, Atul. That was great. I think you've given us a great overview of vitreoretinal surgery with lots of glimpses of what is state of art at the moment. We now have the last topic of the session, that is Retina 2023, which continues on to what is on the horizon. So you know what is state of art today, and what is it that we can expect over the next few years is what Dr. Srinivas Joshi is going to talk about.
Thank you, sir. But before that, I would like to just play a small video of the star of the iFocus. Please be ready. Audio, please. Audio. इस तरफ. Yeah. Audio. Audio, please.
मेटल इस पेड़ पे नहीं उगते, उन्हें बनाना पड़ता है प्यार से, मेहनत से, लगन से.
माँ के पेट से मरघट तक है तेरी कहानी, पग पग प्यारे दंगल दंगल.
70 मिनट है तुम्हारे पास. शायद तुम्हारी जिंदगी के सबसे खास 70 मिनट.
Okay, good evening everyone. I would not ask you how's the Josh because I know it's very low. So we want to bring it up high. I request all the participants to please come up over here. Dr. Ashwita Alva, Dr. Charu Maggo, Dr. Aishwarya K, Dr. Agrima, and one will be the wildcard entry, which I will tell you after my presentation. So let's finish quickly my presentation. It's just 20 minutes. I'll not take much of your time. Thank you, Dr. Santosh Honavar sir. Thank you, Dr. Dinesh Talwar sir, and Dr. Atul Kumar sir. So quickly we'll move on to, sorry. Okay. Right. So what's new in Retina? So let me go quickly, move on to brush up your, what all you have learnt, and I'm sure it's 9:41, 7:41, I'll try to finish it by 8 o'clock. So here, this is how we have divided either into diagnostic or the therapeutic. So diagnostic, there are various modalities which has already been introduced to you all. I'll not go into the detail. Then comes the non-surgical and then the surgical. Let me go quickly. So OCT, please remember, frequency domain OCT, the two types. One is the Fourier domain OCT and the swept source OCT. So swept source OCT, instead of using the superluminescent diode laser, that is what we call it as SLD. So here what we use, SSOCT uses a short cavity swept laser. Short cavity, so it has more than 1 lakh A scans per second, and the imaging of the deeper structure is possible. So what's new in that OCT angiography? Why OCTA has to be done? Anybody? Why OCTA has to be done? Boss, first, exam pass hona hai. Write a note on OCT angiography, mention its action, algorithm, clinical application, advantages and limitations. So these are all the questions asked in the DNB and the MS papers, right? So I'll not go into the detail, but please remember the OCTA, moving blood cells pass through the vessels, they generate changes in the OCT signal. So let me quickly go in through the 30 seconds video. So if you see here, so what happens here? It is the moving RBC, right? The what way it moves, at what speed it moves, at the same location is calculated. T1, T2, T3, T4. Now you see here, it is moving at the same location but different time points. So T1, T2, T3, T4. So this calculates a motion contrast composites of the erythrocytes, which is created in 4 images, which is now they are formed to form an composites of these assembled to go into the Fourier transformation and then assemble them into a OCT A cube. Okay. So this much, I think. What is new in this? EFI, SSOCT, that is 12 into 12 mm with enhanced field imaging, right? So that is going to be the future in the case of swept source OCT. So coming to the next is the wide field imaging. Wide field imaging, here we had 30 degree, 55 degree, there are various machines which go into it. The Optos gives a 200 degree field of view. This uses the SLO technology, whereas the Spectralis uses the confocal scanning laser technology, that is CLSO, right? So here what are the different types of lasers being used? Blue solid state laser, diode laser, and a second diode laser at 820 nanometer. Now this is the difference between the Heidelberg and the Spectralis, which gives 200 degree field of view. Heidelberg gives only 102 degree field of view. So these are the two different images seen here. Wide field angiography of the vein occlusion. Here you can see this is the Coates disease with the peripheral neovascularization, which otherwise could have been missed if we do it in a regular, unless we steer those images or steer the eye. So what is new in this? The Zeiss Claris 700. Here you see this is the Optos image, which comes with a pseudo color, but here it comes with a true color. So that is the advantage of having the newer machines. So what's new in wide field imaging? It comes with Optos Monaco, where you have wide field color photograph, wide field OCT and wide field autofluorescence. Whereas in case of Optos Silverstone, what all we have? We have fundus photo, red free, autofluorescence, FFA, ICG and OCT. So coming to the next is the RetCam. Here you can see this is the case of retinopathy of prematurity. This is the shaken baby syndrome. Here pediatric retinal imaging can be done. And what's the advantage? It avoids reliance on the human memory. So you don't have to remember what stage it was. Even if you write stage 2 or even if you write zone 3, whether it is zone 2 posterior, zone 2 anterior, it might change from surgeon to surgeon. So these are the different field of view. The RetCam montage image, this by the Clarity picture given by one of my mentor, Dr. Wai-Ching Lam. So here how we do it, just apply it on the baby here, you can see. So steer it on the nasal side, superior, inferior and the temporal side, right? So here you can use the interchangeable lenses as I showed. And finally, what you can see here, you can see, so this is the case of stage 3 ROP in zone 2, right? So coming to the next, what is that? Artificial intelligence. This is going to really be a breakthrough. So please remember 3 types. One is the machine learning, what we call it as ML, deep learning, what we call it as DL, and then we have neural networking. So machine learning is something which the computer is capable to recognize and understand the patterns. You have seen Netflix, you have seen Prime videos, what it shows. This is 98% which matches to the videos you had seen earlier. So these are the matches which you like. How it knows that? Because you have fed the information to it. So that is machine learning. You feed it. Whereas deep learning, what is deep learning? The algorithms can determine on their own if a prediction is accurate or not. Say for example, here it is so bright. So you will say, oh, it's so dark here. Then it switches off the light. It is so, I need some bright light. It switches on the light. So that is deep learning. And then comes the neural networking. Neural networking is the multiple processors working in parallel and arranged in tiers. That is in tier 1, tier 2, tier 3. Example for it is check processing, speech to text, facial recognition, and they are basically known for being adaptive in nature. So this is, see, this image used through the iPhone. It just takes the picture either from the camera or the library. AI is computing and it gives a final diagnosis, right? Not just that, it also gives you a differential diagnosis for this OCT, right? So Google AI uses retinal scans to estimate the hard disk risk. And then this is the most approved for diabetic retinopathy. It's called as IDX-DR system that detects the signs of diabetic retinopathy in retinal images. This is, see here, it gives exam quality is insufficient, or it may say that patient is negative for referable DR. The patient has signs of referable DR. So this is how it gives you in a different section. This is the FDA approved IDX-DR analysis report for diabetic retinopathy. Now coming to ARMD, this is the Nota Vision. This is the home-based OCT system, right? So this you can take it to your home and keep it at your home. It takes 10 OCTs per day, and then in case of any fluid, then it pings your doctor. Then the doctor calls you and says, come back, take the injection and go. So that's being purchased with the Novartis. That's going to be the Nota Vision, and Usha Chakrabarti from UK has done extensive study on that, and the sensitivity and the specificity of this machine has already been very well established. Now there is something called as black box phenomenon. That is, the researchers don't know what AI is using and computing to really come to the diagnosis. So that is called as the black box phenomenon. So whether it is exciting, unsettling, or whether it is heading to the Skynet, nobody knows what is going to be in the future. Anyhow, my question would be there about chatbot in the star of iFocus. So please, if you can, Google it and search the answer. We'll come to that later. So artificial intelligence enabled retinal vasculometry for prediction of circulatory mortality, myocardial infarction, and the stroke is also being analyzed. And it says that, like how you have TROP-T test or the treadmill test, the various biomarkers, cardiac biomarkers what we have. So it says that probably this can replace, the AI can replace these cardiac biomarkers and no need to give the blood sample. But however, a lot of studies are needed to still prove it. RAIDS, what is that? Retinal Artificial Intelligence Diagnostic System for multiple retinal and optic nerve diseases. And it found out that 10 of these diseases which they found it complex was much easily diagnosed by the computers rather than the ophthalmologists. Now, say thanks to COVID or no thanks to COVID, I think you should not say thanks to COVID, because this is what is going to happen. If the COVID keeps continuing, then you will have to pass the exams using these. What is called as AI Incorporate Teaching Post-COVID. That is called as Gen ROP, where it gives you variable sections, variable pictures, and it tries to grade your intelligence where you did the mistake and how to teach you. This is what is going to happen if we don't see the patients regularly, right? So it's been piloted in the US and Canadian trainees and found that there was a significant improvement in the trainees. Diagnostic accuracy of the trainees was improved. Now coming to the next, iTelligen. Telligen is development of a web-based diabetic retinopathy education module, right? So this is how it gives, what are your correct answers, what was the results. It's something like a NEET test you have to reappear if COVID keeps continuing. So where all AI is used, it's screening of patients, booking profile, diagnosis, prognosis, personalized machine, novel treatment, monitoring of the treatment, except the physical form of the doctor, everything it does. So I don't know when it is going to replace us also. So coming to the next, I'll not go into the detail. Anti-VEGFs, I think Dr. Prashant Bhawankule sir has explained it very well. But please remember, this is VEGF R1. What is ILIA or VEGF trap? VEGF R1 receptor is taken, R2 receptor is taken, that is fixed to FC fragment of IgG. So what happens, the VEGF thinks that, oh, this is my own receptor, let me go and sit there. So it gets trapped. So that is why the name VEGF trap, right? It's also called as the decoy receptor. VEGF R1 and R2, what are taken and being fixed to the antibody, this is called a decoy receptor. So we don't know where Joe Biden is flying, whether in this Air Force or this Air Force. This is called as decoy Air Force One. So next is brolucizumab. I think he has already explained it. Brolucizumab is the newer anti-VEGF molecule available, where it's a more potent 10 to 12 molecules per injection and having a lower molecular weight. So what is new? The ranibizumab port delivery system. It just got launched in the last ASRS last year in New York, where it is a 6-monthly refillable injection like a petrol tank. Tanki bhara do aur chale jao. 6 mahine ke baad aa jao. So something like that. It's a port delivery system. It's a reservoir of the anti-VEGF. Slowly it gets released. So there are various abicipar, pigol, squalane lactate, aflibercept, hydrogel depot. There are many more others. I think because of the lack of time, I'll move ahead further. Now coming to the laser, why laser? All these presentation has been prepared based on the question papers only. So what is micropulse laser? Micropulse laser, I'll not go into the detail, but please remember this one video, you will understand. Please understand the concept here. Later on you can write. So what is micropulse here? Continuous waveform, what happens? If you see here, the wave it hits the temperature bar, it keeps rising high. Right? So the collimated decimation, that means the surrounding retinal structures will also get damaged. But whereas with micropulse emission, what happens? This is short pulses of laser. So when you hit, the temperature rises. Before the next wave comes back, it cools down. So that is how it becomes fovea friendly kind of laser. Right? So this is the subthreshold nanosecond laser. Good to know. It's having a role in cases of AMD. Now navigated laser is nothing but you have this, it takes the FFA, it fixes where is the microaneurysm and then it just hits it. It does all automatically. So what is new in Navilas? Navilas new is non-contact PRP. So that is you already have to use a contact lenses, right? So here you're doing a non-contact PRP, use the condensing lens, ask the patient to sit. It does have an eye tracker. When you click your eyes, it stops. When you open your eyes, it's just like putting a rangoli. You already prefixed plates have been put, it just keeps typing the laser spots. So this is the navigated laser non-contact wide field PRP. So coming to the next, I think this has already been covered by Atul sir. 20 gauge we have evolved to 27 gauge. From 0.9 we have moved to 0.4. They will definitely ask what is the diameter of 25 gauge also. Please remember it. So evolution of cutter technology, we are at 10,000, we have moved to 20,000. You also have to remember what is cut rate and duty cycle. These are very, very important terminologies. So here, innovations, what is the duty cycle, how it calls twin duty cycle? It cuts while going and it cuts while coming back. So that is how effectively, if it is 10,000 cuts, it is called as 20,000 cuts. Because cutting while going and coming back, 10 plus 10, 20,000. So this is the small example I want to show you about what is segmentation and delamination. See here, this was a case of tabletop TRD. So here, what we are trying to do is using this cutter itself as a segmentation. So how do you remember segmentation? Take a bridge with 2 pillars. If you cut across the bridge, it is segmentation. If you cut it at the pillar, it is delamination, right? So what I'm doing now here is segmentation. It is called as cutter segmentation, right? See here, I'm just going it, dissecting it. So this is cutter segmentation. Now you see here, I'm using the cutter itself to remove these epicenters of these plugs. That is called as delamination. So please remember these two important, cutter segmentation and cutter delamination. See here, I'm just, so this, we try to remove most of this by the cutter itself, you can see here, and this is the post-op picture. And hypersonic vitrectomy, yes, it's good for history because it cuts 1.7 million cuts per minute. So this is, you can see the videos, but somehow it has not been successful. So, but it's definitely good to know because it might be asked what is hypersonic vitrectomy is 1 million cuts per minute, right? So coming to the next is we have the advanced visualization system. This is the bare eye surgeries. You can see here, then we move on to microscope, then we moved on to monitor base, and now we are with the heads-free visualization system. So I'll not go into the detail because it's already been discussed nicely, but definitely it's a fantastic teaching tool. See here my two trainees which are being trained. She's teaching SICS. So what are the advantages, best visualization? Every detail of the step can be explained and can be taught to many people at a time. Right? So what are the advantages here? You have personalized color profiles and the light temperature. And see here you can see it's like something like house automation you have in your houses, cool color, hot colors. So the different types of colors are now coming out. So this is, you can just adjust it whatever you want. You want a yellow color or the blue color, hot or the cool colors. See, these are different types of colors which you can use. Now coming to the next is the Sony HMS-MT. It's like an Iron Man. It's going to come out in future where you can see up and still do the surgery. It's everything which comes in front of your eyes like a screen. So that is what is being tried out. Robotic retinal surgery is also being tried out. The skilled retinal surgeons, because they have two types of tremors, that is horizontal tremor and the vertical tremor. If you didn't know, then find it out. So which tremor you have. So this is going to decrease one type of tremor. I also forgot. I'll come back to you later if I remember. But definitely it's good for ILM peeling is what they are predicting it, but still not into the market, but definitely good to know. So coming to the next is, last two is the gene therapy. In the gene therapy, what is used? It's adding an AAV vector, adeno-associated virus is used to insert the gene. So this is the most approved, what is that? Is Luxturna. That is Neparvovec Rizil. Okay, so what happens here? Basically in Leber's congenital amaurosis or retinitis pigmentosa fulvis punctatus, the RPE65 protein is lost because the gene is defective. So if the gene is defective, it does not produce the RPE65 protein. If there is no RPE65 protein, then the visual cycle will not get completed. So that is how they are having the blindness, because it's basically an outer retinal degeneration. So here the copy is taken, you can see here the copy of the gene is taken, it is injected into the subretinal area. So what happens? This gene, it is injected through the adeno associated virus vector that is injected into the cell. So once it goes into the cell, it gets expressed out, and then the RPE65 protein starts getting generated because it's replacing the gene, RPE65 gene. So that tries to develop RPE65 protein. So that is how probably it's going to. So here you see here what we call it as the multiluminance mobility test. So what is this? Here you can see this is the pre and the post Luxturna. The patient is able to move. They are making him move. In the left hand, if you can see, it is the pre-Luxturna and the post-Luxturna, where the patient is able to find out what are the objects, where to go, where is the path, where is the door. So this is the good results what we are obtaining through the Volti gene, that is the Luxturna. Now coming to the next is the FCVB, that is foldable capsular vitreous body. I'll just show the video. So what is it? Instead of using the silicone oil, which has its own complication, why not use a foldable capsular vitreous body? It's just like inserted in the intraocular lenses, you know. You make a small 3 mm,
expand the incision,
4 mm incision
and implant the triple
and then inject it.
FCVB.
So once you inject it, it gets unfolded in the vitreous cavity, and that tries to attach the retina. So what are the advantages? Absolutely no silicone oil complications at all, because it is in a folded capsule. So it doesn't come out at all. You just have to remove it and replace it. That's it. So that's the advantage of foldable capsular vitreous body, which probably are reaching into the final stages. Now coming to the next is the artificial retina. That's the only one unfortunately still approved, that is Argus 2. But definitely we are fortunate that there is something to the blind. Argus 2, Argus 3 is, again, why this question? What is bionic eye? What are the principles of its working, and enumerates its indication? It's been asked in the exams, right? So these all are very important. So what is bionic eye? Bionic is bioelectronic eye, which we call it as bionic eye, right? So here there are various, like retinal prosthesis is being tried, optic nerve prosthesis is being tried, cortical prosthesis are also being tried. So these are the various prostheses which are being tried clinically. So who are going to be benefited with that? Basically the patients with outer retinal degeneration. So if you place an implant over the retina, it's called as epiretinal implant. If you place it in the subretinal space, it is called as the subretinal implant. So whatever might be the staging, whether it is stage 1 or stage 5 complete blindness, unfortunately still there is no treatment. And what are the research therapeutic strategies? It is repairing the gene, slowing the disease, and finally bypassing the retina, right? So what are the indications? Severe to profound outer retinal degeneration. But please remember, these patients should have some light perception. If the waves are not get carried through the optic nerve, then this process is completely futile. So this is the external part, that is the video processing unit, and this is the, this both are the external part, the video processing unit and the Oakley glass, like how you have Polaroid, Ray-Ban, Polis. So this is the Oakley glass, for which a small miniature camera. This is the internal part of the, I'll show it in a video. So this is how you see the animated video here. The person or the model is wearing the Oakley glass, and it has a miniature camera. So once it's captured, it goes to the video processing unit in the pocket. It comes back to the telemetric coil, and then through the radio frequency waves it is transmitted. It's nothing like Bluetooth. It's transmitted inside into the eye, where these waves are going to hit these electrodes and try to generate the action potential. So how it's going to generate the action potential? Just in 30 seconds I'll tell you. What's the resting potential? Minus 70 millivolt, right? So how does it open? How does sodium and potassium gated channels open? Once they open up, sodium keeps going inside. Once it keeps going inside, what happens? It goes to plus 40. Last minute. It goes to plus 40. So once it comes down, so what happens here? It generates the action potential. So what we do here, after keeping the implant, we are trying to generate it by electricity. Once we try to stimulate it by electricity, it is forcibly asking these gated channels open up. Then the sodium will try going inside. Once the sodium goes inside, again the action potential develops. That is how an impulse is generated. You cannot artificially create an impulse. The impulse has to be generated for this to move on. So you are artificially making the system to create an impulse. That is what is the about these artificial retinas. So this is the quick surgery. I will show it to you. So this is a peritomy is done, and just regularly as we hook the muscles, so the muscles are being hooked, right? And then this is the telemetric coil, which is situated in the supratemporal quadrant. And me and my mentor, Dr. Robert Devaney, did this surgery. So here you see, we are taking a suture tab. We are trying to fix it in the supratemporal area. And this is the most important. You see the forceps? It is all silicon tipped forceps. So this is the 60 electron micro electrode tray, right? And then what we have to do here is to first to do a proper vitrectomy. If there is any epiretinal membrane has to be removed. I'm just fast forwarding that. And now you see, after making a 4 mm scleral wound, that just trying to insert it slowly. And all care has to be taken that it should not twist. If it twists, then there will be 4 engineers surrounding us who will be telling, sir, 5 degrees to the right, 2 degrees to the left, and all those things. And they keep checking it, because this surgery might take around 2 to 3 hours. And in between, if the circuit fails, and at the end everything is successful, if circuit is not working, everything gone. Again you have to repeat those 3 hours. So there are engineers who keep alerting you, telling that, okay, now you have to stop and we'll test it. See here, using a tack, that is nothing but a screw. We call it as tacks. 19 gauge tacks is used, and that is inserted inside, and slowly, now again the engineers help here as what has to be the angulation and what over the posterior pole, and how we fix it. We screw it. So it screws the retina, the choroid, and finally gets clicked into the sclera. So that is how this is being done. The tutoplast is used. So I'd like to thank the courtesy of the video, my mentor, Dr. Robert Devaney here, for giving me these videos. And then object detection, direction of motion, visual acuity. So what is the cutoff vision? 20 by 1000. So still we are far away from the reality. And what is the field of view? It's only 20 degree. Normal degree field of view, 180 degrees. So still again, as I said, it's not near, but definitely something is there. And MIT, Harvard device, holographic, retina, AG implant, these are all good to know. Nano retina. And finally, I would like to thank my colleague, Dr. Giriraj, for helping me in his presentation. Thank you very much for the patient listening. Thank you.
Thank you, Srinivas. That was
Thank you,
great. I think so. We have a view not only of the present, we also have the view of what the future has for us. And now I think we can proceed to the next